Bonjour et merci
Good morning. Thank you for being here for this second day of the European Cancer meetings. Thank you for those present here in this room, and also to those many numerous people who are following us live online. Yesterday we heard the various speakers of cancer care and cancer research with master classes and joint actions to be implemented at the EU scale. Today we'll have the feedback on the experts workshops that have been organized around 5 key topics in parallel to these master classes, and then in the afternoon we'll have the 2 roundtables for the next 18 months, what possible synergies with the national plans, and we'll start with this morning with the speakers of the opening session, and to start we have the pleasure and honor to welcome the Minister for Solidarities and Health, Olivier VÉRAN. Mrs. European Commissioner, dear Stella, who is with us in video conference, dear Lastimil, Minister for Health of Czech Republic, recently appointed, my colleague, welcome, be strong, and it will be okay. Mrs. MEP, dear Véronique TRILLET-LENOIR, so committed to fight against cancer at the French and European levels. I see a French an MP who is working a lot against cancer, Mireille Robert, dear Norbert, dear everyone. I'm very happy to open this second day of the European cancer meetings of INCA within the framework of the the French presidency of the EU. It's the World Day for the fight against cancer, and I would like to greet the millions of people affected, the healthcare professionals, the scientific community who fight every day against cancer. I would like to mention a breakthrough that happened yesterday. It's not a symbol, it's tangible and concrete. In a few days we'll have the 20 years of the law against the rights, for the rights of the patients. Yesterday the Parliament has voted the right to be forgotten for 5 years and removed the health questionnaire for a few real estate loans. So these are great progresses that were not granted, that have been obtained with a strong mobilization of the MPs. And it enables us to raise awareness on the societal challenges for patient survivors or cancer patients or cancer survivors. We owe this to the associations, ROSAP, Ligue contre le cancer, Séropot, the mobilization of which enabled to raise the awareness of politicians and the public opinion. We owe this to INCA and other scientific research institutions to produce robust data, and I would like to have a great thoughts for Agnès Buzyn, my predecessor, because treatments have changed the situation, because we have more scientific data, because the principle of solidarity must prevail. Things must move forward to the benefit of the patients. The French presidency has placed the fight against cancer as a top priority. It ensures the continuity Well, the French presidency has placed the fight against cancer as a top priority. It ensures the continuity with the German, Portuguese and Slovene presidencies. It was an obvious decision for France that has a chance of launching its new 10-year strategy against cancer last year after the launch of the European plan, and this was made directly by the French president, who is committed to this cause. The management of the health crisis of COVID-19 must not make us forget that the fight against against cancer remains a priority shared by all the member states of the Union. Behind the figures of the number of victims of cancer within the EU that are cold, impersonal, we're talking about lives, deaths that we could avoid, families that can rebuild themselves. Hope for a lot of patients. This is why, despite the difficulty of time, despite this pandemic that has postponed so many care, especially for cancer patients, the EU is united under the banner of its action plan announced last year by the Commissioner, whom I would like to congratulate for this commitment. Dear Stella, I hope you heard the beginning of my speech. We must reinforce the cooperation in Europe and internationally. The EU must play a role in many important and complementary levers of the member states. The EU of health must enable the Union countries to react jointly to a health crisis and to cooperate to improve prevention, treatment, and the follow-up of diseases like cancer, and also to have innovative medical supplies at accessible prices. The EU for Health will contribute to better protect the health of citizens, give the EU and its MS means to better prevent and fight against possible future pandemics, and of course we hope there won't be any, improve the resilience of European health systems. Cooperation between key EU and the international stakeholders in the fight against cancer opens opportunities that are great for progress, for research, prevention, testing, and early diagnosis, and also access to quality services and innovative treatments. France wants to contribute to the acceleration of progress at the EU and global scale. That's why we wanted with the Czech Republic and Sweden and the EU Commission, the European Commission, to call all the European stakeholders, public and private, to intensify their cooperation efforts to make our fight against cancer move forward. This declaration reaffirms the priority of fight against cancer. It calls for the implementation of concrete actions everywhere where the cancer plan of the Union can be demultiplied by the intensification of cooperation between member states. 5 key topics had been proposed by the INCA in consultation with all our European partners: prevention of cancers of poor prognosis, pediatric cancer, employment during and after disease, and international cooperation. 5 major topics where the European action can have a real added value and a true impact. We must be more effective on prevention. While 40% of cancers are created by preventable risk factors, mainly smoking, but also alcohol consumption, poor diet, lack of physical activity, pollution, of the environment, dangerous substances, and cancers related to infectious agents. We must implement major actions with a high impact, especially against smoking, which is our main enemy. We must accelerate progress to enable to significantly increase the survival of cancer patients with poor prognosis, with disruptive programs, the implementation of European clinical trials that will enable Europe to finance innovative research and identify new therapies. Pediatric cancer, one of the priorities of the European Cancer Plan. It's one of the first causes of deaths per disease of children in the EU. Europe has a true added value with the implementation of EU clinical trials for pediatric cancers to pool our efforts to progress faster for new therapies with less after effects and a better quality of life. The review of the regulation on pediatric drugs and orphan drugs will be a crucial step. There's also the question of maintaining professional activity during the treatment and after, when it's possible and desired by the employee, that contributes to the improvement of the quality of life of cancer patients. It's an essential right for every person affected by cancer to have an environment that is adapted to their state of health, and to continue working and having projects by guaranteeing access to loans. The Mission Cancer and the French plan have increased our plan of action. This can inspire other issues in the fight against rare diseases. I'm convinced that the European Union can play a leading role in the global scene, thanks to all the stakeholders in the fight against cancer and numerous initiatives that are implemented through the European plan and the Cancer Mission. So we propose to implement a system of coordination of the fight against cancer, where EU will play a key role. the cancer has changed the situation. The discovery of vaccines, which has not been exclusively European, although we sometimes forget to say that BioNTech was a German company, or our capability to coordinate in the emergency situation with a certain number of member states and the Commission to make Europe the first purchaser and producer of exporter of vaccines, that showed the great necessity to coordinate more in the field of health policies. We have also created a need in the citizens who didn't believe in the European health. And the Europeans said before, health is a national prerogative. But we share the same money, and we had a difference in life expectancy of 10 years, a level of 1 to 4 in child life expectancy. And so we are proud of each of our health system. Each state is proud. But in terms of universal coverage and care for pathologies, we can move forward to more towards harmonization. And it's not the objective of the French presidency of the EU, the FP EU. So it's just to say that our research capabilities would be higher if we look at what neighbors are doing in terms of pediatric cancer. We don't have to all have national programs on certain pathologies when we can pool our skills and means. Yesterday, on the occasion of the FP-EU, we had an agreement on the ethical use of health data in Europe. Pooling health data to identify risk factors we don't know yet. This is an essential step to be able to develop research programs and follow great cohorts of European citizens to implement adapted prevention policies. And something I haven't said in my speech regarding prevention, there's of course fight against smoking, alcohol. There's a strong thing to do, a strong emphasis to put on the environmental health and factors. But there are indeed great risks that some environmental factors around us contribute to the propagation of cancers. And also, we have beautiful prospects. Let's talk about COVID, the NRI messenger vaccines are key to prevent cancers. If we're able to say to cell, you must produce this or that molecule, and it is capable of producing antibodies that are adapted to the various viruses that can affect you and provoke cancers, why can't we dream that in the next 5 to 10 years we can eradicate a certain number of infectious pathologies that are the cause of numerous cancers, like papillomavirus, which is a fight I'm fighting, and we must have at the French and European scale. We can't satisfy of having HPV vaccines when we can have so many preventable cancers that can be preventable. So there's a high sensitivity when we talk about vaccines right now. First, we had the obligatory vaccination for children, now vaccination against COVID, and we must work, rework, and regain ground to convince the population that science is a chance and not a handicap, that vaccine is a great opportunity, an invention that is magnificent, that aims to cure and prevent diseases and not a constraint related to an injection for which you should hide yourself. We shouldn't be ashamed of seeing science that progresses, but we have to look at what science can do for a patient or in a pharma company. So I say this because I'm a minister in charge of health. How after a health crisis that will have been on the public agenda for 2 years, how can we go and see the French and European citizens to talk about health? So the health topics, people are fed of that, and we can understand that. But it's tomorrow that we'll have to talk about well-being, about public health. It's tomorrow that we'll have to enable French people to go back to fitness rooms or to do sports and jogging. And when we see that French people would have gained 5 kilograms on average during the pandemic with the consequences for health, it's now we have to tell our citizens that they it's urgent to stop smoking, to start exercising, to work on well-being. So we have to find a way forward. I'm convinced that moralizing discourse doesn't work. It was poor before, and it will even be less effective. So the message, abuse of alcohol is detrimental for the health, is not integrated anymore. We're used to that. Moralizing discourse telling as teenager you shouldn't smoke because it can kill. It's no longer effective. We have to reinvent our public health policies. We have to really use social media, use self-assessment methods, implement incentives and indicators for youth to incite them to have a health public policy that will be adapted to them. That's how we'll be able to fight against cancer. That's part of the 10-year cancer strategy and the cancer plan. And we'll need you in the weeks and months to come to be able to talk about health to our citizens without making them sick, because it's up to our future and the future of everyone, and that's why we're here today. Thank you very much. Thank you very much, Olivier Véran, for this introduction. We will continue in Brussels, but before that, we'll take a few minutes to watch a video that was produced for this day for February with the community entities. It's the video for the World Day, and we'll come back. At first it was hell. I didn't think I was going to make it. I had little hope, but fortunately I was not alone. I was surrounded by the right people. They helped me, encouraged me, supported me throughout my journey. That's why I'm here today. Tariq Mukrin, cancer survivor. You can't face cancer alone, and the sooner you detect it, the more chances you have to defeat it. United for Europe's Beating Cancer Plan. So, European mobilization, echoing what we have seen, what we have heard this morning and what we've been hearing since yesterday. And through the speech of the EU Commissioner for Health and Food Safety, who is online with us, Stella, KYRIAKIDES, are you with us? Can you hear us?
Yes, I can hear you. Can you hear me?
Yeah, we can hear you completely perfectly. I leave you the mic and the word for your speech. Thanks a lot to be with us.
So thank you very much. Good morning, ladies and gentlemen, dear friends. I'm really delighted to join you today on World Cancer Day, which is an important day in our calendars every year. And I want to begin by thanking the French presidency, Minister VÉRAN, dear Olivier, and the French National Cancer Institute for gathering everyone today and for continuing to shine a spotlight on cancer. I also want to take the opportunity to thank Madame TRILLET-LENOIR, a member of the European Parliament, dear Véronique, for your important engagement and our close collaboration on this topic. If the EU truly wants to tackle cancer and to improve research, treatment and care, especially to reduce cancer inequalities and deliver concrete lasting benefits to its citizens, then Europe, as Minister VÉRAN has already said, needs to work together. And we need to have cancer as a top health priority across the board. We know we are much stronger as one. When medical professionals, when patient advocates and policymakers coordinate, share experience and expertise, and cooperate towards common goals. And today's event is really a very powerful illustration of that cooperation in action. And I want to thank all those participating for their commitment. More than anything, World Cancer Day is about those whose lives have been touched by cancer, for patients, for survivors, for their families and their friends. And every year, 2.6 million people are diagnosed with cancer, and 1.2 million lives are lost in the European Union. And unfortunately, These numbers are set to grow unless we all together reverse this trend. And these numbers are not just statistics. They are personal stories for all of us. These past 2 years living with COVID-19 have added new challenges for patients and for healthcare professionals. We know that the pandemic has disrupted and delayed screenings and treatments and reduced access to medicines and follow-up care. But it has also highlighted the tendency that we have seen to underfinance and underprioritize our healthcare systems. Exactly 1 year ago to this day, we launched Europe's Beating Cancer Plan to address these very problems. We put today's patients and survivors at its center, and of course, tomorrow's too. And Europe's plan on cancer aims to strip away the worry that comes with a cancer diagnosis and replace it with hope, with support, and with access to effective treatment and care, so that diagnosis is supported with better research, with better preventing strategies, and better health and greater health equality. But, of course, Brussels cannot do this alone, and this is why we need the full cooperation and strong commitment of all key stakeholders. For us, as a European Commission, it is a priority. But EU member states play a fundamental leading role in this process, and I am really delighted that the trio presidency of the EU aims to keep cancer high on the political agenda for the next 18 months, because this sends a clear signal to citizens that their health is our priority and gives us an opportunity to make great progress. Ladies and gentlemen, dear friends, Europe's Beating Cancer Plan is, of course, an ambitious strategy, but it is grounded in concrete, realistic steps and actions. And I believe that we have put the key building blocks in place for this success. By cooperating with all stakeholders in all policy areas, we are addressing challenges posed by cancer in a holistic manner. Because cancer can not only be the responsibility of the health sector alone, we need the whole of the society to be involved in this work. The plan's 4 pillars cover the entire disease pathway with very ambitious flagships and actions. And all of the stages of the journey of a patient are equally important. We look at research and innovation, personalized medicine, and reducing inequalities are cross-cutting themes. And we are looking at a modern, a forward-looking, and an inclusive plan. We have put an implementation plan in place. This is important because it has timelines and milestones. We need to know where we're going and what we are doing when, because we intend to stay on track. And crucially, we have committed a substantial 4 billion euro in financial support to deliver on our promises. Last year, we launched 16 major initiatives. This year, we will see more actions financed to see a strong emphasis on prevention and diagnosis. With the Cancer Plan and the Horizon Europe Cancer Mission, the Commission has 2 major initiatives in place that will influence policy, research, and funding on cancer prevention and care in the years ahead. Let me just share some of the major milestones to date, because we need to be concrete. In the past 12 months, we launched the Knowledge Center on Cancer, the Healthy Lifestyles for All initiative, and the Samir Action Plan, which ensures that radiological and nuclear technologies continue to benefit the health of EU citizens. We also launched the European Commission initiative on colorectal cancer to develop guidelines and quality assurance schemes for colorectal cancer screening and treatment. And we have started to look at the work to revise the Council recommendation on cancer screening and to update the European Code Against Cancer. We are supporting the establishment of comprehensive cancer centers in all member states and the creation of an EU networking between them to facilitate patients, families, and professionals. 2 days ago, at an event I hosted and where Minister VÉRAN and Véronique TRILLET-LENOIR also participated, as many others here. I hosted an event to shine a light on cancer in women. And there we launched 4 more actions: the joint action on HPV vaccination, the first phase of the Cancer Inequalities Registry, a call for evidence concerning the Commission proposal for a revision of the Council recommendation on cancer screening, and launching an EU network of youth cancer survivors to strengthen the long-term follow-up care and connect those young people with the experience of cancer and their families, as well as informal and formal carers. And I am determined that we are going to continue to make rapid progress to turn these into our common achievements. So supporting events like today's provide the energy and the expertise to help us carry forward and to keep us on the right track. And the 5 key issues today on today's agendas that Minister VÉRAN has also presented are really central and key issues of the cancer plan. Childhood cancer is highlighted as a particular priority and is of course very close to all our hearts. The advance on cancers with a poor diagnosis and the need to use the potential offered by research and innovation and digitalization. Cancer prevention, which is a key pillar with healthy lifestyles, HPV vaccination, raising awareness, and addressing cancer and employment. And I wanted to share with you that we will soon launch a report on fair access to financial services, the so-called right to be forgotten, an area where France in particular has experience and that we want to learn from. And of course, international cooperation, exchanging with WHO and OECD are crucial in the fight against cancer. So, dear friends, I'm here today to share with you many of these issues and to just remind all of us that this is a living, breathing plan. This is Europe's plan, and your insight and your perspectives, your commitment, fuel its guide and its implementation and ensure its success, because we have a unique opportunity to make a difference. So let me once again thank the Minister, dear Olivier, the French presidency for their ongoing support in this field, and to say how much I welcome the political declaration to be adopted in this event, because it illustrates the trio's presidency's commitment. And a final word of thanks to the patient advocates, the researchers and the policymakers, the health professionals who are helping us turn this plan into concrete, tangible benefits for all citizens. Together, we can build more equal societies and healthier societies. Together, we are stronger and we're more effective. Thank you.
Et nous allons clore cette séquence d'ouverture avec en accueillant celle qui est venue déjà hier porter le plaidoyer, les convictions, les propositions du Parlement européen sur ce sujet-là. Elle est rapporteure de la Commission spéciale du Parlement européen
on the Beating Cancer Plan. We now have Véronique TRILLET-LENOIR. A round of applause.
Merci beaucoup.
Thank you very much.
Monsieur le ministre des Solidarités,
dear Minister of Solidarities and Health, dear Olivier Véran, dear Czech Minister of Health, dear colleague, Dr. Valek,
Madame la Commissaire à la
dear
Santé
Commissioner for the Health of the European Commission, dear friends, ladies and gentlemen. Not long ago, we were together, dear Stella, to launch the public consultations on the research for cancer. The European Commission presented the Beating Cancer Plan not long ago. On the 15th of February, the European Parliament will actually make a decision on my report in plenary session. Tomorrow, dear Minister, the Member States
will implement this strategy and objectives together. On behalf of the three institutions, we have to bring an answer, an ambitious answer, on behalf of all the European citizens that are affected in different ways by this disease. To have progress for families, but also for caregivers. There are 6,000 children who are affected. There are 4 million patients who require today, now, some efficient and innovative treatments. We have to satisfy the expectations of the 2 million survivors. You've seen an example, that have to face the back to life and the difficult return to employment. We have to think about the future. They have to be informed, protected, especially bearing in mind the environmental circumstances. We have to answer the concerns of the governments that have to face a growing economic burden of the treatment and late effects of these diseases. This concerns all of us. No one is saved. But we are poorly armed against this disease. It is a disease of social injustice. We are facing a survival rate difference that is huge from one country to another, that exceeds 25%. It is intolerable. We are unequal in terms of prevention, because we are not and we are not on the same footing when it comes to cancerogen agents. When it comes to information from one country to another, we are not on the same footing as to fast access to innovative treatment or standard and high-quality treatment. We are also not on the same footing when it comes to finding a job again, to be financially independent. It is our common duty to launch a reduction of inequalities within the European Union, but also beyond, especially in low-income countries, where, for instance, the African continent. And this has been the soul of my parliamentary work. With this report, we set out and outline a beating cancer plan. There are 4 fields of action: prevention, screening, equitable access to treatment, prevention. That's prevention that falls under the aegis of the European remit. This should allow us to avoid having 40% of cancers, 4 out of 10. Prevention actually allows to act upon behavior, social elements, environmental elements. We have seen, working with scientists, dear Elisabeth, we have worked on this, and for each element we have considered legislation or recommendations. Prevention of cancer, ladies and gentlemen, is the subject matter of a lot of pressure of influence. May it come from industrialists, from corporations, or conspiracy theorists. It is the honor of politicians to make sure that we remain vigilant and to keep working on research and implement this strategy. The European standards, and Minister VÉRAN has actually called upon this to the MEPs. It should not be put in the back burner. It is important to make sure that we have that the financial debates do not entail health in the back burner. Whatever happens, we have to defend our ambitious objectives. We need to have a tobacco-free society, a reduction of 10% of alcohol consumption in terms of abuse of alcohol by 2025. We need to have food-related information that is legible with the right labeling. It is the absolute right of European consumers. We need to deploy HPV vaccination and also to break down and destroy cancers brought by this virus, in particular when it comes to cervical cancers. The coverage rates go from 30 to 70% from one country of the EU to another. And with the European Green Pact, this will be all about the fight against environmental carcinogens, in particular on the occupational premises. We will develop education of help for young generations on secondary prevention, screening. We have participation rates that actually vary from 25 to 80% according from one country to another. We support the objective that is proposed by the European Commission and to have a solicitation of 90% of the citizens that are concerned by the breast cancer screenings, but also colorectal and cervical cancers. As for cancer medicine, we need to have a public health union that is united and coordinated. This is urgent. The EMA delivers a common authorization on the European market, but also assessments on the risks and benefits, and negotiations with the health industry are being done in a non-concerted way with the 27 countries. That actually favors inequality of access and also illicit trade. We have the opportunity to set milestones for a virtuous circle that will allow us to have equitable access to available medicine that would be affordable for us. We should have joint procurement procedures. We should fight together against the risks of lack of access to medicine that is generated by our dependence, that is tragic, and that depends upon India and China for basic active substances. We need to restore our sovereignty on innovation when we compete against the United States. We'll have to convince the governments of the member states on the basis of the example of the success that we've had for the purchase of vaccines, and we need to be efficient when negotiating, all of us, the 27 of us, as compared to unbalanced bilateral agreements. We need to improve innovation, and this will be the venue of privileged success. We need to have public-private partnerships. We need to have a strong Europe in terms of help to fight against cancers, but also for orphan diseases, in favor of children, of teenagers, young adults, any kind of rare cancers. We are calling upon the delivery and easier access to medicine when it comes to treating rare and childhood cancers. I would like to talk about a concern that is recurring and that is very legitimate. What we will manage to do for cancer medicine, we will manage to do it also for chronic and rare diseases. This is what experience has shown. Equitable access of medicine, but also support throughout the patient pathway, are all about a common engagement and commitment of everyone in the member states. We want to have conventions on high-quality criteria that should be shared for screening, for labeling of healthcare centers, for training high-quality medical centers, and to deploy also digital centers. We want to identify in each member state a reference center, at least, and a comprehensive cancer center. Also, the cancer patients had to pay a huge burden against the backdrop of COVID. This needs to change. We need to think about also the relatives of the patients. We need to express recommendations, which we will do, to increase the quality of life, to find the right dosage, and to also enhance reinsertion, reinclusion, and support fertility, and take into account mental health and functional and aesthetic late effects that might happen. We recommend to implement the right to be forgotten as well. And we need also patients not to have a double penalty with this. So we will only manage this if we work together with patients' associations. These are actually eye-openers. They are the ones to show the way, and I really would like to pay tribute to them, because we know we can actually rely upon you. What are the means of action? Research, obviously. That's the main thing, but also there's the complexity of disease that justifies to work all together at European level with the Europe Horizon Cancer Mission. We have to mobilize also artificial intelligence technologies, but also develop infobiology. We need to have also European multicentric inducing measures. We need to touch upon vulnerable populations. We need also to work on environmental health. And we want patients' associations to help us and to collaborate in clinical projects. Secondly, we need to share expertise. We need to work in networks on expertise, on rare cancers, those that are complex. We have to share data coming from cancer registries. We offer to roll them out and to have at least one per European region, but also to give a lot of life and to understand the health determinants, to have a better customized medicine. Then we have to work with the scientist societies to have a training program. Budget is 4 billion euros, and it should come from all the budgets of the European Commission, not only the health program, dear Mr. Ryan. I would like to wrap up by saying another means of action that should be also determinant, namely the networking of the 27 national plans aiming at beating cancer. One single plan shouldn't be the adding up of 27 plans. We need to have a virtual European cancer beating institute that coordinates all the national programs in terms of screening, of reference, of registries. We need to have a cooperation on exchange of data, to have common recommendations, to have also exchanges of good practices, specific missions, but also the hosting of a register of inequalities, as you said, dear Stella, that is highly actually supported by the European Commission. We need also to schedule in the right way altogether screening campaigns and to do communication with the public, the large public. We also need to call upon everyone for all these recommendations that are non-binding, that should actually be incumbent upon the member states and their responsibility, their willingness. We want them to be the subject matter of a European Charter of the rights of patients that are affected by cancer. And we want the signature by all the governments that constitute the European Council. I would like to draw the attention of the representatives of all the presidencies of this tripod, France, the Czech Republic and Sweden, for them to make sure that the engagement towards all the European citizens be visible and credible. We need to make sure that we have solidarity in this effort. Thank you. Thank you. And before talking about the rest, since most of what we said, the gist is actually the workshops we had with all the experts who gathered yesterday to have a political declaration on 5 topics. The declaration has come. It's freshly printed, and we are lucky to have the president of INCA before us that will actually deliver this political declaration to Mr. VÉRAN. Dear Minister, thank you for being with us. I would like to give you this political declaration and also the list of actions that are recommended by the panel of people that represent the stakeholders. Thank you for your attendance. Thank you, dear Norbert. Thank you, Thierry BRETON, as well, for this document that we will certainly read, because we're looking for the future now. We're preparing the future, so it's actually right on time. Thank you. I will now talk about the next sequence, namely the feedback on the proposals that are actually in this document. The document is in my hand. You can actually retrieve it when you exit the premises. I will urge you to do so, because that's actually the summary of everything that we will tell you, but also this shows also the rich content of everything that has been discussed with all the experts to show the approach, but also the mindset and the soul of this. I would like to welcome Thierry BRETON, the Director General. Thank you very much. Director General of the French National Cancer Institute. Ladies and gentlemen, a few words before you have actually a summary of all the works we've done, but actually during all the weeks before now, not only yesterday. We have to explain to you how we designed all this work. This is a little bit the footprint of INCA. We want to develop and have a vision that is integrated, that is global, that is consistent, that takes into account primary but also secondary prevention, the recommendations for good practices, communication, information, legibility of medicine, but also the funding of research that are important points. Why are we developing this vision? Why is it a source of inspiration? Because we know that if we want, and we hope, and if we want to have concrete results, we have to address all these questions simultaneously. These meetings, these workshops, we have thought them out with a vision because we thought about the population, we thought about the patient's needs. We know that those of us that are affected by the disease have to go through a difficult period of time. We have the question of care, that's the first issue, but it's not the only one. We also know that cancer diagnosis also has an important impact, a financial, a psychological, but also social impact. It actually disrupts family life. And if we want to help these people, to help their family, we have to make sure that all these needs are being addressed, because recovery is not only a matter of care. It's also a social, economic, psychological matter. And with this integrated vision, this is what we wanted to implement by having discussions during these meetings. I will certainly speak about it in a way that is not the same as our MEP and Minister of Health, but What I would like to say is that there's an added value with the commitment of the European institutions that has already been the case. We've seen it with the commitment on the different topics to which we have to face. Actually, all these issues exceed the national borders. We can't remain on our own in silos, because then we would not have the right weapons to fight cancer. As the Minister has said, Europe has been the venue of solidarity, but also efficiency in vaccine management, and we can see the strengths of the European Union to tackle these subjects hand in hand, all together. We already have the tools that are well structured, the European plan, the Beating Cancer Plan, and also the Fight Against Cancer, the 10-year strategy plan. This is why we have organized these meetings. And in the wake of the 10-year strategy that France has launched in February 2021, we wanted to see what it was possible to do to make it richer, to develop synergies, to have a more concerted approach, to see if we could coordinate ourselves better, pool our resources, enhance our tools, and fight against inequality. And from this stepping stone, we have been working on these themes that are priorities. There was one masterclass yesterday that showed it. We could talk about share of data as a priority issue. We decided not to do it because sharing data, well, actually data are not an end per se. It's a means to an end. We want to improve the health of European patients. This is what we want to do. Data sharing will be found anyway in all the topics, and we will talk about it certainly when we have the feedback from all the different commissions. So 5 issues have been identified. Childhood cancer is one of them. They're not numerous, we know that, but we understand how much this is painful for the families. It is complex. It actually raises a lot of problems because there are not a lot of cases, be it in France or elsewhere. Clinical research organization is thus harder to implement. This is harder to find innovative medicine. It is harder to make medical research. Another topic that we wanted to take is poor prognosis cancer, namely survival rates by 5 years are under 33%. They do not have the same progression as for the other cancers. They are complex to treat. We can mention lung cancer, some breast cancer as well, some TBNC, childhood cancers, for instance. They are complex cancers, and we need to think about research on these issues at the European level. Also prevention. The main margin for progress, if I may say, it's there. We know what the main risk factors are: tobacco, alcohol abuse, lack of physical activity, for instance, and the type of food we take. So we can work on these, and if we work on these, we know that the objective that we all pursue, namely to reduce cancers, this has to go through an important effort in terms of prevention, On this point of view, may it be at the national level or European level, the commitment of the Commission on the fight against tobacco, which is the main enemy in terms of public health. This is a strong signal. We need to go further in this fight regarding also consumption of alcohol in an abusive way is also one. But there's also pollution, because pollution also has consequences. We have a scientific answer to organize, to bring to our patients, to our citizens. The task upon us is daunting, and this is why we should work at the European level to help each other. Fourth subject. This is an illustration of this vision, and this shows why we want to work together for the benefit of patients. It's actually the right to be forgotten and the support to help patients go back to the employment. It's now 5 years for the period of time upon which they have the right to be forgotten. These elements are very important. They allow everyone before, of course, without going back to before, because there will never be a return to life as it was before. So the right to be forgotten is important. And employment are important themes. We need to have tools, we need to have regulatory provisions to help us on that. This economic dimension, this capacity to make personal projects once again are important. We have to work on this. Also, on patient recovery. And a fifth issue, that's the international cooperation. Already with the European meetings, we have that. When we work with the European Union, this is what we do. But beyond this, it is also possible to think about the role that the EU could play on globally. As for vaccines, we've seen it. The EU has been an area of solidarity that was incredible. There was a lot of commitments towards solidarity at the international level, because vaccines were actually distributed to low-income countries. And so there's something to do when it comes to the EU's role globally in the fight against cancer. We think and we have in mind the fight against AIDS, HIV. We've seen the efficiency in terms of international cooperation. And we think that international competition should be synonymous of synergy, should be a driver, but should not actually entail rivalry. And it is important to get closer, to gather ourselves around these issues that are important and also complex. So these are the 5 issues. There are hundreds of experts who gathered and worked on this, who accepted to work on this in 3 meetings during several weeks. I would like to thank them, because they've actually done that in addition to their usual work. And what we said is that we gathered them and we said, we have important tools. What more could we do to reinforce this momentum, to have better tools, to have a better coordination? What are your proposals? And this gave rise to the proposals we have here, and we will hand them over today. There are 32 proposals. We did not think that there would be so many of them, and I want to thank them. I am grateful to all those that will actually talk about it and talk about their findings today. I would like to seize this opportunity also to thank the colleagues from the International Institute of Cancer, They've done a huge coordination work. This actually takes the shape of what you've seen in the hands of the minister. We'll have a political declaration as well. You will be able to read it, and this has been signed by the representatives of the Czech Republic, of France, but also Sweden, in the European Cancer Beating Plan. And they will show also the most important proposals and recommendations. The European Commission will also issue a press release, if I'm not mistaken, to reaffirm this commitment that is a common objective, a common commitment. And appended to this document, we'll have the proposals. We'll have to know what we are going to do with it as well. A political declaration highlights the importance of what we do, of how much we care. The work that is being done is under the aegis of the French presidencies, embodied by the INCA, but that's not the ownership of the French presidency. That's not also the ownership of INCA. It's a common ownership. We have to all take ownership of this and to implement all these actions. It's very important for us, and these proposals are a stepping stone. We have to work in consultation with the experts to have a better roadmap, to go even more further, to fine-tune some of the proposals. And this is what we'll do under the aegis of the French presidency, but also with our colleagues from the European Commission and with our colleagues from the Czech Republic and Sweden. This is what we'll do in the months to come. We'll try to fine-tune this roadmap. And then one point on which I would like to insist before wrapping up, or as a wrap-up, what we strive to do was to launch a momentum that should be as large as possible. And if there's one thing to keep in mind, a back-to-home message, let's say, is that we should replicate it. We should see each other again, see the progress that we've made regarding these proposals, talk about the difficulties we encounter. And another idea that has also inspired this moment, and this is why we've designed it in such format, it is important for all of us to be mobilized, to be involved. Of course, rallying everyone around this, from rallying the member states, the parliament, the associations, the experts, but also the corporations, the health industries, banks, insurance companies. It's important to rally everyone around these issues. And thanks to that, actually it's a condition precedent to the success of our endeavors. If we want to beat cancer in Europe tomorrow, if we want to give progress and hope to European citizens tomorrow. Thank you.
We will now move to the feedback session of these 5 workshops on these 5 topics that have been presented. You'll be able to collect the document with all the feedback. It is important. It's a comprehensive document regarding the proposals, that what we can say verbally. It has also been approved by the members of the various commissions. For our connected friends, it is important to say that this document will be placed online as of midday on the website of these European Cancer meetings, so you can download it online. And also for these 5 workshops, we'll highlight the 3 key measures that will be supported by a spokesperson that has been appointed in each group, who will explain with me how these measures have been made and what ambition they want to support at the European level. We'll start with this first topic, of poor prognosis cancers. It's 30% of incidence for men, 20% for women, with major challenges to reduce the time to diagnose, make research move forwards, have more effective treatments. There are a lot of international networks that have been created on these poor prognosis cancers. So how can we give political support to make more efforts? So the spokesperson for this group, Josep Maria Borras, the director of Catalonia's cancer strategy from the Barcelona University.
Hello, thanks to be with us, Josep. We will start maybe, before presenting the statement, with a little introduction. And the first point, which is not that, which is really necessary, is trying to view exactly what is the scope of poor prognostic cancer, as you may have defined it in the group, because there might be a lot of definitions.
Well, thank you. First of all, I would like to thank the French presidency and the INCA for inviting me and for this initiative to organize this meeting that it's very relevant and very important. So, poor prognosis cancers could be defined in several ways, but I think all of us agreed on the definition of one-third lower on the definition, focusing on survival in less than 33%, 5-year survival. So all the cancers that fulfill this condition, I think, could be defined as a poor prognosis. I must say that it's the same definition, a similar definition than we use in the IPAC with neglected cancers, that maybe it's a word that give focus to the lack of recognition of these cancers. And I must say that it's, considering this definition, 1 out of 4 cancers in Europe, diagnosed cancers in Europe, are included in this group. So it's a large amount.
Still a main issue. It was a group, as much as I could hear, where there were a lot of accurate and intense discussion, very precise discussion. Yet it was maybe the group where they had this, I don't know how to say, a certain sense of feeling of fatalism, like, let's try, let's go. It won't work. We won't have the support. We won't go to the end of it. Do you agree on that? How can you explain it? And what are for you the main challenge to come on this poor prognosis cancer issue?
Well, I think any cancer poses a challenge to any clinician and the patient and the family and the health system, but poor prognosis cancers pose specific challenges due to the lack of survival, and that could also provoke this kind of fatalism around these cancers. But the group, I think, agrees on the fact that we can do something, and we can act now, trying to apply what we know that could be effective, and to expand in the health systems in order to offer the best we can offer to our patients, and obviously support research to change. But I think the message is we can do something now.
Yeah, that's the motto out of the assessment is yes, it's difficult, but yes, we can do something for real. With the 3 different statements, and we're going to discover them. The first of them, is this the first? Yeah, yes, this is the first one. You can read it. I'm not going to read the whole of it, actually. Make research the priority to radically switch approaches to poor prognostic cancer. Call this high-risk, high-gain proposal at European level. This high-risk, high-gain program, if I can say, is here to boost research against this cancer. What exactly do you call high-risk, high-gain? The name is really nice, but what's behind the name? And how could it be a game changer, or at least a game booster on research on this poor prognostic cancer?
Well, I must say that there was a significant discussion about the concept of risk, because it could be easily misunderstood in terms of patients, from the patient's perspective. I think that the meaning, it's clear that we need disruptive approaches to to this kind of research. So we need to support innovative projects in this area. So the situation so far and the research so far...
What is called innovative project? Because, I mean, every research project is innovative by itself.
Well, in some cases, I must say that several research projects try just to confirm what we know or to expand slightly. But I think we need projects that could change the game and offers new approaches to different perspectives to treatment, to basic science, to epidemiology, to the risk factors definition and things like that. So I think we need to support really original ideas to offer different perspectives that could be different from what we know and the classical approaches to this research. I think the focus is in innovation, but innovation changing the game and the field in order to see if we can offer better solutions.
Does it mean, because it's having like new blue sky research thing, it's a bit of this actually, is something interesting, but I mean there's a call for research programs, and in the calls there's criteria, and the criteria says need to have this proof of concept, and if you don't have it, just it's not for, the room is not for you. Does it mean that you have to change the selection of the project, the vision, the definition of proof of concept as the entrance path for getting the support on the programs?
Well, yeah, I think probably the definition of the calls should slightly change. I think also we should make clear that we prioritize this kind of projects, focus on these poor prognosis cancers, which is, I think, something controversial, but for us it's important to really highlight the relevance of focusing research on these cancers, because if not, due to the fatalism, due to the fact that these cancers seems without any kind of, let's say, practical solution, even researchers are not interested in applying for this kind of cancer. So I think we should make clear that we give importance and relevance to do research in this area from, let's say, innovative perspective.
Yeah. It's not a switch, it's a complementary approach from the traditional approach, yeah. Actually. Let's go to the second statement, and the second statement is about I would say the data sharing, if I'm correct. It's important. It's important to provide a framework and tools to enable the engagement of health professionals and researchers to share the data in advance of project. We talked about this yesterday, in order to better understand barriers and benefits from each other's progresses. This is very important, but why is it so important on this field of cancer, and how, I would say, not to make it just a declaration of intent, one more on data sharing, because we said yesterday everyone wants to share, but at the end no one is really able to share, because there's always so much problems when it comes to really go to sharing.
Yeah, well, this is one of the things. Certainly, we discussed yesterday 2 ways of sharing data. I think we need to share data because we need to monitor data about outcomes and the process of care, and to learn from each other. So I think this is, but this needs frameworks to make the definition of the variables standard, and to structure the data in order to be able to share this data. Because I think one of our main goals is precisely to develop what we can call a learning healthcare system. So a system that learns from the experience of the day-to-day work with patients. This is one of the ways that we can do, and I think this is particularly important in this kind of tumors, because there are good experiences across Europe that should be shared, and should be shared with data, not only with the concept, with the idea, I think with real data that could monitorize and assess the good outcomes. And I think also, and it was I think one of the points yesterday, we should share data as early as possible in the beginning of the project, not just to wait at the end.
So meaning as a condition for support,
yeah, and
in the program?
early in the implementation of the project. Yeah. I think because it's also relevant to learn about the barriers and to learn about the difficulties based at that usually comes out at the beginning of the project.
It means that the data of one research could be freely used by other researchers.
Yeah, I think data should be shared should be shared openly, obviously following the privacy regulations and all the regulations, but I think there are ways to share, and we have developed fair programs and fair approaches to share this data, and we should support, especially in this area of poor prognosis cancer. Yeah.
It can be, even though a kind of a pioneer field to create this disposal of sharing of data. Next statement, the third one, is more focused on the model of care of this poor prognosis cancer in order to improve the diagnostic, the access to treatment, the quality of life of the patients with it, ensure the best available care is provided by increasing quality and speed of delivery for patient as an individual and for patient population as a whole. It's a large scope, actually. can have a lot of things inside of this. Could be early detection, could be treatment, could be quality of life, and should be the whole of it, actually. What is the main issue the group wanted to address on these different aspects in this statement?
I think it's important to realize that we need to focus on two levels of care. So one is with the individual patient and the individual clinician, and here from this perspective, I think multidisciplinary care, development of expertise, concentrate expertise, and offer early access to this expertise for offer the best treatment that we can offer. I think, but this also has a strong implication in the organization of health services and in the healthcare policy. I mean, when we are talking about, for instance, developing highly expert groups, multidisciplinary teams in referral centers, we are talking about health policy. And I think it's important because this is also aligned with Europe's Beating Cancer Plan and many of the cancer plans in Europe, that they are talking about offering comprehensive cancer care to the patients in comprehensive cancer centers. I think this is important, and this has been shown to offer better outcomes and better quality of life to the patients. I think this is important because this could be implemented now. So this is something that has to do with policy, and not only with, let's say, the individual treatment of one patient. So it has to do with how do we organize the timely access to this treatment.
So it will be also a way to look at the implementation of these comprehensive centers and the way they can work in the different countries also, and also to reduce inequalities in the countries, which is one of the objective of the network of comprehensive centers.
And this offers two additional advantages. These are better places to carry out research projects, and the second one is that you can easily monitor the outcomes, so certifying that the quality of care is as good as it could be. And also, it should be complemented with a focus on quality of life and palliative care if required.
Necessary, because usually the patients are facing problems to access to treatment, access to diagnostic, and also social difficulties. They can really accumulate the problems. Next question is a question I will have to every voice speaker. What shall be for you the next step to come? I mean, you know, the clock is ongoing. What's next?
Well, then the next things, I think it's important to raise awareness of the things that we can do and the problems associated with this kind of cancers. I think this is important because if not, we are not talking. So sometimes when you read news on the newspapers about cancer, you think that this is almost solved, and it's not. So we need to do a lot of research. So raise awareness, for me, it's important. The second thing, obviously, it's a focus on research, because it's important, that will eventually improve the situation, but also that we need to do something now. So we cannot say, well, you know, research and we need more research, which is something that we agree on. But on this, I think there are many things, or several things, that could be done in terms of organization of healthcare, of access, of sharing good clinical guidelines and monitoring the implementation of guidelines, things like this, assessing the policy initiatives around Europe. I think things like this could be done immediately on the short term.
as I said in the beginning, there was maybe sometimes a kind of sense of fatalism in the group, but also impatience. I mean, they want things to be done really happening. We have a few minutes left because it's a 20-minute time for each. Maybe we can use that to take comments on these statements from the audience. Also, the connected audience. It can be in English, can be in French aussi. Ça peut être en français aussi, hein, les commentaires. So I don't know if that doesn't have to be a real question to Josep. Can be, but Josep is speaking on his name. He can be speaking on the group name. But if you have some comments or complementary point you want to address on these statements, or on the statements that are not there, but might be, could be, please don't hesitate, raise your hand, and a mic will come to you. And also on the internet, of course. Normalement, ça marche. Voilà.
Thank you very much for this.
Ah bah ça, normalement, la première fois ça marche pas, la deuxième fois ça marche. Et là, est-ce qu'on peut, il y a un autre micro qui peut venir pour Monsieur Blé?
I can scream otherwise.
No, this is not an option. Not in that room. This is not a room to scream.
No, I think it's working.
Oh,
yes. Yes, on top of innovation and treatment, on local treatment and systemic treatment, which we all acknowledge is crucial, I think that there is a wide area where we could increase things simply by applying at the best level the clinical practice guideline and the best practices. When we look at that on some specific tumor types, and we are here with the RNs trying to show that, we observe increase in long-term outcome and survival, which is of a magnitude of 10 to 15% by itself, which of course makes a big difference. My question is, how can we ensure that at the European level? And I think to measure that first, and probably registries are going to be crucial, and I would like to have your opinion on that.
Yeah, I think there is a long way of things to do in this way. I think the first, obviously, is sharing data, but also for me, it's also using data to implement measures. So not just sharing data for publishing, if not to implement. And I think from the policymaking perspective, our policymakers should learn that there are things that could be done, but changing the way of organizing the healthcare in a way. So I think that this is the first thing. The second thing is monitoring the implementation of clinical guidelines. So clinical guidelines are not only to be published, are to be implemented, and we need to monitor the implementation. At this calls for an action at meso level, so at the managers of the hospitals, the managers of the cancer centers, and things like that. And this should be supported by cancer plans. I think the European Beating Cancer Plan, it's really an enormous step forward, but I think we need to also to build cancer plans at national level, to focus on this way, on this approach to change the way that we deliver the care. For instance, in my country, we need to expand the concentration of care for some specific procedures, for instance, surgical procedures. And we are doing, but it's not an easy task to do. But I think this is important, this European perspective, to set, let's say, a bidirectional approach from the country to Europe and from Europe to the country. I think this is very important, and also to learn from the others' experience. So I think this is important.
Is it in complement to what Jean-Yves Blé said, on this last proposal, might there be also something about the clinical indications on this poor prognostic cancer? Because usually, as much as I could see, some countries have their own clinical specifications, guidelines, and there's international guidelines, there might be European guidelines, and so they spend time translating, and then at the end, who are the best ones and who are the good ones. Might there be also a kind of harmonizations of the guidelines? On this specific cancer, it might be an issue.
Yeah, we need to avoid duplications of guidelines, simply repeating guidelines, because of you need to write your own guideline. I think to learn from each other could be useful, and there are very excellent guidelines developed at European level. So I think what we need is to apply. So the challenge is not to write a new guideline. So the challenge is to apply. And I think this should be the focus for doing this.
One question from the internet is, is there a specific plan for pediatric cancer with poor prognosis? Can answer that question, and also the fact that there might be a link in between your two actions. We're going to see it.
Yeah, I think, well, the pediatric cancer will be another restitution, no? But yeah, I think we need to learn from pediatric cancer, because pediatric cancer 30 years ago, 40 years ago was more or less in the same situation that we are now in poor prognosis cancers.
Yes, there's here, yes. Bonjour.
Thank you, Ruth Ladenstein. I'm heading the EN PETCAN as a coordinator. And I just want to build on what Jean-Yves just said, and addressing also your question on the guidelines. Just pinpointing that I think working together towards common standards is an absolutely crucial key, and I'm quite proud that the pediatric community over the last 12 to 18 months, the European clinical trial group's main themes have established common agreement on frontline setting guidance. So we are not talking about the diversity one against the other, it's a common voice of guidance. And we will measure this with a registry, very slim, but much larger than an epidemiological registry currently is. And so implementation is now the next step, yeah, how to make it a reality. And I think the more we bring it to the national level with all the measures into health systems to appreciate such a common voice of experts towards a better implementation, I think this is absolutely key. Yeah, so thank you, very supportive, but I think we need to create this common feeling and common voice across unify the community, actually.
There was another comment there, yes.
Yes, I would like to make a strong comment. I will make it in French to make sure I'm well understood. I would like to comment on the first proposal regarding disruptive fundamental research. For having worked 40 years in disruptive research, it's a high risk. So high risk, high gain, as you said, to define this strategy is not perceived as such by researchers in general, because you very well know that it's not the risk which is valued in basic research, it's the quantity, if not quality, of the results that are published. So how are you going to implement at the European level, not only in France, a strategy that will be interesting to motivate the new generations of researchers to take risks? How are you going to implement committees that have the expertise required to assess high-risk research? It's not so easy indeed. And finally, how are you going to organize this at the European level to have meaning and not just a declaration of intent?
We don't have time anymore. We're really out of time. But these are stuff to think about in the group. This is a inspiration for the group. Okay. Thanks a lot, Josep, for your comments and your presentation. Thank you. I have to be a real timekeeper for equity in between all groups. On passe au deuxième atelier. Il concerne les enjeux de prévention. Prévention qui est un levier d'action pour aller au-devant de tous ces cancers jugés évitables. On en a bien parlé. Des budgets qui restent limités, c'est 3% des budgets de santé européens. C'est des réalisations qui parfois tardent à venir, sont compliquées à appréhender au niveau des agendas.
And they actually not very much high on the agenda in the cancer beating plan. We will talk about it with the director of the European League, and especially we've talked about it about the European Code of Conduct, and we have Wendy YARED, director of the Association of European Cancer Leagues.
So we're going to discover the three statements of this group. But as I said, prevention is a major issue for cancer. We know about this. Lots of initiatives are going on. But results can be viewed as a bit if not low, not so visible actually, because there's a lot of resistance on alcohol consumption, tobacco consumption, it was said today, this morning. So what is the main goal for you to step ahead? And I would say, recalling the title of one of your articles, I really love that title, to dance on new tunes. We're not going to dance on new tunes here. We could, actually. I wish we could, but it's not the place for it. But what should be the way to dance on new tunes on prevention?
Well, am I going to report back on the groups,
this is introduction. This is for you.
Okay,
and after we do the statement.
Yes, well, the idea to dance to new tunes is really, you know, we've been dealing with cancer prevention for so long, and the risk is still there, and the rates are still there, so we really need to be more innovative and think of solutions. You know, what can we do differently? We have to review what we've done in the past and what we can improve on. So this is what I mean by dancing to new tunes. And then also new partners, where to find new partners, or maybe have new moves, but with the same partners, and see what works. And, you know, to your point, you were saying, you know, prevention, you know, we have a lot of resistance, but also something that is resisting, that is a challenge, is that actions in prevention takes decades to manifest, right? So, I mean, cancer can take decades to develop, so you change your lifestyle habits, but it might not show itself until afterwards, and I mean, also bad habits as well.
Dancing on new tunes is one thing, and dancing on new tunes is another thing on the European scene. You have a dance floor, now the dance floor is Europe. Usually in prevention, we go national actions because it has to be linked to the cultural habits of the people, to the proximity with the cultural spirit of the people. How and why a European scale, a European dance floor, is that much important on prevention today?
You need to work together at the European level in order for the messages to trickle down to the local level. And indeed, you need to cater that. And if I can use the example of the European Code Against Cancer, which has been now developed almost 40 years ago by the International Agency for Research on Cancer. It was developed in English, but then it needed to be translated. So when you look at the literal translation, as you know, when you look at Google Translate, it doesn't always make sense. So we actually had to ask our leagues to help us translate, because it is the leagues such as in France, here's La Ligue contre le Cancer, who knows how to communicate with the general public. So we look to them to make sure that the messages can translate across. And this is why it's so important to work at the international level. And I can tell you that there were also some difficulties when we're working in translating French. What is the translation in French here in France? But what is it in Switzerland? Right? So, I mean, there are different, but it has to be adapted to the local context, and I think this is very, very important, but it's very important that we already have as a basis at the European level, so that we can work together at the national level. We
saw yesterday on the Cracking the Cancer Code initiative that they had to translate in 12 languages the toolkits, and each translation was also a way to speak the patient language for each country. So let's go to the statement and go to see the first statement of this group is to create a coalition of European cancer prevention stakeholders which aim to promote evidence-based prevention, deploy intervention at your level, and bring priority theme to the forefront of European policy debates using targeted statements. So here you want a coalition to arrive, to come. Who shall join such a coalition? Stakeholders, which ones actually? And what shall be the agenda concretely of such a coalition?
First, if I can, before I embark on the initiatives that was agreed by the group, I want to emphasize that it was a whole bunch of people, stakeholders and experts working together, led by Anka. We very much appreciate this. And, Thomas Dubois has been, doing excellent work in order to get us together. So in a way, we already kind of started this coalition, didn't we, for cancer prevention. But we also, when we were discussing this, we also realized, and recognize that there are coalitions and networks that already exist at the European level. So we said, yes, we want to create a coalition, but we don't want to also reinvent the wheel. So we need to build on existing networks, existing coalitions, and then we also decided, we need to look at what are the themes. So these themes, why did we specify alcohol, pollution, vaccination, screening, inequalities, et cetera, because there are other themes as well, because we felt that in these areas, perhaps the existing coalitions either are not addressing enough or can do a lot more. And so this is only an idea that this could be a leading initiative to create a coalition, but it does need to be developed more further. But this work started only a few months ago, so you can see that this is not ending, and we're hoping that it will be taken on by the next presidency.
It's a coalition to advocate, to inspire, to exchange practice.
To address all the challenges and all the questions and what can we do more? What are the new tunes that we can develop?
And you want it as a step-by-step approach, this coalition, or something to be with an agenda at the first meeting and a roadmap to go?
Well, we need to map. I think that's very important, to map already what exists, to not reinvent the wheel, and then to proceed from there. So it's a work in progress, I believe.
Let's go to the second statement of the group. Promote a healthy environment and avoid risky exposure, notably through actions addressing commercial determinants and aiming for a tobacco-free society and the denormalization of excessive alcohol consumption, implementing a mandatory front-of-pack nutrition labeling which might be inspired by the Nutri-Score, promoting the integration of physical activity in daily routines and strengthening regulation provision related to pollution. As for the first group, this is a big scope of actions, actually. Yes. And some stuff are already done, like the Nutri-Score in some countries. Yes. What exactly is, how can a statement like this reinforce these actions? Because lots of them are ongoing in different states.
And I think we need to see, read what this is about, because we're saying to promote a healthy environment. So we're not making the responsibility solely on the individuals. We're saying that we have to create a healthy environment so that the individuals can avoid risky behavior. So, if you look at, again, if I can talk about the European Code Against Cancer, they are messages that are directed for the general public to follow, but it also says that policies need to be able to support. And this is what we're talking about here, creating a healthy environment. And we also said, we need to address also commercial determinants. And that's been, in this Congress, we already heard several speakers talking about industry influence, and, Madame TRILLET-LENOIR also pointed out, that it's important to address the commercial determinants. And I think that that's something that we haven't done enough in. We've done a lot, I believe, in the area of tobacco. I mean, we all know tobacco industry is there, but how much do we know regarding the alcohol industry, about the sugar-sweetened beverage industry? So we need to address those issues, and this is, I believe, what is new here. How do we promote a healthy environment? I think here in France, you have done quite a bit. When you turn on the TV, I'm always impressed when you have the commercials, the advertisements for snacks, and it says, manger, bouger, okay, it's fine to eat, but in moderation, and also make sure that you move. So I love that, and I think this could be a great example that other countries can follow.
Is it also the fact that the responsibility is not all for the individuals, but it also is for the states, because this is addressing them?
And this is important, if without such a message, without saying that the government is encouraging you and promoting such a healthy environment, it's very difficult for the individuals to follow and to have healthier lifestyles.
Next initiative, reshape communication strategy targeting population and training targeting professionals. This is something which is very important to reshape. The trainings, to reshape the communication actions, yet on which specific aspect do you want to prioritize this reshaping?
when we were discussing in the group, we felt that, yes, there's communication to the general public for the example, the leagues, as I already mentioned. But what we felt was missing was training of the professionals. You're talking about employers. How much do employers know about, for example, if you run a construction company? How much do you know about the risk to UV radiation, the sun? You have your workers working in the sun every day. You don't know, maybe they're not necessarily aware that they're increasing the risk for skin cancer and melanoma, which is the most deadly form. And then also in addition, we were talking about health professionals, because if you're talking about medical students, they're being trained in treatment, how to diagnose, but they know very little about prevention. When was the last time you went to your GP and your GP said, what is your employment, and is there asbestos? Are you working in a bar? Do you drink a lot of alcohol? And do you work outside? Because they're preventive measures, or you're above the healthy weight. You do need to lose some weight. I mean, at least my GP is too busy. He will treat the disease, but he doesn't help prevent the disease. And I think, and this is why when the group was discussing, we need to reshape the communication strategies, but we also need to target health professionals. Also, part of this is addressing the migrant populations and the underserved populations. And you mentioned that the European Code Against Cancer is already translated in the official languages, but it's also being translated, it has also been translated in the unofficial languages. So if you go to our website, for example, cancer.eu, you'll find the translations into Hebrew, into Chinese, into Arabic, because we want to make sure it's reaching to all the pocketed populations that aren't necessarily reachable normally.
Is it also a way to address in that reshaping, like Olivier Vérran said, the new tools like social networks, where there are a lot of messages that can be fake news stuff coming, and that it needs also to reshape the communication tools to be pertinent and to be have a larger impact on these new ways of communications.
Indeed, because we have many now new channels, with the social media, and this is where all the fake news is coming on, and that's where it's really prolific. I mean, we know about the anti-vaxxers. They go on social media, and then people follow all the fake news. They frame it in a way as if, the other day I saw a message, I saw a chart that supposedly was from the World Health Organization, because they put the logo there, and then they put, the fake rates, the dangers of vaccinations, COVID vaccinations. And if you look at it, it did not come from the WHO, but they put the WHO logo, and they took numbers, they threw it in to shape it, to make it look like it's real. And I think, then the health professionals and the advocates for cancer prevention, we need to go back to the same areas where the fake news is appearing, and we need to address it with evidence-based information. And this is why we said, it has to be rigorous, it has to be based on rigorous scientific evidence, and this is how we can make sure that we reshape the communications by reaching to the general public, and also using youth. Using our young populations.
And on these new ways of communications, the exchange of best practice at European level is very pertinent, because sometimes, like you told me about the Denmark initiative, where they created a platform to promote HPV vaccination after there was a promotion of non-vaccination on the social network. So this might be also tools that can be used by different countries and inspirations too. We have time for questions and comments from the audience here and the connected audience there. So if you have some points you want to address to Wendy, English or French, it's possible. Yes and yes. Just do a little presentation of yourself first.
Yeah, I'm Mathieu Pro, past president of European Cancer Organization. Hi, Wendy. I'd like just to continue on what was said about the way we communicate. We have all failed. Our way of communication has not worked, and Olivier Vérran said it very clearly. And came to my mind a provocative way of thinking. We know that the best people to work in the environment of safety in the computer industry are the hackers. And I know that for sure because I'm indirectly involved in there because of family ties. I think we should use those that put up the fake news and convert them, and they would be the best to communicate the message. It's a little bit provocative.
Thank you very much, Mati. Excellent.
There was, yes, you had a point also. There.
Yeah, Christine Leclinche, I'm a French health economist. So thank you for your proposal and the restitution of the work of the group you manage. You mentioned in your first proposal the focus on first 1,000 days, and I think it is an important topic, but what do you mean exactly by focusing on those first 1,000 days? It's my first question. And do you mean we need to focus on future young parents and on the baby and how to tackle with social inequality in health, which is very connected to the first, to this issue, I think. Thank you very much.
Thank you very much. Can we go back to the first initiative, please?
The first one?
Yes, where we talked about the 1,000 days. And indeed, it is about starting from as early as possible. Because when you start at the young age, you know, when they're already very little, and then also adjusting the parents, then you have a head start. And this is very, very important. And I believe this is built on a French initiative. And this is why it's there, because this is the French presidency. And you mentioned dealing with inequalities. Indeed, this is a big issue. And I think we will hear more about it later on. But dealing with inequalities, especially in prevention, is very important about the messages. We already talked about the fake news, because the people who initiate the fake news, they tend to target specific populations, the migrant community, in their own language. Because most of the information, communication that we get are in the languages of the country. Here is French. But then what they don't hear is if you're a Hungarian migrant or a Romanian migrant, you don't get that same information in your own language. And so what do? You know, you listen, you're targeted by the pockets. But thank you very much, because I think it's very important, the inequalities, and also when you talk about screening, you know, we need to make sure that screening services are reachable by the rural communities that are not just in the cities.
And the fact that you address this first 1,000 days might be an issue also for the coalition, as it says. And there's a question on the comment, more likely on the internet coming, saying that tobacco and alcohol are the most bigger problem. There's a lot of stuff done on tobacco, and alcohol seems to be a bit behind on the scene of these actions. How can the situation can change? Can we expect an international tools like we have for tobacco with the WHO Framework Convention on tobacco tools? Can it be also maybe on the agenda of the coalition of European stakeholders to try to have these international tools for alcohol like tobacco? Is there another comment? Yes.
I'm here.
Yeah. Oh, yes.
Walter Ricciardi, I'm the president of the Mission Board for Cancer of the European Commission. I can tell you that all your proposals, all your initiatives have been envisaged and supported by the board. And essentially, we also classify these different actions in possible implementation. The problem, we shouldn't hide ourselves that this is the most difficult part of the job. So we say to European Commission and member states, you cannot be serious to tackle cancer unless you tackle behavioral, social determinants of commercial determinants of health. Because otherwise, you are going to focus on the diagnostic and therapeutics, and you are going to face in the future the perfect storm, which means you are not decreasing the burden of disease, you are increasing needs and demand by the population, by a population which is aging and which is adding risk factors, and you are in a perfect storm because you have incredible technological innovation, but you cannot afford that because you will be having so many patients that you will not be able to treat. Even the equity approach will be in danger. So essentially we propose that. Unfortunately, this has not yet been prioritized, and we shouldn't hide why, because certainly we need a bottom-up approach because we made a top-down approach, but we need a bottom-up. We need a strong collaboration with politicians. We need a strong collaboration with advocates. We need a strong collaboration with citizens. We need a strong collaboration with professionals. We need a strong collaboration with patients, because otherwise, in the past, these strategies have all been failing. Maybe just the tobacco, but now the new tobacco is the nutrition, the nutrition field. And already grower Arlen Brunton in WHO failed. So we shouldn't be aware, and we have to act together.
Thank you. Thanks a lot.
Thank you, Walter.
Thanks to Wendy for the presentation. Merci beaucoup à vous. Merci beaucoup à Wendy. On passe à la restitution
Thank you
du
very
troisième
much.
atelier.
We'll go to the
Un
third
atelier sur
workshop,
cancer et emploi,
Cancer
sujet
and
essentiel
Employment.
puisqu'il
That's
concerne
an
la vie
essential subject
pendant et après le
because it
cancer.
talks about the
30% de la
life
part des
before and
patients qui
after cancer.
perdent ou quittent leur emploi dans les 2 ans
There are
après le
people
diagnostic
who
de la maladie.
actually
Alors, comment accompagner ce maintien à
are
l'emploi,
dismissed or
qui est
lose their job within 2
sociale,
years
créer aussi
after
d'une
being
sécurité
diagnosed with
financière
cancer.
pour les
That's
malades.
also
Pour en
key
parler,
for
Jacques est la
financial
porte-parole du groupe.
security. So I'm going
Elle
to
a
give the
conduit de
floor
nombreuses
to
recherches sur le
the
sujet. Elle a
rapporteur of
aussi
the group.
participé à la
She's
mise en œuvre
been
des
very
guidelines
much involved in
sur le
this.
sujet
She's
dans son
also
pays,
co-worked
aux
on
Pays-Bas.
the guidelines
Angelique
in the Netherlands.
professeur at the Maastricht
So we
University
have
is
Angelique
with
Derich, who's
with
a
us.
professor at the Maastricht University.
Hello, thanks to be here with us. We're going to see the 3 statements of the group, but just to have a few introduction on these very specific topics, maybe the less expected topics on the 5, actually, with the return to work. It's how, I would say, why return to work is nowadays for you a major issue in cancer health policy, and also why is it such a problem, whether for employers, whether for public institutions?
Well, thank you. It's a privilege to talk about this. It's actually my topic. I've been working on return to work for 20 years in research at my university and also in practical projects. But the link is very much to cancer here, and there are specific reasons for that. Due to better treatments, as we all know, the survival rates have increased tremendously. This is a good thing, of course. It's certainly positive, but it also calls more and more for looking at quality of life and survivorship. Survivorship is not just surviving cancer, but living after having had this trajectory. Cancer takes place in the working age. It's about 40% of the population is still in working age, or is in working age, is already in working age, because we also talk about the young people. And we know from research that it's so important to get back to work to really feel the full survivorship of cancer. And if you don't go back to work, and that's taking place in about, it differs a bit between countries, about 1/3 doesn't get back. They had work before, but they didn't get back. And what about the young people who can't enter the labor market because of their cancer history? It's making it more difficult. So that's a major issue. But then the practicalities also. Because we have specific characteristics of cancer, it's a different type of diagnosis. At the moment of the diagnosis, most patients do not have so many symptoms, so also the employer do not perceive them as being very ill. The workability decreases once the treatments, during the treatment period. So it's more difficult to manage than the other type of diagnosis. And next, we have many innovations in the treatments, which means that the return to work trajectory, or the getting back, when you get back to work, this can last years, 10 years maybe. And there are more long-lasting effects. We know more about it, the fatigue. So our systems, our social welfare systems, do not really align to that. We are going to talk about legislation here.
It's very important, because it's like with the relapse thing, it's not like you're sick and then you're not sick. and the welfare system is a bit on that vision.
Yes, exactly.
As the employers. You can have relapse, you can, and even years after.
So it's also more difficult for employers. This challenge of making work expectations is also more difficult. It's not you make a plan and you just follow the plan, but it's, and also the unpredictability of many trajectories make it also more difficult to manage. So employers refrain a bit, they have their dilemmas, they have their concerns also from their side, and then if nobody does a lot, then people are not supported well, and it's also in relation to the social security legislation and all our legislation, and also the occupational health physicians and so on. But there is more to talk about.
Yeah. What the European level? How is it very pertinent to move the regulation and to help support the actors?
Yes. Yeah. So what we need is better return to work policies for all in working age, and in particularly that they fit with all these special characteristics of cancer. That's, for now, it's really important to address that. And all our countries is what we share, and this was also, I think, in the speech of Mrs. TRILLET-LENOIR, we share something in Europe. We share this history of welfare states. We have some degree of income protection. We have some support for having a decent job, but it varies also across the member states. So we share this vision, there is a lot of variation, and now a word to France, because I think that France is historically in a very good position to lead in improving legislation and establishing institutes. And, so it's also about improving and having them in place. So, en français, un grand merci.
A big thank you to France for its initiative in this field.
Oh, it's difficult for me to switch between English and French.
Do you want me to help you? Where is it? C'est sûr. Pour son initiative.
For its initiative to address.
It's like, you know, in the theater, I'm the guy who is hidden and give you the word.
D'adresser cancer et emploi pendant sa présidence.
So, for addressing cancer and employment during its presidency of the European Union.
I wouldn't do half of this in Dutch. Not a word. Maybe we can see the statements, the three statements coming. And the first statements from this group, very important statement. Yes. To promote and implement a supportive legal framework for people with cancer to facilitate their return to work, but also develop legislation concerning the right to be forgotten when accessing financial service to prevent discriminations. How can the right to be forgotten be a real asset for the patients with cancer? And when the groups speak about legal framework, is it like a call for a new law or a new directive to come on this subject?
Well, we have discussed in the working group quite a lot about this right to be forgotten and how it's linked. And I would really like to emphasize that it's about, it's very important for those who are not employees working for an employer, but for the particularly for the self-employed. And we have an increasing number of self-employed. So within my country, and we are a bit ahead, I think, on European average, 1/3 of the people that do not work in a permanent job for an employer. The other that 1/3 is self-employed, but also in platform work, in all kind of flexible contracts. So it's very important to keep that in mind and to safeguard financial security. And the right to be forgotten means that after 10 years, and now in France after 5 years, it's not in your list anymore. It's not on your CV anymore. If you apply for insurance, for mortgages, for anything financially. You have the right that your cancer history is to be forgotten, so you can have more financial safety, which is very important.
Because these people apply by themselves all the time.
Yes,
for this insurance.
yes, exactly. They are not protected by the social system. Yes, so that's one thing. But more has to be done, of course, regarding the right to return to work. That would be our wish, on our wish list, of course. So first, it's very important that, the previous speaker has spoken about workplaces and their responsibilities, but they also have responsibilities regarding return to work. And during the French presidency, there will be established, or this is the aim, to have a specific work stream in the European Beating Cancer Plan, a work stream on return to work. So it's not only about primary prevention in the workplaces, but it's also about a secondary prevention. And so we have to work on return to work in directives in all places in from Europe to, well, the member states. That has also been addressed, this implementation issue. But there is a very important directive, the 89 directive, which addresses healthy workplaces, social rights in the workplaces, and it's still a very important one, and I still teach my students about that. So it's very important what Europe says about what workplaces have to do. That's really important. It may take some time in some states, okay, but you have to give these examples and to establish a standard.
And have an agenda concretely about this. Let's go to the second statement. Second statement is to develop a structure of interaction as well as tools and services for stakeholders and people with cancer to support them and be guided in the process of the return to work. How could such a framework be existing? I mean, some of you called it an employer clubs in a way, and would this concern, like it's always the case, the big companies, and what about the small and medium companies? Usually they're a step aside from these initiatives.
Yes, yes. So, well, we talked a lot about this because in our group there is a lot of expertise on all kinds of things that could be done. But we agreed on this is the structure of interaction, that many different stakeholders, actors are involved, have to be involved, publicly, private and public stakeholders. So it's employers, it's healthcare, it's direct social environment. Return to work, staying in work for this long period during which you are still recovering requires better structures. And then you need tools and services for each of these stakeholders. And the employer club is one. And yes, you may be critical about that. You know, in most countries, the majority of the employers have small, medium enterprises. But in most countries, also the majority of the people are working in the larger enterprises because they have more people working there. That's one thing. Another thing is that this is about giving voice to the employers, giving, showing examples and gathering the early adopters. The people from health prevention will know what I'm talking about, the early adapters. So they show this commitment. They say, okay, cancer is difficult to manage in the workplace. We struggle with the dilemmas, the concerns, but we do something and we try to develop ourselves in workshops, in all kinds of things. That might work for a part of the workers, but we need other types of tools and services for others. We have developed in Belgium, well, as you might know, Maastricht is not so far from Belgium, so we collaborate also with them. We have developed a website for small, medium enterprises, so they can easily get all kinds of information for different stages of survivorship in relation to cancer on this website, because they do not have a lot of time. And also services in hospitals. France is ahead of this, and you have really great examples that you have easy access to work-related service to even occupational physicians in the hospitals. We are looking at that also from Maastricht and the Netherlands. So it's about also mapping which are the different groups, because equal access to care and to support is important here. And we have a very diverse group. We did not address yet the work-life balance issue, combining caregiving tasks. We had yesterday an example of this mother diagnosed with breast cancer, single mother, having to work, having to deal with breast cancer, having to care for the children. This is not a rare example. This is just in our environment. So it's important that we take into account whether the services work for the different groups.
So it might be like places to meet and to inspire and motivate too, because this is two main things, and tools that can be existing and then generalize in the Europe if it's possible, because they're working where they are happening at the moment.
Exactly.
Like with the mapping.
Exactly. We want to share better all our examples, and it's also about this more specific translation that was also discussed with the previous speaker. So it's not only translating in the language, but it's also translating to the context. We have expertise, we have quite some knowledge, but we need more knowledge. We are also going to talk about that. But we do a lot, but we need to share better. So that's also in this statement, yeah. And
third statement is about the knowledge. Build up research regarding the return to work for people with research by leading on EU research program. What is today, and you know that by heart, I would say, the major difficulty to lead researches on this field? It's a very specific field, but what are the main difficulties? The mic here.
Oh, yeah. The argument is very often, well, countries differ in legislation, so you can't compare very well. Well, we should see that as something we can learn from each other. There is a tradition of comparative research. We have methods for that, for doing that. So it's a chance to learn from each other. So first we have to map better the legislation and how it affects the return to work and so on. And then it's also very much about numbers. And that has also been addressed this morning already. We need, as researchers, you always need large numbers to say something. So we need really to share the data and to collect more numbers. Also, in the young people, around the young people with cancer, I just addressed briefly, there is also an issue when you are still in school, you are diagnosed with cancer, how will your working career be? And we know from research that the work participation at the age of 40 is less if you had cancer in when you were young. So these kind of data, the groups within a country might sometimes in some countries be too small, but you want to share here the specific experiences of the patients. Yeah.
What would be the next step through all these statements and proposals? Because each one has quite a big scope, actually.
Yeah. Well, first. Having return to work in this works as a work stream in the Beating Cancer Plan, that would be really nice, and France made a promise there. And secondly, I think there's an urgency to meet in conferences and to also write provisional research plans, so we are ready when the budgets are there and we have a better consortium, including all the groups that already exist, of course. So the French have planned conference meetings. The Czech have planned something on survivorship, so we see opportunities. I have confidence that the Swedes will do so as well, and also will include this this topic of return to work and cancer, or cancer and employment. And what we have seen now with this working group, there is a lot of expertise and there is also a lot of commitment for a more long-term strategy, because for return to work and staying in the workplace, we need longitudinal data. So we need this long-term strategy on research. We can start with smaller research and share better. Well, that's so meet each other already within this presidency.
We can see through your presentation and the way you do it that it was really a group where there are a lot of expertise and also gentle approach from each other and learning from each other country. We don't have much time for the questions. Just recording un commentaire d'internet. Il dit,
just one comment from the internet. In France, we have RQTH, which is a recognition of handicapped worker, which enables people to have adaptation of workplace and time. It's a measure which is not so well known.
About what's existing already and can be benefiting to people returning to work after cancer. Thanks a lot, Angelique, and we can applaud her a lot. Thank you.
Thank you.
Thank you very much. Thanks a lot. Thanks a lot. On va passer.
It's a comment outside microphone, sorry. Comment off microphone, sorry, we can't hear and translate. Talking about social dialogue between employers, contribution associations, instead of doing major research, which is interesting, but it's the daily implementation at the European level in taking into account these situations that we have to act, more than at the Parliament. Go to social dialogue. Well, there is indeed a social dialogue on health, which exists with a strategic plan with on workers. I don't say it is sufficient, but I say it exists. And it complements what has been done here with OSHA Bilbao working on the prevention of these risks.
Suggested, or you said I didn't include a trade union, l'union de trade.
Yeah.
Oui.
Okay.
Je comprends.
But
I could not call all stakeholders. I couldn't include all stakeholders, but it's in our minds. Yeah.
C'est dans l'esprit. Merci à vous. Merci beaucoup.
Thank you very much. A big round of applause.
And
points as yours are listened to because, of course, the objective is to continue working on these topics. We move to the fourth topic, pediatric cancers. Olivier Véran reminded that it was a priority. It continues the masterclass of yesterday of Dominique Carrès, a survival rate that has been improved considerably, but we say 35,000 new cases per year in and so to see how to act more and more effectively, we welcome Gilles Vassal, the director of ITC. Normally the jingle, you have to wait for the jingle. Okay, so do we have the jingle or do we not have the jingle? No jingle.
So you're the president of the ITCC, Innovative Therapies for Children with Cancer and Accelerate platform. You very well know your subject in and out.
This is a topic where a lot has been done in the last years. We talk about the regulation, there's a lot of research ongoing. It's on the priority for the French national plan, for the European plan. So what are still for you the main difficulties to address in that pediatric field?
So you said 35,000 children and young people are diagnosed each year in Europe with cancer.
Yes.
Three numbers. 80% of them will be disease-free, thanks to the treatment established over the 50 years by European and international clinical research, raising the probability of survival from less than 40% to 80%. But 20% difference across Europe, from west to east and east to west. We need to reduce inequalities. Second, very soon there will be 500,000 European citizens who will be childhood cancer survivors. Already 300,000. They have, for 2/3 of them, consequences of the treatment they receive, which are often very intensive, and consequence of the disease. We really need to cure them better. We need to reduce intensity of treatment and to provide any childhood cancer survivor with a passport, whatever we call it, smart card European, with a passport that will provide all the prevention, all the measures, all the follow-up that will assure that those of them having 2/3 of the sequelae will be light sequelae. Third number, 6,000 children and young people die each year of cancer. The leading cause of death by disease in this population. And the plateau of the survival over the last 5 to 10 years. We did the most we could. And we need to boost innovation to understand better this disease and develop and accelerate the development of this innovation to increase the survival rate. So in summary, cure more children and young people with cancer, cure them better, tackle inequalities, and above that, understand better cancer. We need to reinforce the research on cancer, especially to understand why a child has a cancer, which is one of the questions that the parents are asking after they ask the question, will my child survive?
One thing that is coming is the fact yesterday we saw it that there's a lot of collaboration ongoing. The Accelerate platform is a scheme for that. What is needed to support better and to sustain better this collaboration at the European level? A lot is done already, actually.
Absolutely.
You did it yourself.
No, not only.
The community.
No. Yeah. Oh, just a message. I am just reporting the discussion in the group that was installed by the ENG with parents, patients, survivors, pediatric oncologists, radiation oncologists, representatives, researchers, representative of the European Medicine Agency and of the French authorities.
That's what I mean. The community organized itself a lot.
This is not me. This is the group. All the work that will be reporting in the group, the work for the group. So, February 2020, President von der Leyen launched the cancer initiative in Europe. And she said, childhood cancer is a priority at the European level, and they will be put under the spotlight. We are in February 2022, 2 years later, and this is it. This morning, Mr. Olivier VÉRAN, Commissioner Stella KYRIAKIDES, and MEP Véronique TRILLET-LENOIR highlighted the fact that it is a priority. And when we look at what has been done, despite the COVID crisis, clearly there are measures really that can help in the next 10 years to cure more, to cure them better, and tackle inequality. So clearly this cooperation is existing. We need now the member states to step in more, to cooperate, because this is something that will be done only at the European level with all stakeholders and with the member states. So this is why we strongly believe that there is an agenda, and this really can deliver on the objective in 2030.
Let's go to the statement for this group, which there were a lot of convictions and a lot of really, as much as I heard, it was really a group where they want, you were very precise on the wording, precise on the statements. You really want to have the one word and the one measure that you want, that were really the consensus for the group. First measure, establish new ways to coordinate and follow the actions specifically related to pediatric cancer, to support the goal-driven, successful and coherent implementation of actions and projects concerning children and young people with cancer. This is something important because it looks like, as much as I could see, that implementation was a main word coming in the discussions. You had a regulation already happening, and it didn't go to all the promises of this regulation. A new one is coming, and you look to be quite vigilant about what's going to come out of all this good news and good promises from the regulation and the new changes. How can you establish new way to coordinate? How can you follow the action and their implementation concretely, actually?
So in the Beating Cancer Plan, there is a flagship program on childhood cancers. But there are actions in the BT Cancer Plan outside the flagship program that concern directly children and young people with cancer. In the cancer mission, there is clearly a say to improve, but outside of this, there are as well other measures. In the pharmaceutical strategy, the revision of the pediatric regulation, the revision of the orphan regulation, directly for childhood cancer, but the implementation of the HTA regulation that we were discussing yesterday with Véronique TRILLET-LENOIR, and other measures regarding shortages and so on really concern childhood cancer, children and young people with cancer. And there are other measures across Europe. So we say all these measures can really make Europe achieving the goal of getting more and better. And we think that that might be a little risk because it's complex. Understanding this on the ground level and even at the upper level is complex. The interaction between the Beating Cancer Plan and the mission is not obvious. And we said that would be really great to have a proposal to coordinate and follow these actions related to pediatric cancer across all these measures that would really facilitate Europe to really achieve the goal as mentioned. So it is not us building this, and we said to the Commission, we said to the Council, we said to the Parliament, let's figure out how this could be done in the next year to assure that all these measures will be implemented in such a way that we will achieve the goal.
Let's use our expertise.
We are ready. We are working together. The cooperation bit and the work together between the professionals and the parents and the advocates and survivors is really, really good in our field. So we are really, really and willing, keen to collaborate and work with the people.
This is a claim for this first statement. Second statement, ensure the right of children and young people to access clinical trials by reinforcing international clinical trial platforms in pediatric oncology, hemato-oncology, and the reference network of pediatric cancer, the IRN, and facilitate access to cross-border clinical trials by lifting actual current administrative, legal, and financial limitations. Let's start with the second point, the cross-border clinical trials facilitations. What might be the lifting? What is important in that lifting to facilitate the cross-border?
But why did this pop up as a priority? In pediatric oncology, clinical research and care are integrated on a daily basis. We are not talking only on the development of new medicine with pharmaceutical companies under the pediatric regulation and the better regulation that will come up. We are talking about the clinical research set up by the academy over the last years on therapeutic strategy, really providing not only a way to continue to increase the probability of survival, but also to provide quality of care. And it's clear that frontline treatments in clinical trials really help increasing the quality of delivery of care for these patients. So you need to know that more than 60%, sometimes 70% of patients at diagnosis participate in Europe to academic clinical trials. But this is again an inequality across Europe. Because in other countries, especially in Central Europe, this is less than 20%. This is why it is important that this should be reinforced to provide access to all children in Europe to those clinical trials. It's not only developing new medicine, it's really developing better strategy and improving care.
Meaning that they have to be accessing this clinical trial by traveling to countries where they are or in their own country?
And we need both. Reinforcing at the national level how to improve the infrastructure to deliver such clinical trials, and when it is needed, because sometimes it is needed, facilitate cross-border delivery of clinical trials in another country. But let me say a message on this. This is a message to the member states. In the Joint Action on Rare Cancer, Josep BORRAS did an evaluation of all national cancer plans, and we looked at the pediatric topic in this cancer plan. 50% of this plan did not address pediatric cancer. And only one cancer plan was addressing comprehensive cancer plan for, no, not center, a comprehensive cancer plan for childhood cancer. So our aim, our wish is to see each national cancer plan among the 27 member states implementing a childhood cancer plan, cancer specific plan.
Strategy. Okay, this is known also, that will be in the statement. And the third statement, very important, is the one on data sharing, like Poor Prognosis cancer, reinforcing the benefits of research and long-term following up of patients by principle to be applied and harmonizing the application of the regulation. Why is it so important to have a focus on this data sharing and how to promote them better on these pediatric cancers?
So why? Cancer in children is rare. Cancer in children is sometimes ultra rare. We have more than 60 different malignancies. The only way to progress is to get together. This is what we have been doing over the last 50 years. And nowadays, we need to share data. We need to be able to reuse data. And not only data, but biological samples. And this is absolutely crucial, because if you want to run artificial intelligence, no, artificial or artificial intelligence.
Artificial intelligence.
You need large numbers. And if you have a rare constituent, you need to aggregate at the European level and at the international level. So this is why we say that in our field, it's absolutely crucial. And we have been doing that already. Just to say that in 2014, the International Cooperative Group on Neuroblastoma decided to build together an initiative called INRG, International Neuroblastoma Research Group, just to pull together clinical data and molecular data. At that time, this is 20,000 data from 20,000 children with neuroblastoma, which is available. Neuroblastoma, young people, 7% of cancer, and so on. So this is feasible. And what we say, GDPR is slowing down the process. GDPR at the moment, because the harmonization is not there, because the implementation in the different member states and in the different institutions in the same member state is interpreted differently, really makes life difficult, not only for childhood cancer researchers, but all researchers. So we say, let's make the general data protection regulation friendly for research, not modifying the research, the regulation, but making this really facilitating sharing, facilitating reuse of data, facilitating data linkage, and facilitating the cooperation with international groups. And this is one of the actions that we would like to see, making GDPR friendly for research, for example, for childhood cancer research.
Last question, the next step for you, what would it be through all these statements?
So yesterday we discussed a lot what would be the next step. That was a good debate. And we come up with, first, we would like to see a roadmap that would take these actions and say how we will implement, who will be doing what, just to transform this nice work and commitment. And we see that the Commission, that the trio and so on will endorse some of these actions, how this would be implementing in the next years. And the second action we would like to see, and is clearly how the coordination and the follow-up of all these actions for children across all members, all initiatives in Europe on cancer would be really set up.
Okay, these are the next steps, and this were very discussed, as you discussed everything very...
And finally, yes. Cooperation with the member states. That is very important for the ERN-PETCAN. ERN-PETCAN is an instrument which is very important, but we need support by the member states. We need the member state to say at the national level, childhood cancer is a priority. And this is how would be, what will be implemented at the member state level. Cooperation, working together. And we showed that in the field of pediatric cancer. Professionals and patient, parent, survivors are really working together, and we are keen. You mentioned Accelerate. Well, we work with EMA, FDA, industry, and we move the lines.
Like Dominic,
so let's move the lines together.
Like Dominic says. Thanks you for your convictions. Thank you for the proposal. Thanks a lot. Gilles, we can applaud him and applaud all this proposal from the group. Merci beaucoup, Gilles. Merci à vous. Merci beaucoup pour ces propositions.
Thank you for this proposal.
We'll go to the last, our last, notre dernière restitution d'atelier de la journée. Elle concernait un terme transversal, celui de la coopération
Rapporteur
internationale.
on international
qui existe déjà, qui se développe déjà beaucoup,
that also already
mais
exists.
qui parfois manque de moyens,
Sometimes
manque
it
de
lacks
portage politique
means,
aussi pour être des cas
but also political
plus
impetus
largement au sein de l'Union, mais surtout
within
au-delà.
the European
Pour en
Union,
parler,
but
nous
also
avons
beyond.
avec nous la chance d'avoir
We
le
have with
président
us
de l'European
the
Cancer
president of the
Society,
European
qui a joué un
Cancer
rôle
Society,
important,
who has
l'European
played
Cancer
an
Society,
important
dans la mise en
role
œuvre
within the
dans la
implementation
conception du plan
and the
européen
design
du
of this
cancer, qui
European
travaille
plan
sur de nombreux programmes
beating
internationaux.
cancer.
Merci d'applaudir très fort
I
Andras
would like now to
Charalambous.
give a round of applause to Andreas Charalambous.
Hello, thanks to be with us for this last restitution. Just a few words to introduce that important subject. Why is this international cooperation so important to you at the moment we are in the fight against cancer to promote and to structure better than it is actually?
Thank you, Reggie. Let me start by saying that it's a huge pleasure for me to be here with you. I would like to thank INCA and the French presidency for their invitation and the opportunity for me personally being here, but also giving me the opportunity to be here as part of my role as president of the European Cancer Organization. And in terms, coming back to your question, you said and asked the audience to get this document on the way back. But this is, for us, this is not simply a document. It conveys the pathos and the ethos and the logos of the people involved in this group. It conveys our belief and determination in creating this international, national and European collaboration in targeting this problem created by cancer. And why would this be so important now? Because the cancer burden on a global scale is increasing. I mean, the numbers, even the most modest ones, the projections for 2040, for example, they are referring to a 47% increase in the global cancer burden. This is tremendous. Imagine just the people's lives that this disease will touch in that period of time. And it's not just about the patients, as you may all well know, it's also about the families, the societies, the countries, and the world. And I think, and I believe that this workshop comes last because we heard many good ideas in the previous 4 workshops, but what is all that without collaboration? Can we achieve anything without working together? It is by definition an impossibility.
Why is it, what are the main difficulties to build this international collaboration now on? You might try to do a lot of the networking in your cancer society. What is still difficult to achieve?
Well, I see also the workshop we worked in, it is a microcosmos of this international and global society committed to the fight against cancer. So people work on different agendas. They're coming from geographical backgrounds with perhaps different priorities. Some of the efforts are fragmented, and there are quite a few European and international initiatives. But what we have seen is that there is a lack or poor coordination and governance between these organizations in order to establish a strategic common agenda, to get everybody working on the same topic, on the same, maybe not on the same way, but to the same vision and strategy.
It's something like we can do Zoom meeting all the way along, but we need an agenda out of this to work the action and to go to action. Let's go and see the statements. They are really impressive statements for this group. The first one is short, but big. Call for the creation of an international cancer coordination mechanism, like a G10 format. First question, who shall it gather? And why is there such a need for that new thing, I would say? And will it be the new thing and just to meeting and then pass to reinvent the wheel in another way afterwards?
Well, definitely, as a group, as professionals in the field, we don't want to be creating something new that will be replicating the status quo. That's not the idea. This strategic mechanism basically is based on a successful model that we have seen that it worked in the past, and we want to build this international cooperation mechanism based on that successful model. The idea and the question here is not really how many countries are you planning or thinking of including in this format. The idea here is to mobilize countries who have demonstrated a successful pathway tackling cancer. They have mobilized enough resources for doing so, but also countries who hold the scientific expertise. And they have proven their international collaboration in other occasions. So you have to start from somewhere, right? And this will be, let's say, the basis upon we are going to be building on. And this is not a static suggestion, it's a very dynamic one. So you can start from G10 and moving progressively, this will expand and embrace many more countries.
It shall have a political agenda, it shall have an operational agenda also, shall it have also outcomes?
Most definitely, it needs to have, it will have a steering committee who will be deciding on some of the topics that you have mentioned. But yeah, in order, this is a different kind of collaboration. It is on a government, it is on a governmental, on a state level, where the highest policy people will be involved in these initiatives. So the the decision making and the implementation will be part of this initiative.
As much as you have an expertise on these international topics, what shall be for you the key of success of such an initiative? The thing that it will really work, that it will really make people have the desire to go back to the next summit, I would say.
Well, I believe the key in any kind of collaboration is to have a common goal. You have to make this your own baby. You have to work for this and to make it happen. If you don't believe in an idea, no matter how well you work with people, it will never take you to where you are visioning to be.
Next statement, short too, and also ambitious, built on EMA and FDA cooperation on pediatric cancer to extend to other regions and cancer treatment. What was I would say, the aim of this statement, and on which type of region or cancer treatment do you have the intuition that you can extend this existing cooperation per pediatric cancer?
Well, it's a pity when you have so many successful examples actually working and producing results in real life to let them go. So the idea that came from the group is to build on that successful EMA and FDA collaboration that is currently taking place primarily within the pediatric cancers, and expand that to include non-pediatric cancers as well. So we're not trying to change the status of that collaboration, but build on that successful framework and expanding it to touch those non-pediatric cancers as well.
Last statement, also an ambitious one, to the call for the creation of a global cancer fund mechanism. That's huge. What should it be financing, and shall the money be taken from the existing fund? That's a bad question, but you know.
Well, money can never be enough, and the resources allocated now to the tackle of cancer, we know they're not enough, and we have seen with the numbers that I mentioned earlier that with the increase of the global burden of cancer, healthcare systems around the world, they have to deal with an increased pressure. And this pressure in many times means that things that have to be done, they're not done. And this global fund steps into the scene in order to contribute to the already existing ones. And again, this global fund idea and initiative is based on other successful ones, such as the Global Fund for the fight against HIV/AIDS, TB, and malaria. So it's not an idea that came or fall from the sky, but it is an idea that addresses a real need. We need to be investing more in the tackle of cancer.
What's the next step for you from all this? What's to be done in the next months, if not the year to come, on these three really ambitious statements?
I believe the first and most important step is that we acknowledge the problem. And we have put together this political declaration. For these ideas to thrive, we need the political will and energy to back it up. We need a consistency and sustainability of these ideas. It's not only about the French presidency, it's also about the Czech and the Swedish presidency that comes along. Only when all countries embrace the ideas, these ideas will take action and materialize in real life. And I'm referring also to what it was mentioned before. We do need an implementation plan. We have put the ideas on paper, now we have to plan on their implementation.
If there is one or two short comments on on these statements coming from the audience, we can use the few minutes we have left for it. Are there some hand raising on this proposal, impressive proposal?
It's crystal clear, I think. We all need it.
Yes, everyone is agreeing on this proposal. So if we don't have questions, and there are not so much coming from the internet, one is about the sub-Saharan Africa situation to be addressed also by this kind of organization and structure. Well then, thanks a lot, Andrea.
My pleasure, thank you.
Yes, on peut l'applaudir très fort.
A big round of applause. Thank you for the people present here and for those following us online for these feedback. So everything is in the document, so you will find here outside the room and online. You have lunch boxes here, and you can eat, but stay seated due to health requirements. And if you have a translation headset, you can give them back when exiting, and you can take them afterwards for the afternoon, for the roundtables of this, the end of this day. Thank you.
Mathilde qui fait le... On l'a pour 2 jours de même.
Ah ouais. Macumba.
Je travaille pas à la com, mais...
Macumba.
Faut faire la photo aussi.
Ça te regarde
Si on peut. On la cherche. Hop là, hop là, hop là, de chaque côté.
Comme ça va avec vous.
Attention, avec Mathilde.
Voilà. J'adore parce que je souris quand même. Regardez. Oui, c'est
oui, ça.
Hein? Comme ça, moi, j'ai pas fait sourire avec les yeux. Viens. Non, non, on peut pas.
Attends, on peut se décaler un peu si tu regardes. On se décale, on se décale.
Ok. C'est parti. Voilà. Merci. Ah, moi aussi, tout à fait. Là. Merci.
Yes.
Moi, je suis là.
Et eux, ils sont tous les deux. Est-ce qu'il faut une chaise en plus? Non, mais je vais demander à François.
Ouais, mais je...
Comme vous voulez, vous mettez d'un côté.
Ouais, je vais mettre. Ouais, je peux mettre au milieu.
D'accord. Là.
Mais tu vas bien. suis en train de jouer.
Mieux vaut être au banc du gouvernement qu'à celui de la société.
Elle m'a juste dit de me mettre là, non, merci. Je vous vois rarement contre-plonger.
Oui, oui, oui. J'ai rarement l'habitude de voir les gens d'un peu haut.
C'est bien, je trouve cette position de surplomb.
D'accord.
Démarrer à peu près à l'heure dite parce que. Alors après, moi j'avais prévu d'enlever mon. Et non. Si. Parce que c'est un peu difficile de parler à distance avec un.
Mathilde, c'est Mathilde, ça c'est le collecteur.
Comment? Il y a une table ronde.
La puissance de sortie est décalée par rapport à.
Il y a une des tables rondes qui est m'auto-accueillir. Pardon.
Le programme, ce qu'il faut qu'on accueille qui après?
Après, on a la table ronde.
On les a tous déjà accueillis.
Cécilia Le, John Ryan,
Oui, ça j'ai déjà
tous les deux à la même table.
En fait, il faut qu'on accueille Claire.
Et vous à une autre.
Oui.
Elle sera en Zoom, Claire Chéry.
Ah oui,
Claire Chéry
c'est
est en
ça.
Zoom, Madeleine Duré est en Zoom, Johanna Redrek, elle sera sur site. Elisabeth,
on n'a pas d'accueil.
En mettant à cette table.
Après
Je disais à Thierry tout à l'heure, quand vous répondez
tu
aux
l'as
questions,
déjà accueilli.
n'hésitez pas,
Ouais.
si
Pas
vous voulez,
d'accueil.
à passer
Non,
la parole après à l'un des
Claire Chéry, elle sera
pilotes,
en
de compléter. Voilà. Et on fait passer un micro. Il est où Mehdi? Mehdi, tu seras prêt pour les questions-réponses? Si on a besoin de passer le micro. Ouais. Oui, c'est Mehdi qui passera. Non mais on a Mehdi qui s'en occupe.
Ah pardon.
Pourquoi ils mettent de la musique là? Je vais juste vérifier.
Ça serait bien. Habituellement, un jingle, c'est très très court. C'est exactement ce que je voulais dire. je disais que les jingles, habituellement, c'était plus court, mais...
Si, il vous voit. Bonjour, merci d'être avec nous pour cette conférence de presse sur les rencontres européennes de l'Institut national du cancer. Avant de passer la parole au professeur Norbert Iffray et à monsieur Thierry BRETON, je vous rappelle juste quelques éléments de fonctionnement pour notre conférence en distanciel. Vous avez un chat où vous pouvez poser vos questions. On y répondra avec grand plaisir juste après l'intervention du professeur Iffray et de monsieur Thierry BRETON. N'oubliez pas de mettre votre nom, s'il vous plaît, et votre média. Comme ça, nous pourrons ouvrir les micros et vous donner la parole. Ensuite, vous recevrez juste à 14h à la fin de la conférence de presse un lien vers le dossier de presse et la déclaration politique commune. Mais je vais laisser le professeur Iffray et monsieur BRETON commencer cette conférence et nous répondrons tout à l'heure à vos questions. Merci.
Merci à vous, Lydia. Et merci donc à vous d'assister à cette conférence de presse. L'événement qui nous a rassemblés pendant ces 2 journées et qui va s'achever cet après-midi autour de tables rondes que je vous invite à suivre après cette conférence de presse, notamment l'une sur les leviers et les obstacles et l'autre sur la mission Cancer Europe, marque un temps important dans la lutte contre les cancers. Cette première édition des rencontres européennes, organisée par l'Institut dans le cadre de la présidence française du Conseil de l'Union européenne et à l'occasion de la journée mondiale de lutte contre le cancer, constitue une formidable opportunité de renforcer et d'accélérer la lutte contre les cancers au bénéfice des 450 millions de femmes et d'hommes qui vivent sur notre continent. Vous le savez, depuis 2 ans, l'Union européenne a renforcé son rôle en matière de santé. Pour les cancers, elle peut jouer un rôle, en fait, encore plus grand. Le plan européen pour vaincre le cancer, comme la mission Cancer, constitue de nouveaux engagements ambitieux. En parallèle, en France, comme vous le savez, il y a tout juste 1 an, le président de la République annonçait la stratégie décennale de lutte contre le cancer. Ces plans, tous ambitieux, partagent des objectifs communs et se rejoignent sur de nombreuses mesures destinées à lutter contre cette maladie. Ça n'est pas tout à fait le hasard. Très souvent, elles ont été précédées par des concertations. Nous sommes convaincus que nous pouvons aller vers plus de coopération et ainsi placer l'Europe à l'avant-garde de la lutte mondiale contre le cancer. Et la déclaration politique, concrétisation de ces journées, représente un engagement fort en ce sens. Le trio de l'Union européenne, à savoir la France, la Suède et la République tchèque, se sont engagés ensemble. Cette déclaration qui vous a été remise à l'instant réaffirme la priorité politique et scientifique de la lutte contre les cancers. Diagnostiquée chez 2 700 000 personnes en 2020 au sein de l'Union, responsable d'1 300 000 décès, le cancer deviendra en 2035 la première cause de mortalité au sein de l'Union européenne, du moins en l'absence d'actions à la fois urgentes et efficaces. L'enjeu est tel que la réponse ne peut être que commune et coordonnée. 5 thématiques phares ont été proposées par l'Institut national du cancer en concertation avec l'ensemble de nos partenaires européens. Il s'agit de la prévention, Faut-il rappeler encore que 40% des cancers sont liés à des facteurs de risque évitables? Ils sont traits aussi au cancer pédiatrique qui touche 35 000 enfants en Europe chaque année avec 6 000 décès et dont 75 à 90% des causes de développement ne sont pas connues. Les cancers de mauvais pronostic, dont la survie à 5 ans ne dépasse pas les 30%. C'est le cas notamment des cancers du poumon, des cancers du pancréas, du foie, de certaines tumeurs du système nerveux central, dont, on voit comment les choses se rebouclent, le contingent pédiatrique est important, et les leucémies aiguës myéloblastiques. La liste que je vous donne n'est pas exhaustive. L'emploi, pendant et après la maladie, un chiffre. Au moment du diagnostic de cancer, en Europe, 1 600 000 personnes sont au travail. Vous imaginez le retentissement. Et enfin, la coopération internationale pour renforcer et accélérer les efforts relatifs à l'ensemble de ces thématiques. Donc, 5 thématiques à différentes étapes du parcours du malade et à différents échelons de la lutte contre le cancer, là où l'action européenne commune peut avoir un impact fort pour accélérer les progrès au service de tous. Toutes ces mesures ont été co-construites avec nos partenaires européens, en coordination, je l'ai dit, avec le trio de la présidence du Conseil de l'UE. Ce sont des mesures d'envergure concrètes qui nous semblent indispensables pour lutter contre le fléau du cancer. Elles ont été complétées par une série d'actions qui vous ont été présentées ce matin, issues d'ateliers qui réunissaient les principales parties prenantes européennes des 5 thématiques que je viens de citer. Thierry Breton va intervenir plus précisément en revenant sur ces 5 thématiques et sur les actions phares que les 150 experts ont élaborées ensemble. Je vous remercie encore de votre présence à cet événement majeur de la lutte européenne contre les cancers. Et donc, je passe la parole à Thierry Breton.
Merci Norbert. Bonjour à tous et à toutes. Oui, alors peut-être en complément, dans ces rencontres européennes organisées par l'Institut national du cancer, il y a vraiment un point qui nous paraît important, qui est celui de la mobilisation. Hein. Donc, on a autour de ces thématiques-là, autour de tous les points qui ont été évoqués dans les masterclass, de ceux qui le seront cet après-midi dans les tables rondes, un objectif peut-être premier même, hein, qui est celui d'élargir la mobilisation dans la lutte contre les cancers au niveau européen, parce que, voilà, le professeur Ifra l'a dit, c'est la bonne échelle pour faire face à un certain nombre de défis qui dépassent largement le niveau national. Et donc on a besoin de cette mobilisation collectivement, et évidemment c'est la mobilisation de tous les acteurs institutionnels, mais aussi des associations, mais aussi des entreprises, mais aussi des banques, mais aussi des assurances. Et on cherche à créer ce mouvement-là pour appuyer des outils qui existent déjà au niveau européen, que sont le plan cancer européen, en matière de recherche, la mission Cancer Europe, et compléter, approfondir et développer cette action voilà, pour faire en sorte que demain, au niveau européen, comme on cherche à le faire au niveau national, on puisse réduire le poids des cancers dans l'Union européenne. Alors je ne vais pas pouvoir commenter les 32 propositions qu'ont fait les experts. Alors déjà, 32, c'est un chiffre assez significatif. On n'espérait pas en avoir autant. Hein. C'est dire la qualité du travail qui a été réalisé. On a réuni pendant quelques semaines, à l'occasion de 3 réunions bien denses, 150 experts de tous les États membres, et donc voilà, qui ont produit d'abord, qu'on a remercié, on les remercie encore une fois de l'engagement et du temps qu'ils ont passé avec nous pour réfléchir à ces questions-là, et les remercier bien sûr, je crois, pour la qualité de leurs propositions. Donc on a quelques actions, voilà, qui sont selon les thématiques peut-être un peu plus en avant. Je crois que sans les commenter toutes, peut-être m'arrêter sur quelques-unes d'entre elles. Si on prend la lutte contre les cancers de mauvais pronostic, la difficulté à laquelle nous faisons face est celle à la fois de la complexité des cancers, de certains cancers des enfants, et puis le faible nombre de cas. Donc ça c'est heureux, même si évidemment ces situations sont éminemment douloureuses pour toutes les familles, mais le fait qu'il y ait peu de cas en France et qu'il y ait peu de cas en Europe, finalement, plaide pour une mutualisation et pour avoir un accompagnement de la recherche clinique au niveau européen. Donc c'est une des propositions que fait le groupe au niveau européen d'avoir le groupe d'experts, pardon, qui est d'organiser cette recherche clinique parce qu'on a besoin voilà, d'offrir à la fois plus de solutions et d'organiser des essais qui soient des essais de plus grande ampleur pour apporter des solutions thérapeutiques à tous les enfants européens. Si on s'arrête sur le sujet des cancers de mauvais pronostic, un exemple parmi d'autres, hein, ils sont tous de même valeur, entre guillemets, hein, mais qui paraît peut-être emblématique. Hein, donc c'est des cancers qui sont d'une complexité importante et qui font que voilà, les équipes prises isolément ont les pires difficultés à traiter et puis à proposer des pistes thérapeutiques. On peut citer le cancer du pancréas, certains cancers du sein dits triple négatifs, le cancer du poumon, etc. Donc le groupe, entre autres, proposé la mise en place d'un appel à projet au niveau européen qui donc permettrait aussi de fédérer les équipes européennes. Un appel à projet qui est qualifié de high risk, high gain. Donc c'est ce nouveau type d'appel à projet qu'on a commencé à implémenter en France, hein, qui consiste à essayer de soutenir des projets de recherche qui ont un potentiel disruptif, d'innovation qui est beaucoup plus fort et d'avoir une prise de risque scientifique qui est beaucoup plus forte. Donc le groupe a proposé cela. En matière de prévention, le sujet, par exemple, va être celui de la mobilisation autour de la promotion de la santé et donc du renforcement et la création d'une coalition de tous les acteurs dans la promotion de la santé. On sait que les enjeux en matière de prévention, le professeur Ifra l'a rappelé, sont très importants. Hein. C'est de loin la principale poche de progrès si nous voulons réduire le poids des cancers demain. Hein. 40% de cancers évitables, je pense que ce chiffre parle de lui-même. Et donc, il y a cette idée aussi que la promotion de la santé, c'est l'affaire de tous, et que ça passe aussi par une coalition, une mobilisation de tous les acteurs, en particulier vis-à-vis du principal facteur de risque que représente de loin, et le premier facteur de risque que représente de loin la consommation de tabac. En matière de cancer et emploi, on a... et de droit à l'oubli. Alors, l'actualité était particulièrement forte sur la scène nationale, puisque, vous l'avez vu, et le ministre l'a rappelé ce matin, il a annoncé, donc le droit à l'oubli, suite au vote des deux assemblées, a été réduit de 10 ans à 5 ans pour tous les patients touchés par un cancer, et pour d'autres pathologies, il y a aussi l'hépatite C de mémoire. Et donc nous sommes, voilà, nous, Institut National Cancer, mais collectivement, finalement, soucieux de promouvoir aussi ce droit au niveau européen, comme de promouvoir aussi tout ce qui va être et va permettre le retour à l'emploi ou le maintien en emploi, avec des dispositions qui peuvent être réglementaires. On a le sentiment, et c'est un peu des propositions du groupe, qui a besoin de régulation et de réglementation supplémentaires, hein, pour permettre et éviter ce surrisque de chômage, et puis des actions complémentaires en matière de recherche pour mieux connaître les parcours de ces personnes-là et pouvoir y répondre. Et puis enfin, en coopération internationale, peut-être le sujet de cette volonté de créer un groupe des pays les plus avancés qui réunirait leurs forces, comme on cherche à le faire au niveau européen, sur les sujets, les grands défis, les sujets les plus complexes, pour que voilà, la compétition internationale soit la plus efficiente possible et qu'elle soit source de progrès. C'est cette idée d'avoir l'équivalent d'un G10, voilà, qui permette aux pays les plus avancés de se coordonner dans la lutte contre les cancers et de coordonner leurs actions de recherche, et évidemment au profit de tous. Alors voilà quelques exemples pour illustrer partiellement l'immense travail qu'ont réalisé les experts pendant ces quelques jours.
Merci. Alors, je vous propose maintenant d'en venir à la partie des questions-réponses. Avant de débuter, je souhaitais vous préciser que nous avons aussi parmi nous, pour répondre à vos questions, les 5 pilotes des ateliers thématiques qui donc ont eu lieu en amont de ces rencontres européennes, et également notre expert sur les données qui pourra aussi répondre à vos questions. Alors, on va débuter avec Monsieur Alain Pérez pour Terragora, qui pose une question sur la recherche. Monsieur Pérez, on va ouvrir votre micro et vous allez pouvoir nous poser votre question directement.
Bonjour, vous m'entendez?
Oui, on vous entend bien.
Très bien.
Oui. Je voulais poser une question sur la faiblesse. C'est un sujet qui n'a pas été évoqué. Moi, j'ai assisté à tous les ateliers depuis hier. Et la faiblesse de la recherche européenne, quand je parle d'Europe, je parle d'Europe, bien sûr, des 27. Hein. Donc la recherche à la fois académique et industrielle n'a pas été du tout évoquée, alors qu'on voit qu'aucune des percées majeures qui ont été effectuées ces 10 ou ces 20 dernières années, et dans le domaine des thérapies ciblées, et dans le domaine de l'immunothérapie, et dans le domaine des thérapies cellulaires, aucune ne vient de la vieille Europe, encore une fois, l'Europe des 27, si on exclut bien sûr Roche, Novartis, les constructeurs suisses. Et si on voit le bilan, le classement des 10 premiers industriels en oncologie, ben, on retrouve Roche, Celgene, Novartis, BMS, J&J, Pfizer, et tout, et on ne trouve aucun donc, des industriels européens. Encore une fois, l'Europe étant réduite aux 27. Alors, la question que je me pose, c'est est-ce qu'on peut... vous avez parlé tout à l'heure d'innovation disruptive, on est bien dans ce sujet-là. Comment faire pour rattraper ce retard qui est connu, qui est identifié depuis maintenant très longtemps et qui touche, comme je disais tout à l'heure, à la fois la recherche académique et la recherche industrielle? Merci beaucoup.
C'est absolument une question centrale. À vrai dire, pendant très longtemps, la recherche a été considérée comme une dépense et pas comme un investissement dans beaucoup de situations. D'autre part, à côté de la découverte scientifique elle-même, sur laquelle je suis moins sévère que vous, la prise de risque et le passage, entre guillemets, de la découverte scientifique à la start-up ou à l'industrie, clairement, dans beaucoup d'États, est une étape qu'il faut considérablement améliorer. Après, quand vous regardez ce qu'il y a en termes de recherche fondamentale, véritablement, je crois que c'est un petit peu méconnaître ce qui se passe en Europe, et notamment dans les pays européens les plus investis dans cette recherche, que de dire qu'il n'y en a pas. Par exemple, un très bel exemple, ça a été toute la recherche qu'il y a eu sur l'écarté. Il y a eu des recherches faites au niveau de de pays de l'Union européenne, dont la France. Puis ensuite, comme il s'agissait de travaux sur des OGM, on a eu des législations très frileuses qui ont fait que lorsqu'il a fallu passer à l'étape, je dirais, préclinique et clinique, sont apparues des frilosités et des gens sont partis. Donc ça, c'est bel et bien ces démarches que nous proposons de voir s'améliorer, parce que cette frilosité, ben, on en a vu les séquelles, on en a vu les conséquences. Maintenant, ne soyons pas trop durs. Dans un exemple très récent qui n'a aujourd'hui, mais encore que c'est faux, rien à voir avec le cancer, qui a été celui des ARN messagers, oserais-je vous rappeler que BioNTech est une entreprise allemande? Je ne sais pas si je vous ai répondu, mais vous avez raison sur le fond, non pas sur le travail et la qualité de la recherche fondamentale, mais sur sa capacité ensuite à se transformer en, je dirais, en médicaments au sens très large. Il y a du travail à faire. Ceci dit aussi, ça passe par l'engagement aussi d'industriels plus ou moins frileux. Moi, j'ai travaillé dans une vie antérieure avec des start-up clairement européennes qui ont mis en évidence, qui ont créé, par exemple, des anticorps bispécifiques, mais au moment du rachat du médicament, ce sont clairement des entreprises soit suisses, soit américaines qui ont racheté la start-up pour développer le médicament. Donc je dirais que sur l'innovation elle-même, votre diagnostic, il est très dur et probablement un peu injuste, mais là où il est parfaitement juste et où il y a vraiment un travail à mener, c'est sur sa capacité à, entre guillemets, transformer l'essai. On va rentrer dans la période du tournoi des 6 nations, donc pardonnez-moi cette allégorie.
Merci. Alors, je vous rappelle que vous pouvez nous adresser vos questions via l'espace dédié sur le Zoom. En attendant, peut-être pourrions-nous revenir, Monsieur Breton ou Professeur Ifra, sur la genèse de ces rencontres européennes. Quelles ont été les impulsions, voilà, comment on a organisé ces éléments. Je vous laisse répondre sur ce point.
Oui, c'est relativement simple en fait et clair. On a un événement qui en soi est une opportunité absolument exceptionnelle de se mobiliser au niveau européen, qui est le fait que la France préside le Conseil de l'Union européenne pendant un semestre. C'est chose qui est devenue rare avec l'extension à 27 États membres. Donc la dernière fois que c'était arrivé, c'était en 2008 ou en 2009, il y a toujours une petite hésitation. Donc c'est dire que ça n'est pas très fréquent. C'est vraiment un moment où un pays, au nom de l'intérêt général européen, parce que c'est ça qu'il faut avoir à l'esprit, peut porter une vision et une ambition. Et donc on a, nous, Institut national du cancer, avec bien sûr le ministère de la Santé, le ministère de la Recherche français, voulu profiter de ce moment et de cette opportunité qui nous était offerte pour faire en sorte que nous puissions concrétiser un peu les convictions que nous avons sur la nécessité de travailler encore plus loin, plus avant, à l'échelle européenne pour faire face aux défis dont nous voyons bien que la mobilisation nationale, bien sûr, va nous permettre de faire des avancées, mais que pourrait-on dire s'il y avait une mobilisation au niveau européen sur des défis qui sont absolument compliqués. Et on voit très clairement avec la Covid à quel point l'Union européenne a été un espace de solidarité absolument incroyable dans la gestion et l'achat des vaccins, d'efficacité aussi, un acteur aussi de solidarité internationale tout court avec la redistribution des vaccins dans les pays à faible revenu, absolument incroyable. Donc c'est vraiment un espace qui, voilà, pour nous, doit être un espace aussi où on se coordonne sur les politiques de santé, ce qui commence à être fait, mais qui devrait être fait plus fortement demain. Et nous avons ensuite, c'est ce que je disais tout à l'heure, cherché à profiter de ce moment-là, non pas pour avoir une vision strictement institutionnelle, pour faire un moment de rassemblement, en espérant que la mobilisation que nous venons de créer perdure.
Merci. Alors, dans les ateliers, on a un sujet qui est peut-être un peu moins abordé que les autres, qui est le sujet sur cancer et emploi. C'est vrai peut-être qu'il y a des thématiques qui sont plus souvent abordées. Est-ce qu'on pourrait dire un peu plus sur cet atelier-là, sur cette thématique, quels sont les éléments qui sont ressortis du groupe de travail? Voilà, peut-être que M. Foucault veut intervenir sur ce point-là, ou M. Breton, ou professeur Ifra.
Oui, oui. Peut-être très rapidement, je crois que c'était en effet un choix de l'Institut national du cancer de faire une proposition particulièrement innovante sur cancer et emploi. Alors c'est vrai qu'on aurait pu dire cancer et travail, parce que bien évidemment quand on parle de cette thématique-là, c'est bel et bien intervenir à tous les temps, c'est-à-dire c'était aussi se questionner sur ces jeunes enfants qui ont des cancers et qui vont rentrer dans la vie active, et pour eux c'est pas non plus très très facile parce qu'il y a des impacts qui sont retentissants également pendant le cancer et après le cancer, avec ces questions qui étaient assez larges sur le concept de survivorship, c'est-à-dire comment en fait on va accompagner l'ensemble de ces patients tout au long de ces phases. Le groupe en fait a fait des propositions extrêmement intéressantes, extrêmement innovantes en disant il faut aller plus loin au niveau européen, il faut s'appuyer sur les cadres réglementaires et législatifs existants, il faut absolument les renforcer. D'autre part, il faut intervenir aussi à un autre niveau, c'est pouvoir équiper les États européens de dispositifs qui leur permettent de mettre en place des dispositifs pour trouver des solutions concrètes pour ces pays sur cette question de cancer et travail. Donc sur le modèle de ce que la France a pu proposer autour du club des entreprises et de la charte, qui est un dispositif très innovant. Et on l'a vu dans le groupe, la France est vraiment moteur là-dessus et a proposé quelque chose d'extrêmement intéressant que beaucoup de pays en fait souhaiteraient reprendre. Et puis bien sûr aussi la question de la recherche. On a vu très clairement ce qu'a proposé Angelique RIJK ce matin, qui était la question de faire un petit peu un état des lieux, mais c'est surtout comment intervenir. C'est-à-dire qu'en fait, on a un vrai sujet, comment on va pouvoir accompagner davantage les patients, différentes phases dans lesquelles ils sont, quand ils sont dans cette situation de travail et d'emploi. Et donc, on a vraiment besoin de données là-dessus. Donc voilà ce qui a été discuté et proposé, avec des propositions extrêmement concrètes pour pouvoir avancer très très rapidement dans les prochains mois.
Très Très bien. Et peut-être qu'on peut, pour être vraiment dans l'actualité, mais Monsieur Breton, vous en avez parlé déjà tout à l'heure, sur le droit à l'oubli, quelle est l'impulsion de la France et comment on continue à travailler pour faire avancer ce sujet-là au niveau français, mais aussi pour accompagner nos amis européens pour le développement dans leur pays.
Si tu veux, c'est toi qui as interpellé.
Oui, donc on a la chance en France de s'être doté assez rapidement de ce droit à l'oubli, et donc on le connaît bien à l'Institut national du cancer parce qu'on a beaucoup travaillé à sa genèse en 2015 ou 16, je ne sais plus exactement. Et donc on a effectivement à la fois une expérience du dispositif, et puis on voit qu'on est capable de le faire évoluer, et donc l'annonce qui a été faite ce matin est particulièrement importante, hein. C'est un énorme changement en réalité que de passer de 10 ans à 5 ans, de passer ce délai au-delà duquel il n'y a plus besoin de questionnaire médical. Notre sentiment et notre volonté, c'est que au niveau européen, on trouve une façon d'inscrire dans les textes ce même dispositif, ou en tout cas quelque chose d'approchant. Malheureusement, pour l'instant, il y a, je crois, 4 à 5 pays qui sont dotés d'un dispositif, d'un dispositif équivalent. Il nous semble que vraiment c'est un droit qui trouverait sa place au niveau communautaire, dans la législation communautaire. Pour y arriver, donc le point a déjà été mentionné en réalité par la Commission, notamment dans son plan européen contre le cancer. Mais il y a un travail très clairement d'acculturation, parce que ce dispositif, dit avec ces quelques mots, paraît relativement simple. En fait, il est assez compliqué. Et on a un travail de pédagogie vis-à-vis de nos collègues des autres États membres, en tout cas ceux qui n'ont pas ce dispositif, pour faire comprendre un peu comment ça fonctionne et quels en sont les enjeux. Tout le travail qu'on avait fait avant l'adoption en France pendant de longues années avec les associations d'acculturation, de travail avec notamment les banques et les assurances, et puis les autres ministères aussi, hein, qui ont des logiques et des centres d'intérêt un peu différents. Donc il y a tout ce travail qu'il faut faire au niveau européen, de conviction, d'acculturation au niveau des États membres, avant que le sujet puisse être ensuite porté au niveau communautaire. Mais je crois qu'on est 4 à 5 mobilisés là-dessus. Voilà, la Commission l'est aussi. Et donc il faut prendre un peu notre bâton de pèlerin, entre guillemets, pour vendre les mérites et l'importance de ce droit pour les patients.
Si je peux juste compléter et renforcer ce qui vient d'être dit, il ne faut pas oublier que cette décision vient sanctionner ou saluer l'amélioration indiscutable des résultats dans le champ des cancers ces dernières années, bien sûr dans notre pays et dans un grand nombre d'autres pays européens. Et c'est je dirais, un objectif de plus au niveau de l'Europe, puisque, hélas, il n'y a pas encore une telle homogénéité de résultats pour tous les pays de l'Union européenne. Et on montre la voie et on montre le bénéfice de la voie. Et vous voyez, c'est à la fois une reconnaissance et une stimulation considérable à travailler ensemble et à ce que chacun de nos pays apporte sa contribution et prenne aussi exemple de ce qui a pu marcher ici ou là. Il y a vraiment, c'est ce qu'on a pu entendre, c'est ce qu'on a pu voir, pas de pays qui n'ait pas une originalité, un apport, et je crois que une bonne coopération, intelligence va nous faire progresser tous. Et sur ce champ-là, où effectivement la France a été pionnière, on voit les résultats année après année, hein, indiscutablement. Bien sûr, c'est une décision politique très très importante, mais elle ne vient pas sans substrat. Et ce substrat, c'est l'amélioration continue mais substantielle des résultats.
Merci. Alors, je vais vous proposer maintenant une question de Monsieur Philippe Richard, professeur IFRA. On va peut-être ouvrir le micro de Monsieur Richard pour qu'il vous la pose, puisqu'il fait référence à votre propos tout à l'heure où vous citiez l'écarté. Monsieur Richard, à vous.
Oui, bonjour, Philippe Richard de Ouest de France. Vous citiez tout à l'heure l'exemple des quartiers qui sont réglementairement considérés comme des OGM, ce qui a suscité un certain nombre frilosité. Est-ce qu'il y a selon vous d'autres freins législatifs au niveau européen à l'innovation en oncologie? Et est-ce que vous faites justement dans le cadre de vos rencontres, des propositions en ce sens pour faire évoluer certaines réglementations qui pourraient être un frein à ces recherches?
Alors écoutez, je crois que les législations ont terriblement évolué ces 10 dernières années, mais vous savez que, contrairement à une idée reçue, les recherches, elles ne naissent pas agies pour devenir opérationnelles et utilisables en clinique à J+1. Pour vous donner une idée, il y a plus de 20 ans que des gens avaient commencé à travailler sur l'écarté. N'oubliez pas qu'on parle aujourd'hui de l'ARN messager en utilisation thérapeutique et que, sauf erreur de ma part, ça a valu le prix Nobel à Lvov, Jacob et Monod en 1964. Donc, ces découvertes, elles ont eu lieu, et ensuite se sont passées les méthodes, les moyens de s'en servir, je dirais, à l'échelon thérapeutique ou diagnostique parfois. Et je crois qu'il y a eu une grande période de blocage et de frilosité, je dirais, entre le milieu des années 90 et le milieu des années 2000, où tout ce qui pouvait toucher à ce qui pouvait ressembler à quelque chose de génétique, c'était la grande époque des croisades anti-OGM, etc., entraînait quasiment une interdiction de travailler. Moi, j'ai connu l'époque où on ne pouvait pas, par exemple, réinjecter de cellules qui avaient été passées en culture dans des thérapeutiques de maladies extrêmement graves. Et je me souviens très bien, pour un malade, d'avoir un jour transféré en Belgique où c'était autorisé, un malade que je suivais, étant entendu que la technique, c'est moi qui l'avais apprise au gars qui l'avait implanté en Belgique parce qu'il pouvait le faire. Voilà, donc ça s'est passé. Mais on a mis un certain temps à revenir de ce qui a été un excès de frilosité. Je crois, enfin pour autant que je sache, mais surtout que mes collègues n'hésitent pas à me corriger si je me trompe, que tous ces freins à la recherche, ils ont été levés, et il faut reconnaître que les épisodes très récents montrent combien on a raison de ne pas faire de blocage a priori. Il ne faut pas faire de blocage a priori, il est toujours temps ensuite de corriger le tir.
Je vous propose maintenant une question. On peut ouvrir le micro de Madame Debacker de Hospi Média qui revient sur les propositions qui ont été faites par les groupes. Madame Debacker, je vous laisse poser votre question. Est-ce qu'on peut ouvrir le micro de Perrine Debacker, s'il vous plaît, sinon je pose la question.
Est-ce que vous m'entendez bien?
Parfait, merci.
Merci. Oui, je me demandais en fait quelle était la prochaine étape. Comment est-ce que concrètement ces 32 propositions vont être mises en œuvre? Est-ce que les groupes mis en place vont continuer à travailler, par exemple, sur la mise en œuvre pratique des propositions?
C'est effectivement une bonne question. Il ne suffit pas d'avoir réfléchi et travaillé pour aboutir à des propositions et avoir suscité cette mobilisation. Il faut encore que ça perdure. Alors je crois qu'il y a ce qu'il faut noter déjà, c'est qui est important, c'est que tout ceci a quand même une consolidation et un point qui est essentiel, que c'est la déclaration politique qui a été signée par les 3 ministres de la Santé, donc français, de la République tchèque et suédois, qui vient consacrer le travail qui a été fait, rappeler l'engagement du trio dans cette politique de lutte contre les cancers et mettre en exergue, en avant quelques-unes des propositions. Donc cette déclaration politique, elle est engageante, donc les ministres se sont engagés dans cette politique-là de manière très très nette. Et donc ensuite, il faut, je crois, trouver et continuer le travail donc au long cours en réalité, donc pendant la présidence française, mais aussi pendant la présidence de nos homologues suédois et tchèques, pour rendre plus opérationnelles ces propositions, au sens où certaines d'entre elles, parfois, méritent encore d'être un peu affinées. Certaines d'entre elles, la plupart, méritent encore d'être organisées, d'établir un calendrier en fait, d'action. Mais la logique dans laquelle on est vraiment celle-là, c'est que ça soit le support d'une mobilisation et de rendez-vous réguliers que nous souhaitons avoir au niveau européen avec nos homologues sur la bonne mise en œuvre de ces propositions. Mais il y a un point qui est important, c'est que ce travail est issu ou été fait dans un moment qui est celui de la présidence française, incarné donc sous l'égide de la France, hein, incarné par l'Institut national du cancer. Ça n'est pas la propriété de l'INCa et ça n'est pas de la seule responsabilité de l'INCa ni de la France. Et vraiment, ce qu'on a dit ce matin, ce qui est important, c'est que le travail qui est fait, c'est le fruit d'une mobilisation collective. Sa mise en œuvre doit être aussi le fruit d'une mobilisation collective. C'est à ça que nous appelons. C'est extrêmement important. Donc il faut qu'on arrive à garder cet élan un peu nouveau qu'on a su susciter pour rendre concrète et mettre en œuvre ces actions.
Et évidemment d'accord. Et n'oublions pas qu'un très grand nombre des recommandations que nous avons vues viennent compléter et affiner des orientations qui avaient été données, d'une part en France dans la stratégie décennale cancer, mais aussi dans soit la mission Cancer Europe, soit le plan européen pour vaincre le cancer. Et donc, ils viennent affiner des orientations générales et finalement, ils constituent une étape supplémentaire dans cette démarche. Donc, il y en a qui sont déjà suffisamment précises pour passer véritablement en phase opérationnelle. Et si j'osais, il n'y a plus qu'à trouver les moyens financiers de le faire. Et pour d'autres, ils indiquent des pistes. Et ces pistes, comme Thierry vient de le dire, le trio s'est engagé à essayer de les creuser et va certainement donner les moyens aux gens qui se sont retrouvés, qui ont sur ces réflexions, d'affiner leurs demandes.
Alors, je crois que vous venez d'anticiper la prochaine question, professeur Ifra. C'est la question est de Madame Wierzbicki de Pharmaceutique. Julie, pouvez-vous nous dire si ce que vient de dire le professeur Ifra répond à votre question, puisque vous demandiez effectivement s'il n'y avait pas des ponts entre ce qui était déjà dans les programmes européens? On vous écoute. Alors, est-ce qu'on peut ouvrir le micro de Madame Wierzbicki, s'il vous plaît? Alors, je vais poser la question. Parmi les mesures proposées, n'y en a-t-il pas qui sont déjà adressées ou qui pourraient l'être par des programmes européens déjà lancés, Plan Cancer européen, Horizon Europe, EU for Health, qui ont aussi fait du cancer une de ses priorités?
Effectivement, j'ai l'impression d'avoir répondu.
Voilà, ok, merci beaucoup. Alors la prochaine question est de Madame Thaïssa Stivanin de RFI, qui revient sur le sujet Covid et cancer. Madame Stivanin, je vous laisse poser votre question. Votre micro est ouvert. Bon, alors il ne veut pas, donc je vais poser la question. Quelles actions la France et les autres pays européens peuvent entreprendre pour combler le retard des diagnostics et de traitements causés par l'épidémie, surtout au début, donc c'est-à-dire à l'occasion du premier confinement?
Je peux commencer à répondre, peut-être Jean-Baptiste pourra-t-il compléter et affiner. Il y a évidemment eu un retentissement surtout aujourd'hui de la première vague de la pandémie sur le dépistage, le diagnostic et parfois le traitement des cancers. Comment l'évaluer? C'est extrêmement difficile. Ce qui est facile, c'est le dépistage. Il y a eu, parce qu'il y avait des données scientifiques pour ça, une interruption des dépistages pendant 3 mois. De toute façon, c'était une interruption entre guillemets forcée du fait du confinement, du fait que les médecins, assez souvent, étaient occupés ailleurs à soigner des malades et les malades eux-mêmes se déplaçaient ou pas lorsqu'on leur proposait une invitation, y compris malheureusement lorsque un dépistage positif avait été fait auparavant et que l'étape d'après de confirmation était à faire. Donc indiscutablement, on peut considérer qu'il y a eu pendant ces 2 mois et demi là, 3 mois, une véritable sidération qui a correspondu à une diminution qui n'a pas été rattrapée véritablement sur les dépistages. Dès que ça a redémarré à peu près à la vitesse, en tout cas en France, mais je crois savoir que ça n'est pas très loin d'être pareil dans le reste de l'Union européenne. Il y a eu un redémarrage assez rapidement au même rythme qu'avant cette sidération, mais il n'y a pas eu tellement de rattrapage. Donc il y a eu un retard certainement de diagnostic dans certaines situations. Évidemment, il faut le nuancer par le fait que, particulièrement en France, l'adhésion au dépistage est extrêmement variable et insuffisante. Ensuite, pour ce qui est du diagnostic et du traitement, c'est plus compliqué parce que, et là, je voudrais rendre hommage à ce qui a été fait particulièrement par Jean-Baptiste Méric et son équipe, en lien avec les directions d'établissement, les agences régionales de santé et la direction générale de l'offre de soins, c'est qu'on a essayé d'organiser le traitement à l'échelon individuel de chaque malade de la manière la mieux adaptée à sa situation. Ici, en modifiant l'ordre des traitements, par exemple en commençant la chimiothérapie avant la chirurgie ou la radiothérapie, là, en remplaçant un traitement intraveineux par un traitement oral. Tout ça a été fait bien entendu avec les sociétés savantes. Et donc il y a eu énormément de situations d'adaptation pour faire face à cette diminution de capacité d'hospitalisation, les lits étant pris par des malades évidemment en grand besoin de soins, comme vous l'avez vu et comme on l'a tous vu. Donc ce qui est certain, c'est qu'il y a eu une reprise aujourd'hui complète du nombre des actes, immédiatement d'ailleurs complète du nombre des actes, et ensuite l'interprétation du remplacement d'un acte par un autre, on ne peut pas le faire. On ne peut pas le faire parce que on a effectivement changé des options thérapeutiques les unes par d'autres qui étaient plus ambulatoires, et évidemment qui a été calculé, mesuré pour donner le moins de pertes de chance possible. Donc la question est excellente, je pense qu'on aura la réponse dans 10 ans. Aujourd'hui, la réponse qu'on a, c'est celle des actes, et ces données-là, elles sont extrêmement claires. Il y a une reprise aujourd'hui complète du nombre d'actes, il y a une reprise complète du nombre de dépistages. Dans certains cas même, mais c'est très difficile à interpréter, les dépistages ont repris à un taux plus élevé que ce qu'il y avait avant la pandémie. Mais pour ce qui est véritablement des conséquences immédiates de ce qui s'est passé, seuls les menteurs ont la réponse.
Jean-Baptiste, souhaitez-vous
peut-être, si on peut amener des éléments de perspective sur ce qui nous attend, c'est qu'effectivement, comme le disait Norbert Ifra, quand on prend l'image globale, on a retrouvé un niveau d'activité satisfaisant. On l'a retrouvé très vite, puisque les mesures qu'on a pu mettre en place ont permis, dès la deuxième vague, qu'il n'y ait pas de diminution des chirurgies à but curatif de cancer, ce qui est quand même le traitement principal pour donner des chances au départ dans le parcours. Donc ça, c'est un point extrêmement important. Maintenant, ce que l'on observe avec un petit peu plus de décalage et en commençant à analyser un petit peu mieux la situation, c'est que ce n'est pas équivalent pour toutes les localisations de cancer ou pour toutes les personnes. C'est d'ailleurs le cas dans d'autres pays. On en discutait encore récemment avec nos collègues allemands ou avec nos collègues québécois. Et la crainte, c'est qu'une partie de la population du fait de la pandémie, se soient plutôt intéressés à sa santé et soient plutôt allés consulter, et qu'une autre partie de la population soit encore dans le renoncement aux soins. Olivier Véran le pointait ce matin, certains comportements de prévention sont en train de changer dans le bon mais parfois dans le mauvais sens, et donc cette pandémie, c'est aussi l'occasion de nous réinterroger. Le groupe prévention l'a fait sur la question qui était débattue avec les collègues européens ces derniers jours, comment parler de santé, comment parler de prévention des cancers, comment parler de cet avenir après la pandémie, comment renouveler notre discours à cette occasion. Et c'est aussi quelque chose dont nous apprenons entre Européens, parce que nous avons été confrontés à des expériences différentes et nous pouvons en tirer bénéfice. Pareil sur l'organisation des soins. Le télésoin a pris une place tout à fait importante et qui peut permettre demain du télésoin aussi en Europe pour amener de l'expertise auprès des malades en transfrontalier. Donc la pandémie a fait du mal, mais elle nous apprend aussi beaucoup de choses et va nous permettre de capitaliser dans les mois qui viennent sur ces différentes actions.
Merci. Juste pour compléter, nous avons mis en ligne aujourd'hui le panorama des cancers en France, dans lequel vous trouverez une rubrique qui est dédiée à cancer et Covid, avec des chiffres notamment sur les XRS. Je vous propose de prendre la dernière question. Il nous reste une dizaine de minutes. C'est une question de Madame Céline Lisraou de Rose Magazine qui revient sur des traitements qui seraient dispensés hors AMM en Allemagne. Est-ce qu'on peut ouvrir le micro? Voilà, merci beaucoup. Je vous laisse poser votre question, Madame Lisraou.
Oui, bonjour professeur Ifra. Je me posais la question, en matière de coopération intra-européenne, il existe une zone d'ombre, il y a les cliniques, et notamment allemandes, qui proposent des traitements hors de tout AMM, alors la vaccinothérapie, mais aussi des immunos en dehors de leur indication, et des malades de toute l'Europe qui sont en échec thérapeutique achètent un peu de rêve, vont essayer et on les comprend bien, vont essayer de survivre en allant là-bas et se ruinent et finalement ne sont évidemment pas guéris, et pensent en général que parce que ça se passe en Allemagne, c'est sérieux. Des centaines de Françaises y vont, font des collectes et s'épuisent à faire des allers-retours pour l'Allemagne. Que peut-on faire pour qu'une vraie unité existe en matière de règles d'accès au traitement?
Alors, vous soulevez à juste titre une question très importante et pour laquelle nous sommes sollicités honnêtement plusieurs fois par mois, quand ce n'est pas plusieurs fois par semaine. Je vais laisser Jean-Baptiste compléter parce que très souvent c'est son équipe et lui-même qui sont en charge, mais il faut voir que les AMM sont européennes. Les autorisations de mise sur le marché sont européennes, qu'il y a eu une accélération considérable ces derniers mois, disons ces 18 derniers mois, du délai entre le moment où l'AMM était octroyé et le moment où le médicament était réellement disponible pour les malades. En France, il y a eu un moment où on a été très en avance, il y a eu un moment où on a été un peu en retard et on est en train de corriger ce retard. Et puis après, il y a malheureusement, vous l'avez très bien dit, Madame Raoux, ce qui est la part du rêve. Or, il se trouve que en Allemagne, en l'occurrence, puisque c'est de là qu'on a eu le plus de sollicitations, il y a un certain nombre... Les cliniques ont le droit, lorsque... il n'y a pas d'autorisation de mise sur le marché d'un médicament et qu'ils ont pu en avoir quand même par ailleurs, de le proposer. Alors là, on est véritablement dans une zone d'inconnu absolu où il n'y a pas de preuves, il y a des assertions, il y a souvent rien derrière ces assertions, et quelquefois des doses dont tout ce que nous savons laisse à penser qu'elles n'ont strictement aucune chance de marcher. Alors, vous savez, malheureusement, ces parts de rêve, on les connaît. On a eu malheureusement, il y a 4-5 ans, une clinique au Mexique qui proposait des traitements soi-disant magiques, incroyablement coûteux à titre individuel pour des enfants qui avaient des tumeurs du tronc cérébral et qui étaient en fin de vie. évidemment, on est dans l'indécence, quoi. Hein. Donc nous avons écrit aux autorités allemandes, l'agence du médicament française et nous-mêmes d'ailleurs avons écrit aux autorités allemandes pour attirer leur attention sur un certain nombre d'établissements qui, autorisés à traiter des cancers, à côté de procédures parfaitement normales, classiques, etc., avaient, je dirais, une offre parallèle qui ne répond à aucun des canons de sécurité du médicament, aucun des canons de la connaissance. Bon, voilà, quand on dit que l'Europe peut avancer, c'est aussi sur des actions comme ça. Hein. C'est pas seulement, même si c'est très important, sur des harmonisations de prix ou de taxes. Mais Jean-Baptiste, je t'en prie, affine ce que je viens de dire,
oui,
s'il te plaît.
Si on peut apporter un complément de Norbert, c'est peut-être justement le travail qu'on a fait ces 2 derniers jours. Et de se dire que dans le groupe où on travaillait sur les cancers de mauvais pronostic, et donc notamment ces femmes sont concernées pour beaucoup d'entre elles par des cancers du sein triple négatif au stade métastatique, avec un taux de survie à 5 ans qui est de l'ordre de 15% à peu près, hein, ce qui est moitié moins que les cancers du sein en général à ce même stade. Et donc effectivement, on comprend leur recherche désespérée de solutions. Elles ne sont pas les seules, et dans d'autres cancers de mauvais pronostic, nous avons en Europe un accès aux médicaments qui est inégal. Et ce que nous avons proposé dans le groupe, c'est justement de travailler sur cette question de l'accès précoce aux thérapeutiques innovantes, du délai de cet accès précoce et sur les mécanismes d'évaluation communs, puisque effectivement nous sommes plusieurs pays à avoir mis en place des solutions. Norbert, vous le disiez à l'instant, il y a des procédures en France maintenant pour l'accès précoce, y compris pour l'accès compassionnel aux médicaments dans des situations où justement on n'a pas toutes les connaissances, mais on va s'encadrer d'un maximum de règles de qualité et de sécurité pour ne pas être dans l'acharnement déraisonnable et ne pas faire de bêtises quand on traite des patients. Donc effectivement, ces règles, elles peuvent inspirer d'autres pays. Nous pouvons nous inspirer aussi de celles de nos voisins et essayer de construire ensemble quelque chose qui permette un accès égal aux médicaments dans l'Union européenne. C'est un des axes que nous avons travaillé et sur lequel nous espérons pouvoir proposer des éléments très concrets dans les mois qui viennent. Merci.
Madame Lisraou complète sa question en demandant qu'est-ce qu'on peut faire pour éviter les dérives au niveau européen.
Ce que Jean-Baptiste vient de dire, c'est essayer d'harmoniser ça entre nous au niveau européen et faire évoluer, pourquoi pas, la règle dans tel ou tel État qui permet à un établissement de soins de proposer quelque chose qui est, entre guillemets, de fabrication maison. Bon, ensuite c'est sûr que la démarche qui consiste à réussir par des circuits qu'on ne connaît pas à obtenir un médicament qui est en rupture de stock hors essai clinique partout ailleurs dans le monde et à le vendre 10 fois son prix, comment dire, en dehors de toute considération éthique et n'est pas quelque chose qu'on doit pouvoir encourager. Je pense que quand on dit qu'on veut faire l'Europe de la lutte contre le cancer, c'est pas en générant des inégalités de ce type, exclusivement basées sur les moyens financiers, soit de la personne, soit du réseau qu'elle arrive à constituer en urgence, qu'on va faire. Donc oui, ça fait partie, Jean-Baptiste l'a dit, de nos préoccupations. Oui, bien sûr.
Merci. Écoutez, nous n'avons plus de questions. Je vous propose de clôturer cette conférence de presse. Merci beaucoup d'avoir été avec nous à la fois en distanciel et en présentiel. Je vous rappelle que vous avez sur le site de l'Institut national du cancer le dossier de presse de ces rencontres européennes, ainsi que la déclaration politique et un document qui, en fait, vous donne l'ensemble des 32 actions qui ont été discutées dans le cadre de ces groupes de travail. Et nous terminons cet après-midi avec 2 tables rondes pour clôturer ces rencontres européennes. Merci beaucoup, bonne fin de journée.
Bonjour et bienvenue pour cette dernière partie de ces rencontres
Hello everyone and
européennes
welcome for
riches en
this
propositions,
last
riches en
session
perspectives
of
qui
the
s'ouvrent aussi. Dernière partie
2022
avec deux tables rondes
meetings,
qui
European
vont
meetings
adresser,
of cancer.
essayer
We are going
d'aller
to have
voir
two
mieux comment
roundtables
on peut
to
penser
look
des
into
actions
ways and
possibles communes et des
actions
synergies entre
that could be
ce que sont les
common,
politiques nationales,
synergies,
ce que sont
to
aussi
get to know
évidemment
more
les
about
opportunités
national
qu'offrent
policies, to know more about opportunities, what new European initiatives are.
C'est un enjeu majeur
That
et on va le voir lors de
is
cette première
actually
table ronde
very
en matière de
important
santé, en matière de
because
santé,
these new initiatives are very important for new progress. We have to fight today cancer, but also we have to work on risk prevention. We also have to work on the aftermath of cancer. We have to fight against tumors as well, and we've seen it in the past. We have to accompany, we have to support those that face cancers with bad prognosis, but also childhood cancers. That means that the treatment is wider and wider and more complex. This is why we need to have a community-level action. And this is why the measures that we introduced this morning could actually help us all. We will see how it will be possible to implement concrete actions under the aegis of this French presidency. And we'll talk about it right now with the different speakers. Thank you.
So,
I will introduce them briefly. We have Cecilia Haller. Hello, you're the Deputy Head of Division, Public Health and Healthcare Division at the Ministry of Health and Social Affairs in Sweden. We also have Vladimir Valek, you're Professor of Radiology, but also Minister of Health in the Czech Republic. We also have John Ryan, who was here yesterday for the masterclass, Deputy General Director at the DG Health and Food Security at the European Commission, and Mrs. Freid also, who's the President of the National Institute of Cancer. Before looking into details, I would like to know, what do you think about the proposals that were submitted this morning? The aim is to understand better the opportunities that might arise from the plan that we talked about yesterday.
And with that beating cancer plan you presented yesterday, you presented the scope of the plan, the agenda of the plan, and we know cancer has many challenges to come and to face. We viewed quite a lot of them in the today and yesterday, and this European plan is not the first one to come out of the box, I would say. You pointed yesterday, it's an unusual animal. Why is it important to have such a coordinated plan to face the challenges to come, and why does it need that of an unusual animal?
Well, I think it's an unusual animal. Thank you very much for the question, because it really tries to bring together many different initiatives, all of which go in the same direction. So it's not a public health plan, it goes beyond public health. I explained yesterday that there are many legislative changes, for example, carcinogenic substances in the workplace. We might think that the workplace is a safe place, but in fact there are many carcinogenic substances that people have to work with which cause cancer. Also, the tobacco legislation is something which we're trying to strengthen. The legislation on taxation of alcohol products as well. So there are many different individual elements which can contribute towards an improvement in cancer prevention and cancer care. I didn't talk yesterday about the Digital Health Initiative, but the Digital Health Initiative will answer many of the questions that have been raised in the statement here this morning and which we heard about this morning. All these questions about sharing of data, definition of whose data it is, and how you can develop the use of data across Europe by using digital tools. All of these questions are going to come up very soon in a new legislative proposal from the Commission. So, and that's part of the cancer plan. So it's really difficult to explain this to people who are not working in the environment, But what I'd like to emphasize is that it's a many-faceted approach. It really takes an all-of-government approach. And the real advantage of the plan is not alone bringing all these policy initiatives together, but that we have some money to put on the table. Now, usually the money does not accompany the ideas. Normally, there's a sort of a, somebody has a good idea, but maybe the money is not there at the time. We have the occasion of having the 7-year budget of the European Union coming at the same time as the cancer plan. And that's a real advantage. We've managed to put 4 billion euros to one side for the implementation of actions. And I think that's, so we have the ideas and we have some money and we have the contribution now from your groups this morning, which we'll try and incorporate.
To have this unusual animal fighting cancer at the European level, it was created, I would say, a bit before and during the COVID crisis, but are there some lessons out of the COVID crisis that emphasize the fact that it needs to be coordinated, facing cancer as it has been facing COVID?
Well, I think one of our lessons learned from the COVID outbreak was the fragile nature of our health systems. Even in big countries with well-developed health systems, we suddenly discovered how weak they were in an emergency situation. And we have, I think, learned the lesson that we need to reinvest in our health systems. Health systems are not a cost to the economy. They underpin and support the economy. Because we see today in many of our member states that if you don't have a good functioning health system, then the society can't operate. And it's the same for other types of condition like cancer, because our societies in Europe are getting older. We have a demographic challenge in Europe. We have a challenge of a tsunami of chronic diseases, including cancer. And if we don't work on prevention, if we don't work on strengthening of our health systems, in other words, investing in new medicinal products, in training of our healthcare workforce, then we won't be able to deal with this in the longer term, and we will weaken our economies and weaken our society.
One important thing about this plan also, and you told it yesterday, is that it's a really multi-stakeholder approach. I mean, you want to put in the boat as much people as they need to be, patients, politics, region, researcher, and so on. How are you going to, I would say, orchestrate the whole of this in the implementation? And too much people in the boat, isn't it a risk also for implementation to stay on the ground and not coming and not being effective at the end? Because too much consensus means no realization.
Well, I would say the political reception of the action plan has been very positive. I mean, the discussions we've had in the Council of Ministers in the European Parliament have been very positive. The feedback we have from stakeholders has been positive. The problem now is to translate something that's on paper, whatever it is, 20 pages of paper, into something real. And that's why, you know, we need to have that political engagement, because it's one thing the Commission's putting money on the table. It's quite another thing to change the situation on the ground. Of course, we can change legislation. That's what we're doing. We can implement changes in our policies, like the Common Agricultural Policy I was talking about yesterday. We can spend money from our programs, but it really involves engagement at national level. And before I finish, I'd just like to say there's a lot of negative feedback from other stakeholders, people who are working on cardiovascular, people who are working on diabetes, and they're saying, well, why can't we have a European plan on cardiovascular and diabetes? I think if you have a European plan on everything, then you have a European plan on nothing. So really you have to focus, and the cancer plan will in fact impact on many non-communicable diseases, because if we can improve people's health, improve health systems, sort out the digital health challenge, we will be helping many other disease conditions as well.
It's a modelization for participative action. It can be on for other diseases. Norbert Ifra, je voudrais
I would like to have your input, because we have a 10-year strategy now ongoing with 3 priorities, with numerous actions. How about this European dimension? What can you say about this? What does it bring? And what will be implemented? Well, Norbert Ifra says, whatever level at which the questions has been raised, we have had actually a very close answer. We see that the need is here. So that's one thing that's done. Then each of the countries, each of the states is doing everything they can to answer to these questions. Besides that, beyond the prerogatives of the EU, we also have the prerogatives of each state when they are starting to work together around the same objectives. And here we have a domino effect, which is very important. What do we see? We see that whatever the quality of what ladies and gentlemen of each country does, we have disparities every time. And they might come from an outdated legislation. It might come also from a tax law that is not fine-tuned as it should, and that could actually hamper the policy of the neighbor country. And so a common position, a common stance beyond the prerogatives of the EU actually are the guarantor of changing dimension, of upscaling our work, our strengths in the fight against cancer. We're not competing one against the other. We are going to be helping one another.
And it's quite an honor for us to have you in here. Czech Republic has a strong tradition of investment in cancer care. You have, you're one of the very first countries to have a national register for cancer in the world, not just in Europe. You have 18 complex oncology centers. You have HPV vaccination for children for quite some time, and a strong political also prevention, who might speak about it. Yet you stand as maybe what can figure like representative of the smaller country of Europe, I would say, comparing to France maybe. For smaller countries of Europe, how much of an opportunity is this kind of European plan? Is it an opportunity to reduce inequalities, to step ahead in some aspect of the care of cancer where they have less opportunity to have all the infrastructure needed? How much of an opportunity is it for these small countries?
Thank you for the question. You are right. The register and the screening programs are one of the oldest in the world, and it's working very well. The problem is that there are different ways in Europe how to do it. There are different register, different screening programs, and I am very happy that exists such an initiative and that start France cooperation and some idea to cooperate concerning these programs and to do something together concerning health in Europe. I think CERN is a good example. If exists cooperation, the European research could be extremely strong, powerful. And same problem is patients, cancer patients. Cancer is growing, number of patients is growing. There are problems with prevention. There are a lot of risk factors, different risk factors. And there are big differences between countries. If you compare, for example, two countries which are close together, Hungary and Czech Republic, in Hungary they do totally different system like in Czech. And it's necessary to have some expertise, it's necessary to have some support from Europe to compare this program, to compare quality of this program, because we have to offer to European population, to inhibitors, to children, a better future. and with top quality prevention, with lower number of risk factors, and with concentrated register, European register, it's impossible to do it. Without such a register, it's impossible to do some program. And what we expect as a Czech Republic, because our programs are good, we have very good working screening program, but without chance to compare the data, without standardization in Europe, we cannot expect any progress even in Czech. So therefore it's necessary for us also.
Same question maybe to Sweden and you, Cecilia. Sweden is also very implicated in cancer. I mean, the three countries are countries which are really fighting hard against cancer. 3% of your budget is going to research and development in health, not just in cancer, but that's huge. You have 21 regions, so it's a kind of mixed situation in Sweden. What can you expect? What are the opportunities of this European plan for a country like Sweden?
Thank you. To start with, Sweden has had a national cancer strategy for more than 10 years, and in the beginning we met the same arguments that why do you have a national cancer strategy, why don't you have it for a cardiovascular disease and so on. But they are quiet now because it's evident that you need a coherent strategy. Anyway, cancer has been a top priority, and we are, of course, very happy for the European cancer strategy. I think there are plenty of opportunities. As you say, Sweden is a small country, 10 million inhabitants, and many people live out in the countryside. So for us, it's evident that we need coordination and cooperation in a complicated field as cancer research and cancer care. We have excellent cancer research in Sweden, we have excellent cancer care, but for us, for Sweden as a small country, it's absolutely necessary with cooperation. So for us, this is very natural with the EU cancer plan.
Even cooperation in between, you're not just like, Vasim said, cooperation with countries, cooperation inside the country with the regions. This is something, a major issue for you. So we see that, on voit qu'il y a bien des enjeux différents.
So there are different issues that actually arise from one country to another. That's a dimension of the way we can actually have concerted action. We also have the proposals from these work groups, and I would like to have your insight on these groups. One of them was prevention, the other one was back to work committee. And the idea of creating this continuum of care that goes from risk prevention to the aftermath. We have to cure the sick, but also prevent the patients, prevent and warn the citizens, but also help those that have been cured. These are important issues. Norbert Ifra, that's one of the three main pillars, the follow-up after cancer and prevention. What is the gist of what was said this morning? And how about a common scale? What can it bring to these two issues? Because these are actually quite national issues, don't you think? Answer.
Quand on met en évidence ces deux questions, enfin ces deux sujets, et qu'on les sort, on voit qu'on est en plein dans la dimension sociétale du cancer.
Actually showing how much we're in this society. We're talking about society. It's not only technical or mechanical. We're talking about the society at large. We're trying to answer to society's issue here. From the beginning to the end, from prevention to supporting after cancer life and prevention of late effects. That's the message that is conveyed. As for prevention, I'm struck, I have to say, by extremes, because need seems to be the same. We could actually do a copy-paste, it seems, of the European beating cancer plan or the 10-year strategy or the other way around. It's actually the same issues that arise. And what we see also is that This subject is of concern for everyone, but we don't all have the same answers. Why? Because sometimes the incidences are not the same, we don't have the same customs, and sometimes, as well, there are issues that do not seem to have a solution in some countries and seem very easy in others. For instance, if we take the issues that we have in the country that I know best, namely when we talk about literacy, to bring to screening a certain group of people who have diseases, who are excluded from the rest, from those that have more facilities. We have some people who are coming from social, ethnical minorities. Probably, undoubtedly, these people are rare enough in this country for us not to understand the codes that enable us to reach them, to reach out to them and have access to them. It's not because there are not a lot of these people in one country of Europe that they are rare in all the countries of Europe. And this is why we can learn from the recipes that worked well in other countries. And we can circumvent these difficulties. This is why prevention is important. It's a subject on which working together in Europe, all together, hand in hand, can help us to overcome obstacles. Of course, it's a matter of trust as well. We've seen it with vaccination, for instance, during the pandemic. But notwithstanding all the foregoing, we have to convince. We have to overcome cultural reluctances. As when it comes to prevention, it's not all about culture. There's also the fact that we need to talk the same language and try to be audible. For cancer, it's the same. There are some countries which have progressed differently. There's a matter of legislation. We need social dialogue. This has been well said this morning. We need to have common messages. And we shouldn't reinvent the wheel. Some things have been found, and the good practices should be pooled so as not to lose time and to draw upon these good practices and move forward. As for the Return to Work initiative, in France, we worked with companies and they've made their own charter with us. So it's not only a lesson coming from a public entity saying, okay, this is the way it goes. We have people with their own culture that say we just have to apply it. That's a nonsensical. We were the chamber of registration, of dissemination of their thoughts and reflection. The work has been done. There's no reason to think that it cannot be replicated in other countries. And so we can draw upon these inputs.
The Czech Republic, in echoing to what Norbert Ifra said, you have a strong culture of prevention for years on this cancer issue. In vaccination and as an excellency, but not only in vaccination. What are the main challenges you face today to improve the prevention, to improve the avoidance of the risk exposures in the daily life of the Czech people, and how a European initiative or the proposal presented this morning can give you inspiration to act differently?
Thank you very much. Prevention is extremely important. I mean, everybody agree. But the prevention is not only screening program, because it's just only a small part of prevention. It is focused to cancer. There doesn't exist so many screening programs concerning other disease, even if diseases are extremely important. A very important part of prevention is generally good quality meal, There are a lot of children with celiac disease, intolerance, and some allergies, and this is also part of prevention. If the children have good quality of food in school and so on, then it is first step concerning the prevention. If there is a good quality diet focused to different disease, it's first step in prevention, and this prevention is in fact whole life process. And what is extremely interesting, the information here, how many part has the word prevention. Prevention is complex program, and it's necessary to do it as a complex program. It is not only healthcare system program, it is also education, it is school, it is different ministry, and it is very complex program. It is agriculture. We started, because I was, as a member of Czech Parliament, member of Agriculture Committee, my responsibility was wine law. So I was expert concerning this law. And we started to discuss how to improve according some indexes. France is very strong concerning food indexes, not only Danone, but different indexes, how to use these indexes concerning the prevention, how to change generally the strategy. We started to discuss between 3 ministries, and now we want to introduce a program where will be part healthcare concerning diet in the school and so on, concerning support of small producers, this how to say yeah, and how to support with health insure companies. And I think this is part of prevention, and this complexity here is very important for us. This is my home take message from this meeting. It must be more complex as I could imagine before.
More complex, and I would say, and go to John Ryan on this, also in a way more simple. Because in prevention, one of the interesting things in the European plan is that it tried on prevention to address many fields, but it tried to address many fields through one point, which is the patient. There's the smart card for the survivorship, there's a digital patient center, so prevention and support comes from the patient first. Is this something that giving more autonomy to the patients in the way he might be sharing his risk, in the way he will share his life, sharing his data, something very important in the plan to address differently prevention? And just one clue, how will work, that was a question addressed yesterday, this smart card, it's very intriguant for many people.
Yeah, no, I'm sure it's very intriguing for a lot of people, and I would say it's an idea which did not come from the Commission for once. It was something which came from the patient community. It was actually based on an Italian experience, an Italian model. So the idea is really to allow the patient to have much more interactive access to their results, access to their data, and also access to health professionals and to organizations who can perhaps support them in the survival period, because most patients, cancer patients, survive, you know, and at least in the first few years it might be important for the patient to feel accompanied, particularly as we were saying this morning with issues around, you know, their employment possibilities, their insurance, all that sort of thing. So we're not actually setting out a directive or a regulation on this smart card and what it should look like. It's very much co-creation, I would say, with the patient community, with the health professionals, in order to see what would be useful. I would not consider it useful to sign a contract and give somebody 20 million euros and then it's solved, you know. It has to be something that's designed together. And making use of the digital health initiative, which I mentioned is coming this year, this will enable a much greater sharing of data, of patients' data, with their consent. Huh? So these are all questions which are still in the mix, as we say. Cake is not yet baked, but at least we have identified this as being an area of work where we need to.
But is it through this initiative, through the Patient Digital Center, a different way to address support and prevention with the patient and from the patient also?
Yeah, I think the prevention tools and prevention support is something different because we're talking about patient data and patient smart cards, whereas prevention is really something before you become a patient, I would say. And I was very struck by what the Minister was saying this morning. I agree with him 100%. I think putting a label on something and then forgetting about the problem is not the way forward. I am actually very impressed when I see kids in the street protesting to fight against climate change. I'm very impressed with the engagement of young people around Europe when I see them marching and staying off school. I'm not sure if they should stay off school, but anyway, they're really engaged politically for climate change. And that shows that, you know, a certain group in the population have really become sensitive to the future of the planet. What I'm saying is, for me, a success would be if we could convince people that they should be concerned about their own health, and they should be asking us to do something on their own health, on cancer, on cardiovascular disease, on other diseases. And, you know, the experience with COVID, I think, is really instructive because a lot of people are accepting the public health measures, but a lot of people are not accepting the public health measures. So I think we've got to be careful and learn the lessons for the future of the cancer plan, that it's not us giving instructions to people, but people have to take ownership of their health, ownership of their own prevention, as well as whatever we can do at the government level. You see what I mean?
Cecilia, in Sweden you have a prevention issue, major prevention issue on alcohol, on tobacco, and try to fight a lot. Like Olivier Véran said this morning, we have to reload the prevention tools because they're not working if we keep on doing the same thing. What is the vision in Sweden of that, and do you try to have new initiatives to address these prevention issues?
Well, this is, I think this is one of the most...
We don't know it's working, but you have to put the mic, I guess it's working, but you have to put the mic close to the, close to you.
Now it's better?
Yeah,
yes.
That's better.
Well, prevention is about behavioral change, so I think it's extremely complicated challenge. We are working hard with non-smoking campaigns, less drinking, alcohol, obesity, physical activity, but as you said, John, it's not particularly for cancer, of course, it's for many diseases. So I don't think we have solved this challenge in Sweden, but we're definitely giving it high priority and working on it.
Back to French.
Another strong challenge that comes out of the proposals of this morning is the support of risk and life with cancer, and also taking into account what is the fight against the disease today. For a long time it was a fight against a few tumors, and now we are going towards precision medicine, and so behind these big tumors we have many individual cases we'll have to treat. And then we have poor prognosis cancers, pediatric cancer, that are each time situations we have to take into account in a more individualized manner without leaving these patients aside from the healthcare system. We have to treat them and ensure their quality of life, ensure treatment, and it's difficult to address the diversity of these situations and of these care.
Wants to be active through platform, through network, like the UNCAN, like the cancer imaging initiatives. You want to try to address the different figures of cancer and different figures of the fight against cancer, whether it's reluctant or non-reluctant. How such network could boost the development of new pathways to this reluctant, this pediatric cancer, where it's so difficult to open the door, I would say.
Well, under the Cross-Border Healthcare Directive, which was adopted a couple of years ago, we tried to find ways to help countries to cooperate in healthcare. And one of the initiatives I'd like to mention here is the European reference networks, which actually bring together groups of doctors and hospitals, not ministries, but doctors and hospitals, on a specific disease. And we have just extended this network quite considerably. So it's supported financially from the European budget, And it's voluntary, so it's the hospitals who want to who participate. And I must say, one of the biggest complaints is we don't give them enough money, because this is on top of their normal work, and our support is rather economical, shall we say. So I think in the future we may have to consider how we can invest more to support this on the long term. But I know that the results of this type of networking is very good. Also in the area of rare diseases, there's a huge added value to countries working together. Not so much countries, but organizations and health professionals working together. And this can also be of benefit, for example, on screening, because we already have networks on cancer screening in different areas, colorectal, cervical, breast cancer screening. And the fact that people can talk to each other, the Swedish can give their experience, the French can say what worked in France. This is very much the networking that we like to support, and not sort of imposing a solution through a regulation, but allowing people to talk. And then when there is consensus, we can transform that into a recommendation, for example. That's the way it works.
Yeah, you create places for intelligence and expertise to meet, and not solutions, but that they will create the solution in these places. Cecilia, what inspired you in the proposal from the pediatric group and from the Poor Prognosis group? I know you were quite sensible to what was said in this group this morning. How does it echo to the Swedish situation you might have and the difficulty you have to face this type of cancers?
Yeah, you're right. This is, I think, it's very significant for the
If
Swedish.
you can put the mic closer.
Sorry, I forget. And also I have this shield. No, but it's a part that we are very engaged in, because it deals with the data, that we have to gather data that many of us have been talking about here. We have also the new techniques, I would say. So we have great expectations in the new possibilities, that the development of new technologies, and in genetics, and also in data science and fields like that. We hope that this development will help us to be better in early detection, and will help us, or maybe force us to approach diagnostics, treatments, reimbursement in other ways, because of what it will bring to us and to do with diagnostics and care, actually. So I would say the new technologies in genetics and data science will mean a lot for these fields, especially.
Yeah, and you have a big expertise center in Sweden on these fields. In Czech Republic, Vaslimil, it might sound complicated for countries, I would say smaller countries, but this is not, I mean, you sorry for that, but you understand what I mean, actually, where the infrastructure are less important, actually, even though you have 18 centers dedicated to cancer in Czech Republic, which is quite a network, actually. But to have the structure to do the research and to do the caring for people who suffer from this pediatric cancer, from this poor prognosis cancer. Gilles Vassal told this morning how much clinical trials for pediatric cancer are important, and sometimes you have to travel a long way to get to the clinical trials and to find a good doctor and the good medicines. What difficulty do you face in countries like yours to address these issues of poor prognostic or pediatric cancers? And what can you expect from collaborative actions for the other countries?
Pediatric cancer, or children with cancer, it is very, very painful issue. There are parents, there are expectancy, and to treat children, it's not easy way. And the children expect longer survival, like old people. Quality of life is extremely important issue when we discuss about children with cancer, and there is many social factors and psychological factors. So there are two big centers in Czech, in Prague, in Brno. My friend, Professor Sterba, is chief of this. I am radiologist in this department. And there are I think two expectancy and two issues. First, not all studies are available in small countries. In Czech are not available, for example, any genetic studies. It is necessary to open door to each country, even small European country, for each study, because we are responsible as politicians to offer to our children in Europe chance to be part of each European study, even if they are living in small city, in small country. The second problem, some rare tumor, as you mentioned, are really rare. Typical example could be some kind of eye tumors, melanoma, and there are only a few centers where can they do chemoembolization of this tumor. Doesn't exist in Czech. We started.
Doesn't at all.
It's not available because there are only a few tumors, and it's necessary to be very skilled. You must concentrate patients. It's necessary to have a lot of patients if you want to have good quality result. It's related to interventional radiology, it's related to surgery. So I think we have to open door for each European child in these centers. The rule must be same, even if you are living in small European country, because we are Europe. We are not Czech, France, Germany, Hungary. We are Europe. And we must step by step build Europe and slowly open door. It's not easy way, but slowly open door, for example, for children with rare tumor, for example, for children with
Does it mean that we need to put centers in all the countries?
No,
for that?
But must be easier if you want to send these children to such a center. Must be easy to get information where is such a center, where you can treat such a patient with very rare disease. And I think it starts to do European Union, it starts to do Commission. And it's necessary to say thank you very much. And this is what I expect in the future.
John Ryan, maybe one word about what was said and how the comprehensive center can answer that also.
Yes, well, the idea of the comprehensive cancer centers, again, might not make sense for countries with well-organized, well-resourced health systems. But there are 27 member states, and we know the differences in life expectancy and mortality, morbidity across Europe is hugely different. I think we were talking about that earlier. So there is a problem, not only at the differences on prevention, there are differences in early detection, and there are differences in treatment. So anything we can develop as part of the action plan, as part of the cancer mission of the research program, to try and identify ways of helping to reduce these differences is really important. One of the points I did not mention so far is the Inequalities Registry, which was launched on Tuesday this week. And this is something developed by our joint research centre in the Commission. But the idea is to try and put on screen, in front of every citizen, the differences in life expectancy and in treatment that they can expect with different cancers. Now, it may be there somewhere already, I'm sure it is there somewhere already, but the idea was to call it a Cancer Inequalities Registry and to try and use that as a tool for investment then in the coming years, to invest in the things that need fixing. Yeah? So linking the inequalities that we've identified, the gaps, with the investment plan, I think makes sense.
Implementation towards inequalities. Norbert Ifra, d'un mot en regard à ce qui a été dit sur ces enjeux de...
Norbert Ifra, regarding these issues of pediatric cancer and poor prognosis cancers, when you need to have actions that are more and more targeted, expertise that are more and more specialized, and we know that can be difficult. There are initiatives that are implemented within the European plan. It has also been supported by the proposal of this morning. First point, what do you take away from the proposals made this morning around these topics, pediatric cancers and poor prognosis cancers? And after that, how is it possible at the European level to give more echo, more political support to all the networks of researchers, doctors, countries who exist and work hard in this field to work together, but who in the end end up reaching a limit in their exercise? Answer from Norbert Ifra. Well, it's a great question. First of all, I would like to say that I totally support what has been said regarding pediatric cancers by Gilles this morning. Then it is urgent to do a pediatric exception because we should not have any blocking of the insurance, administrative or financial type to have studies carried out for these young patients. It's not acceptable. I strongly believe that we know that when we are in Europe, we are in models that are not exactly overlappable. And when we design a European trial, at some point in time, there's the problem of funding the drug. And at that point in time, we have countries that are able to do, others that aren't able. So, but if we're not together, we don't have the critical mass required to correctly answer the question. So, of course, we don't have to blame the industrial companies, but these are topics that are not really interesting for them. So we must be passionate about these topics. We must be called upon. And for that, Europe has to build a pediatric exception to make sure that whatever the insurance system, it's not a barrier to carrying out a trial on children, especially regarding these cancers that are of poor prognosis, because we add a difficulty upon another difficulty. For years, we've had progress by looking at what was bringing patients together. We've seen progress and we see a plateau because there are things that differentiate them. Regarding what differentiates them, we add rare on rare. So, of course, if we don't have the critical mass, it's useless to start working. It's a lot of paperwork, but not any benefit for the patients and their parents. So if we don't have this pediatric exception, we won't move forward. And objectively, when we look at the price of drugs, which is always in milligram per kilogram, it's not a topic. So we need a political will. And Europe is fully on its mission. As regards poor prognosis cancers outside of pediatric cancers, so what I say won't solve all problems. Some are difficult to access, so there's a great need for research where we are failing. It's not a problem of goodwill or of skills on what exists. We need research, and this is why it has been decided that we have to do high-risk, high-gain research. It's not a high risk for the patients, it's a scientific risk. So we try to move faster, to move from a concept with arguments to a trial as fast as possible, because time is what is lacking for children and patients. When we are out of the children's issue and we're talking about the other poor prognosis cancers, one thing has been said very clearly several times. It's that the minimum is to disseminate the best standards for all patients, because moving from 5 to 10% is nothing, well, except if you're between the 5 and 10%. If you're between these two thresholds of the patients who will be cured, you don't say it's irrelevant. But most of all, what has made the shift from 5 to 10% makes us think about regarding the practices we had. So there's a comprehensive improvement of what we can do to put it at the maximum with the people who know the best the topic, who work in network and who sometimes are competitors but also friend. And then there's also what remains to be discovered. And here we are in Europe of research, not in Europe of fight against cancer. We are really in Europe of research. Something we'll never repeat enough is that when we do basic research is to be cognitive, to learn something, and we never know what it will be used for. It's by working on plants that we understood what non-coding parts of DNA were used for. We thought it was they were useless. We were just well thinking it was biological plant biology, but it was not. So we have to stop being exclusively finalistic when we embark on a research and look at 5 years, like NRA messenger. I just said so recently. Volt, Jacob, and Monod, Nobel Prize 64, used in different fields and for the good of the population after 2020. So here it's true societal issues regarding research and also research on cancer. Yes, we are failing on poor prognosis cancers. Yes, we need disruptive solutions. We need Europe to help us making people coming from different fields work together around these topics where we are failing. Regis says, yes, we'll talk about that during the next roundtable regarding research. Norbert Ifra, when you talk about poor prognosis cancers, it's not that the doctors are not good, it's that knowledge is not enough. When knowledge is insufficient, then we can start research. Regis, I would like to take the 10 remaining minutes to have questions from the audience and from the connected audience. Raise your hand in the room or write a question in the chat and we'll give you either a microphone or the floor. And various speakers can answer. You can ask questions in French or in English and it will be translated. No problem with that. And I ask the password for the MacBook. It's a technical detail, otherwise I can't have access to the comments that are being made online. So if there are questions or comments from the room, don't hesitate to... okay, I have the passwords now. So I have a lot of questions that have already been sent by the online audience. How can we fund new digital innovations within the framework of fight against cancer? Is there a part dedicated to that within the European plan, John?
Digital innovations, and not innovation with the digital ways and solutions, but digital innovation themselves and technologies associated in the European plan.
So in the current cycle of the Commission, there are a number of flagship projects. Cancer is one of them, but another one is Digital Europe, and that has a sub-chapter on digital health. Digital health, which we're proposing at the moment, will be legislative. In other words, we'll be proposing legislative changes to improve the collection and exchange of data on health. But more generally, there's a Digital Europe program, which includes a whole series of initiatives for benefiting society with the new IT possibilities. And of course, many of these apply in health. So there is a budget actually attached to the Digital Europe program. And also in the research program, there is also a component relating to improvement of IT and digital applications. So I would say there are many possibilities there. I would just say that as part of the Recovery and Resilience Fund, which was launched after COVID, well, we're not finished with COVID, of course, but it was launched during the COVID outbreak. This was a way to try and help countries build back better from the COVID experience. And I might just say that so far, the member states have asked for 8 billion euros in funding for investing in their health systems. So I told you that the cancer plan has reserved 4 billion euros in total for the entire cancer plan, but through the Resilience Fund, 8 billion euros have been taken and used often for digital improvements in infrastructure, for example. So there are many, many different funding sources there that can be used if countries organize themselves in time to benefit, you know.
There's a question about, I don't know the word in English, une question au sujet de l'Europe ultra-périphérique.
A question regarding ultra-peripheral Europe, including French overseas territories as a flagrant inequity to access innovation. Are there actions to be implemented through Europe to work on these inequalities in these territories that are ultra-peripheral territories? It's a lot for France and overseas territories, but Portugal has also such territories, and other countries in Europe have such types of territories.
Still to you, John.
Yes, in fact, there is actually a focus in Europe on ultra-periphery societies, and we have a strategy which is coming out in the coming weeks, specifically focusing on this. And one of the challenges we had was, how do you develop initiatives for those regions when they are not normally part of our discussion? So we don't normally have participants from the dom-tom, for example, in our meetings, and therefore we don't know what their specific needs are. We deal normally with Paris or Berlin or Prague, but we don't normally have this daily contact with the regions and with the islands, by the way, because they have their own specific needs. So this is why the Commission is developing a policy, and we're trying to find ways to encourage these regions to become more active and to use the tools which we have at European Union level to try and improve the level of their health, for example.
There's a question that might be maybe occurring to addressing our Swedish and Czech guests is, do you have already a vision of the 2 or 3 priorities you want to have for your presidency on this cancer issue, each of you? Yes, you and Sweden. Specific priority out of what's going to be done by the other ones, I guess.
I am happy that I can say that we want to continue France priorities, because oncology is extremely important issue. And as you know, young Gregor Mendel is from my city, from Brno, and so part of this priority will be genetic. And I mean genetic drugs, treatment, genetic studies, related not only to oncology. I think it is extremely important issue. Second issue is general COVID, and we want to focus to changes mainly concerning long-term COVID, concerning some side effect like endovascular changes, like children COVID, like heart, and psychologic and neurologic aspect after COVID, because there is growing number of complications related to neurology and to psychology, and your Minister of Health is neurologist, so and these are 2 main issues. Also, we want, as a number 3 issue, discuss about general cooperation in Europe concerning new drug strategy. I think it's necessary to discuss. We can develop molecule in Europe, but we are, according to my experience, not effectively produce European drugs related to personal medicine. So that issue is also very important. And I hope we will discuss with colleagues from Sweden that it's necessary to continue. I think half year is not enough to do some deep changes. So therefore must be very close relationship and very close cooperation between countries. And I'm very happy that exists such a relationship and cooperation with France presidency, and we can continue these ideas in Czech, and I hope we will get support in Sweden also. Thank you.
Yes, and for Sweden, Sweden is the last one on the trio, so you have more time to fix out the priorities yet.
Yes, no, but very short. We haven't set the priorities yet, but a wild guess would not be that equality will be on the agenda, because equality in cancer care is important for our government, and the different aspects of equality in cancer care.
Oh, Thanks a lot. And thanks to you for this moment of sharing and debates and discussions and enlightenment. We can applaud our guests. Nous pouvons applaudir nos invités. I'll let you join the audience as we're going to do the next debate on research. And thanks a lot. And the next participant might come and join for the next debates as I shall present the theme and the problematics. Merci beaucoup à vous. Thanks a lot to you all.
Thank you, everyone.
Je le dis, donc, un des grands atouts de cette initiative européenne engagée, c'est de promouvoir des politiques de soins plus importantes, plus concertées, plus vastes en matière de cancérologie, mais aussi de porter, et c'est un aspect très important, une signature de ces initiatives-là, une dynamique de recherche forte. Ces dynamiques de recherche, elles sont nombreuses aujourd'hui en cancérologie. Elles franchissent volontiers les frontières des États et des réseaux internationaux secrets beaucoup. C'est aussi aujourd'hui de plus en plus une recherche intégrative. Le cancer a été un modèle de recherche intégrative. Sauf qu'aujourd'hui, cette recherche intégrative doit intégrer des paramètres de plus en plus nombreux, des champs d'expertise de plus en plus nombreux, et ça rend justement à la fois cette recherche intégrative plus difficile à mener, plus difficile à implémenter sur le terrain, et aussi c'est une recherche qui va être de plus en plus multicentrique, avec de plus en plus de centres, avec de plus en plus de cohortes qui doivent aller se chercher dans différents pays. Et là aussi, la in the different countries, and this is why this is difficult to implement. Europe and European policy can actually help with this. This is why we're going to talk about it in a roundtable. We're going to have Joanna Drake, we're going to have Marek Svoboda, and we should have also Claire Giry and Madeleine Durbadjat, who are with us. And a round of applause. Alors, je vous présente rapidement
I would like to introduce Joanna Drake, who was here yesterday, Deputy Director General at DG Research and Innovation at the European Commission. We also have Mrs. Elisabeth Weiderpass, who's Director of the International Agency for Research on Cancer, dedicated entity from the World Health Assembly. When we also have the Director General for Research and Innovation in General Director of the Maastricht Memorial Cancer Institute in Czech Republic with Franz Marek Svoboda. And we should have online Madeleine. Hello, Madeleine.
Hello, with the Swedish flag from Durbadjat. Vous êtes directrice générale du Conseil de la Recherche.
So you're the Swedish Research
pour la médecine et la santé, le Conseil de la Recherche.
At the research, as the Swedish Research Council, you're the Secretary General for Medicine and Health. You are working on the priority actions. You're also a researcher, not on cancer, but on muscular dystrophies. You've done an outstanding job in the field. And then we also have Mrs. Giry. Are we online? From the Minister of the French Minister of Research. I'm asking Cap Canaveral.
Alors moi, je suis bien connectée.
I'm online.
On vous entend, mais on ne vous voit pas.
We hear you, but we don't see you. Yes, we do.
Voilà, moi je vous entends. Bonjour à tous.
Directrice générale de la Recherche et de l'Innovation, ministère de la Recherche, de l'Enseignement supérieur et de l'Innovation.
You're Health Claire Giry, Director General for Research and Innovation at the French Ministry for Higher Education, Research and Innovation.
The proposal of the morning, try to have an overview about what shall be the real inputs of the current European initiative. Was mainly the plan. This in the first roundtable is going to be mainly the mission on this roundtable. The mission created is a huge new thing coming on cancer research. Yet one could say, well, there was Horizon Europe, there was EU for Health, and both were financing cancer research projects. So what's so new, and what are the new challenges in field of research in cancer that needs such a dedicated place like a mission like this? With the mic.
Thank you very much for that question. Well, I think the whole concept of the mission is new. So let's start from there. But of course, within it are the elements that you are looking for. And what you're looking for is that the approach towards identifying the global challenges and therefore how to tackle them through research and through innovation, but with an emphasis on bringing about the societal transformations, the societal changes, and also the impact that we need to see more. But of course, you might say, but aren't we tackling all challenges like this? Yes, it's true. But as European institutions, we had to work together with the member states, together with the citizens, together with the stakeholders, in order to bring about this value, this added value. And the added value lies in the fact that, first of all, we had to find something that, a goal, first of all, which is measurable, and which one state or region, no matter the financial research, innovation, resources, and capacity, cannot reach by itself. So this is the goal. This is why we have set 3 million lives to be improved by 2030. The emphasis, what are we tackling? We are tackling what we think we could do better together. The understanding of cancer, the prevention, the diagnosis, the treatment, the type of care, the inequalities, and maybe also the data. And therefore, the digital part is really an important, is really important. Why? Because, as I said yesterday, there's a lot of obstacles that come in the way, not to allow us, even between researchers, between the people who have been treating cancer and researching it all their lives and over centuries, but not really having had a picture which could actually help the knowledge inform the policymakers better. So in this way, if you look even at the way that we are encouraging that the different instruments, different funds, even from within the European Union, but also together with the programs that the member states might have in their respective budgets, in their respective priorities, financial priorities at the national level, we are saying that there should be synergies between this. And therefore, this would call also, by nature, by definition rather, a combined governance, doing it together. Now, of course, the challenge is in the how and the when this is going to be seen to be done. And this is exactly what we are facing right now in the implementation itself.
It means that your DG research, and you're going to knock at the door of the other DGs saying, do you have something on cancer and research we can try to make together? This is going to be tricky.
I can assure you we're doing it right now. And I am one of the persons within my own DG which is responsible for this. So I can assure you it is happening. It is not an easy subject. Because by nature, let's face it, I mean, this is how the whole structures have been built over the years, and this is natural, it's nothing to be ashamed of, that everybody have their own budget and they look after it and they make sure they spend it. But not necessarily to create hooks with other ministries or with other DGs in our case, to actually create hooks and interlinkages in the calls for proposals and the applications. And this is exactly how we are working right now. It is not easy, because sometimes you feel you are, you know, like Sisyphus trying to put that rock up that mountain. But it does happen. And I think it takes 1 or 2 or 3 good examples to be followed, which will then become the culture. So this is also happening. The other important novelty, I think, is the citizens' engagement. And I think this is really important as well, because, and we have to be careful what we mean by engagement. It does engagement. I had an interesting discussion yesterday with Claire. I think she's here with, not Claire, yeah, that's it. And we're saying, but what does it mean to engage? And engage doesn't mean just consultation. I think engagement means really something ongoing, really, you know, an idea of having the citizens actually being part of the policy formulation and the policy influence and the methodology influence. And also, I mean, if we look at the digital side, which I said is also the other novelty, how we're going to use digital tools to give us a better picture. You know, patients need to be also proactive for instance, in the digital register for cancer patients, to actually put their data there and to want to share it also with other professionals and with other parts of Europe. So I think all of this, plus the fact that even internally, and yesterday John and I were talking about how the Europe Beating Cancer Plan and the mission were actually conceived and created together with a symbiotic relationship. So from the mission side, we shall inform the policymakers with evidence, with knowledge, with competencies. And of course, from the policymaking side, they will inform us with, what's the best policy ways or what are the options going forward. And I think this is also a good way of doing it. Again, it has not been charted territory, it is uncharted, but I think it is about time that we actually find a better way.
It means that it has to be moved on both sides. One side is the ones who give the money, who wants to promote the research. The other side are the researchers themselves also, and that was a question said this morning. They also have to make their move to have a larger view of the research subjects they want to address. That is not just the subject of cancer, but cancer and other issues engage. They also have to enlarge the spectrum of what they want to do. Is this something that you can address them? It's part of their responsibilities also.
Absolutely, and I said this yesterday as well, and I repeat the message as well vis-à-vis not only the researchers, by the way, who needs to be not only the ones who are proposing which are the subject, but also by listening from the policymakers, from the patients, from the stakeholders, from the administrators, who are actually doing the actual treatment and, who are actually taking certain decisions on the governance side, for instance, to listen to them as well and to see, what would be also wise and urgent, to research. But my message would also be the proactive part should also be very much from the member states and from the governments, from the different authorities, not only at the national level or federal level, but also at the regional and local, because this is a very local thing. It could be a very local thing. So I would say my appeal would be the proactivity needs to be also very much us working together, us being the EU institutions, all of us with the member states at linked up at different levels, and not only at the top level, very much bottom up.
Elisabetta, I would like to have your vision regard on this mission initiatives. You've been following cancer policies and cancer policies in research for long years, so you are a good observer of these policies. What's new, what's promising for you in that mission that was not existing previously?
It's a new concept.
It shall be working usually. Try it again.
Okay,
it doesn't sound to be working so much actually. Yes. Est-ce qu'on pourrait avoir un autre, voilà, où on a un micro qui va pas bien.
Could we have another mic? So the mission is a new concept altogether. Ouais. It's not only research, it's not only implementation, it's not only contact with civil society and patient organizations, it's all combined. And really the aim is to save lives or to protect lives and to improve the quality overall of the cancer, let's call it the cancer situation in Europe within a time limited of 7 years, which is the mandate that the mission has, and within a scope very concrete. So I think I'm here not alone, thankfully. I'm really surrounded by people that worked in the mission. I have Professor Ricciardi, I have a Professor Ciomieni, I have a Professor Ruth on pediatrics, and I have my colleagues from the committee. We worked daily for 2 years to conceptualize this. And actually, it removed us from the board, from our comfort zone. Most of us were scientists working in our labs, on your research centers, and we really needed to go beyond that and say, what will change the incidence and mortality curve within a certain time frame. So it's really, I think, a totally new concept for us in Europe, how it works.
The research needs to enlarge its vision to address new subjects, more subjects to implement. We'll speak about this. it needs also to address more actors, and actors, state members actors, not just for always the same to do the research. Is it also a goal, and is it, how can this research program as a mission can also try to fight against this different, not well-balanced and unequal approach, beneficial approach of research?
Yeah, the mission is broad. So when we conceptualized the European Cancer Mission, we thought it as a house with a very solid foundation, which is understanding better the determinants of cancer, the causes of cancer, the mechanisms of cancer, and how from prevent to diagnose to treat to support survivors and so on and so forth. And then we idealized the pillars of the mission, which would be prevent what's preventable, diagnose early and provide adequate treatment, and then survivorship. And all of this under an equality roof, or a decrease in inequalities concept. And in all these pillars, and in the fundament, and in the inequalities, the involvement of civil society and patient organizations is absolutely fundamental. So our conclusion was it would make no sense to propose another research program within the European Union unless patients and civil society would be with us from day zero, integrating and incorporating their ideas and suggestions in the whole mission.
Je voudrais prolonger ce qu'on dit en
donnant écho aussi à ces propositions de ce matin. By talking about the proposals of this morning, and in terms of research, there were several issues that were raised, including a multidisciplinary approach. We often talk about integrated research with progress, with patients, and we've seen that with the progress of diseases, with more and more inequalities, with changes in behavior, with molecular screening, for instance, this integrative approach is more and more difficult. The aim is to try to have new horizons, to widen up our scope for research. As Angelique has said it, it's important to have a social dimension for life before and after cancer, but also this was mentioned when we said that we have to get out of the concept to widen up the scope of research, to be more, to open up, and to have a multidisciplinary approach in terms of good or bad prognosis.
Is, I would say, the common thing in between all this. You promoted a lot through the YARED. How such an implementation issue means reloading the research approach and the research program ongoing. How can implementation be more present from conception to evaluation?
So implementation and implementation research is not something new, but is something that us, within the mission board and within the colleagues working in the commission, we decided to give a new light and to demonstrate and to put in written, in black and white, how important we think this is. So let's give a very concrete example. Tobacco. We have known of the malefices of tobacco for over 70 years. We are still struggling with decreasing tobacco consumption in the population. Human papillomavirus. We have in this room today one of the biggest human papillomavirus researchers of our generation, Dr. Dionne there. We discovered the vaccine already a decade ago. And if you look at the rates of vaccination against human papillomavirus here in France, it's very low. It's, I would say, shamefully low. So we need to decrease the time between the scientific discovery, the industrial valorization and development of products, and then implementation on the ground. For COVID, the humanity and Europe play a very important role, managed to do this extremely fast. So we need to bring these innovations and implement them faster and faster for the benefit of population and patients. So implementation research as a concept has a tremendous role to play. So how we do faster, how we reach populations faster to implement what we already know, and we know a lot. Because when we say and we publish that we can prevent something between 30 and 50% of all cancers today, it's true. So why we are not doing it? We are not implementing on the ground enough what we already know. So we need to do that and then to discover the causes of cancer and how to detect it early and how to treat well and also implement it much, much faster as we did in the case of COVID.
There's one thing that is quite viewed now on as a possible magic wand to this implementation issue. It's the comprehensive center, because they will be the place for researcher and they will be the place for doctors, both coming just near the patient to bring to the patient the best of research and translated in the best of care. This is a great idea, and as many great ideas, implementation is a great question to it, actually. How is it going to be done on the ground? What shall be the key of success for this comprehensive center to be plainly integrative center between research and health? This is for you, Joanna. Well, with the mic, always.
I can start with what has been established as a milestone in the implementation plan. The implementation plan says that, and both of the mission and the European Beating Cancer, and I quote, that 90% of eligible cancer patients have access to comprehensive cancer infrastructures by 2030 throughout Europe. So that's quite high. We're talking about 90% by 2030. I mean, it's already like in 8 years. And maybe if you're wondering what what the comprehensive cancer infrastructures are, again, there's a definition which is very holistic. It says national or regional infrastructures that provide resources and services to support, improve, and integrate cancer care, research, training of care professionals, and education for cancer patients, survivors, and families carers. So very broad, as you could see. But I think what is really the key, I would say, defining profile of this is that we're emphasizing high quality care and trying to reach that high quality care. Again, we are not saying that there is no high quality care. This is not what we are saying, and that only we have the answer. What we are saying is that we shall strive to have at least a minimum of what we consider to be high quality everywhere. Why? Because inequalities, as Elizabeth was saying as well, is still very much part and parcel, unfortunately, of the profile of cancer care, access to care, access to preventive treatment, to screening, to diagnosis, to knowledge, whatever. So these inequalities, I don't think are acceptable anymore. I don't think we should accept them. And I think we should, as Europeans, want to make it our own mission that we use our resources to the best and stretch them to the extent that they are actually, easily accessible across the board. At least, within a certain ceiling. Then, of course, there's always room for more specialized, more care, more cure. But we have to have at least access to this. Now, again, I say 90%. How are we going to make it? Well, again, the first step would be a capacity building program with the member states and with the support of the member states and also the associated countries in improving or even creating, in some cases, a comprehensive cancer infrastructure. And I have to say that in some member states, this has already started. They are using, as I think also John was mentioning earlier, part of their Resilience and Recovery Fund, for instance, which is the fund that the EU created, when COVID hit, and of course the economies went berserk, for all member states. And as you know, there was a big pot of money, the greatest ever, including money from the market, again, a blending effort, EU money with money from the market, borrowed by the EU in order to help the member states leverage back and bouncing back better. Part of that bouncing back better formula, some member states used it also for this, meaning that they also had already identified, and I have to say, sometimes also with the help of the EU Commission, suggesting to the member states in what is called, we have many funny names within the EU for very good exercises, by the way, but when the people out there know the labels, they say, what are they talking about? But for instance, there are a couple of exercises. One is called the European Semester, and the other one is called country-specific recommendations, where the Commission, together with the member states, in constant dialogue with the member states, actually suggests that money is spent for these important priorities. Some member states take it up, others maybe decide to take other priorities up, it's up to them. But, you know, it's good to know that this is also happening. Some member states do recognize that when it comes to cancer, especially if we have the evidence that there are gaps to be filled and we present it to them, they actually take the suggestion. So, as I say, we are working together with the policymakers, with the EU Beating Cancer Plan, with our colleagues from the health department, and we are making sure that through an integrated approach this is happening. So again, it's a question of putting research together with policy making and bringing them closer together. What is good to mention is what I mentioned also yesterday, and this is the subgroup, this famous subgroup which we have set up under the Cancer Mission, where we are bringing systematically the research people within the governments and also the health people together all the time. And this doesn't actually happen usually. And I'm glad to say yesterday my colleagues were telling me that it's actually being noticed by the other missions. There are 4 other missions, ocean, soil, we mentioned them yesterday, where they're seeing that this actually works when you build up these synergies, at all levels, and keeping the citizens' engagement, making it real all the time, and then translating it into actual programs. And this is happening already now in the cancer
and this is happening in Czech Republic, because Czech Republic is one of the example of the European countries that use this recovery fund to finance important new institution on research. There's a national institution for prevention that is going to be created in the second city of Czech, which is I don't know how to spell it, so I'm saying this is, what's the name of the city? It's Brno. And there's also a National Institute of Research that's going to be created, and you have this comprehensive center existing. It's around 15 of them are existing. Marek, you can take the mic because this question is for you. How such comprehensive center can help countries like you, which I call maybe the smaller countries, to have a better access to high quality research, and also maybe to have a more implemented research more implemented research.
Yeah, thank you. At the beginning, maybe I have to mention that that's really true, and that the European Commission actually gave a Czech Republic as an example of good practice regarding the investment to oncology from the Recovery and Resiliency Fund. The Czech government decided, and it was also because of the COVID crisis and the impact on the human health and on the screening programs, to invest really huge amount of the money from the National Recovery Plan to cancer. For your imagination, it's about 4,080 million euros, which will be invested to the oncology. Which of 340 million will be invested in the strengthening the cancer care. About 40 million euros will be invested to cancer prevention. For example, our institute will build a completely new cancer prevention center, and 60 million euros will be invested to the National Institute for Cancer Research. So, and that's the connection to your question. We decided to build this institute with main goal of connecting all of the research institution, the high quality research institution in the Czech Republic, to be able to solve the most complex task mostly in the translation research agenda. And actually, to some comment on the network and on the comprehensive cancer network, yeah, the Czech Republic already has, it was established in 2006, the network of comprehensive cancer centers, and which are accredited in the national process, and some of them are also accredited by the OECI. And I really think that it's very important for each member state country to have at least one comprehensive cancer center, or of course even more if if it's a country with
which means that it would need a ratio, kind of a ratio of one comprehensive center for that million people, and not just like criteria of qualities of the center itself.
Yeah, exactly, but you can have a different view on that. I think if but there are differences between the EU member states, and some of the differences we can clearly see between the East and West. Of course, it could be regarding also the quality of the cancer care. Fortunately, it's not the case of the Czech Republic. So the accreditation criteria must be nationally done, of course, but there also must be some criteria which will define what is the comprehensive cancer center on the European level. The most important thing is really that each country has to have at least one, because otherwise you can't make any network in the wide Europe, pan-European network of these comprehensive cancer centers. And there are some countries which have a population, for example, below 5 million. So, and we know that there is a recommendation to build one comprehensive cancer center for 5 to 10 million of inhabitants. But the main and of course, these centers must be connecting together not only through the network, but also there has to be members of the European reference network. There has to be also connected to the infrastructures, like in Czech Republic, all the comprehensive cancer centers are connected to the ECRIN infrastructure, the Czech national node of the ECRIN, which is really helping us to conduct a clinical trial, especially the multicentric investigator-initiated clinical trials. And it's really facilitate and speed up the research. And some of the centers are also a member of the European reference network, and then the connection works very well. Yeah.
One word maybe in Sweden also with you, Madeleine, if you're connecting with us, because I know there is implementation research is a major issue also in Sweden. You have a lot of research in cancer, but you have this issue about clinical research, which is a challenge. I mean, you do a lot of research, but when it has to go to clinical stage, sometimes there's a bit of a gap in between what's research at first and what comes to the ground. How much of there's an issue about growing implementation research, and how do you think this can be done?
No, like you say, clinical research and thereby implementation is a challenge in Sweden. And let me just describe to you very quickly, so that the Swedish healthcare system is basically divided into 21 independent regions that each have their own primary responsibility for health and medical care. So the Swedish healthcare system in that sense is fragmented with a low degree of national governance and coordination. And also that research and care are too much seen as two separate parts competing for resources. So it's possible to prioritize care at the expense of research. And also what we have noted, and that has been especially true during the pandemic, is that clinical researchers, they report reduced incentives to conduct research. So for us, and probably for other countries as well, coordination, collaboration, and incentives must be enhanced for clinical research. And also what we have to remember then, that funding is greatly needed throughout the research continuum, from basic research, clinical trials, implementation in healthcare system, outcome research, health economics, and long-term follow-up. And at the Swedish Research Council, we fund basic research, we fund clinical research and clinical trials. And then for innovation and implementation, we have another government agency, Vinnova, but then we have these gaps. So I think now for the cancer mission and for the cancer fields and other fields as well, it's important, and also going back to what Joanna said, it's important that we structure our own national activity, and in particular from funders' point of view, national funders. I'm speaking of governmental funders, non-profit funders, and private funders. They must consolidate themselves now, and now we have a good opportunity to do so. And on this topic, I would also like to mention that the Swedish Research Council, we are responsible for 7 large national research programs, none in cancer so far, however, but for example, in antibiotic resistance and viruses and pandemics. And these research programs, they stretch over 10 years, and the idea behind these national research program is to gather different actors, funders and other actors with complementary knowledge, and they work together to manage major societal changes. So collaboration is a key issue.
En France, avec vous, Claire Giry.
In France, with you, Claire Giry, we have in the field of integrative research in France many structures that support centers that are fighting against cancer, research institutes that are collaborating with a certain number of teaching hospitals. What can you expect from the Cancer Mission on Cancer and the EU bodies to give a broader remit to these integrative fields of research, to address more fields and to act closer to reality and the difficulties from the field? Answer from Claire Giry. I will answer in French. Okay, I will speak in my mother tongue. It's perfect for me. Thank you very much for this question. Indeed, the European dimension for research on cancer is absolutely essential. It is also very intense in many countries according to their size, but in France we have a cancer research which is well structured and organized thanks to our cancer plan and the 10-year cancer strategy, through the role played by INCA, by INSERM, by structuring the cancer community on upstream research. And what we would expect from the European level today, and that's the next step, with stakeholders that are diverse for upstream research, clinical research, and stakeholders like hospitals, and it's a great force in the field of cancer, stakeholders that are able to have research at the service of patients and not continuum with upstream and clinical research. It's something which is cyclic. So we can also start from the patient to solve fundamental research questions and come back to the patient and then have virtuous circles and progress in the knowledge of the disease. So, of course, in the proposals of treatment, diagnosis, and management of patients, a step which we want to support today and which goes beyond is the implementation of proposals that have been made within the framework of the EU Mission on Cancer, and we have to start elaborating on this basis, and we have started building a platform dedicated to research on cancer, which is called oncan.eu. And INSERM in France has coordinated the drafting of coordinated support action we've submitted to Horizon Europe last autumn, and the project had the enthusiastic support of some 20 countries that really wanted to participate in it. And this consortium has been selected very recently, and it will be funded with 3 million euros to prepare the partnership and to prepare a larger audience for this partnership. So it's the beginning of a virtual institute located everywhere in Europe, which will enable us to be ambitious in coordination, and by being targeted on a certain number of well-defined topics on research on prevention, early diagnosis, treatment resistance, all these themes we have mentioned earlier, the themes of biology that can be dependent on age, on gender, and also the questions of survival after cancer, the quality of life issues or long-term effects that must be taken into account. So I think this is a new added value we can have through this European approach and this project. which is important because it is rooted in the field. That's what we must have in this type of research, this relationship with the clinical field. But with all the added value of the possible scientific approaches, among what we can capture and enrich this research on cancer and make it stronger and more relevant, there's also the question of favoring data exchange within this consortium and beyond to benefit from the open approach, to have more patients, have an analysis surface that is more broader. It's really precious on rare cancers where a very few number of patients in a given country does not enable to have enough knowledge, whereas at the European scale we could have this relevant view. So the idea is also to share this knowledge, this data, to build the European data hub of cancer that will be useful for everyone and that will enable us to move further to respond to all the challenges offered by these diseases. Question from Regis. Yes, thank you very much. I would like to talk about what has come up in many of the feedback. So the financial means, but also the means in terms of data to implement and carry out this research. Data is a topic that came frequently yesterday and today. Joanna.
How Conservation will address this data issue? We saw this morning and yesterday that there might be simple decision like decided to have an obligation for every research project in Europe to share data at the beginning of the project, not at the end, just that I want to check, but this is a pre-crawl actually. This might be decided quickly. Another thing is how you're going to build this data policy on research. You're going to be having a European data hub. There's going to be a digital European center with data. There's going to be the image center also has data. It means there's a lot of things coming. Isn't there a risk of too many things, too many data centers, and not very connected, the one with the other ones? How are you going to deal with this and offer a clear vision of data sharing to the researchers? With the mic.
I always forget. Okay, Europe has always been built in small and decisive steps. Okay, so.
But steps.
Yes, but they are steps forward and not backwards. So we should not forget that this is an area, and we talk about the health area in particular, where each member state, you know, very legitimately, they did their own thing. Everybody did their own thing. And of course, at the national level, and this is exactly how it has always been organized. And it will remain like this, but I think COVID has brought a big push towards us appreciating the importance of sharing data, of organizing our findings, of sharing research results, of being quick in finding European solutions. And I think Europe has given a very important message here. So in a way, this is one of the good things of COVID. I mean, there are others as well. There are a lot of bad things too. But this is a good thing, and I think from the European perspective, we had to reflect upon actually using this experience once that this happened at the same time that the mission concept was baked, nearly fully baked, but then we were also thinking of, okay, what's the value added? And one of the value added is exactly this, of actually creating an incentive, creating a database, creating a central shall we say, conglomeration center for data and for clinical trials, which has just gone live. I'm sure that John spoke about it a couple of days ago, thanks to the European Beating Cancer Plan, where researchers and patients have the incentive and the platform available there to share the results of their research, their observations, but also patients to actually share their profiles together with professionals, so that there is a European center for that. Of course, this sounds very naive, maybe in 2022. For a Europe that's quite far advanced, on the global stage, let's face it, in terms of how much money has gone into cancer research, treatment, prevention, diagnosis, lab work, etc., trials. And also, let's face it, some of the world's brightest brains in terms of solutions have come from Europe. But, as I said, Europe has always been built in small and decisive steps. And I think based also on, a very sound and recent experience that we can all relate to on an individual basis. So just to mention two examples that the Mission on Cancer supports, several key actions that are favoring open access to data, and also supporting future clinical trials. There's the uncan.eu, of which you have already spoken highly, and this is actually really creating the hub, if you like, for high quality data to be accessed in general, both, as I said, for researchers and for patients, and also the clinical trials, which has gone live a couple of days back. One thing I think that I should emphasize here is that all this is not just for the sake of data and for the sake of having one European project more, which sounds good. I think at the end of the day, if we're thinking in terms of how attractive is Europe for investors to want to invest further and to believe in Europe as being a leader, a global leader, and the reference point on cancer and how it is, first of all, prevented and diagnosed, then I think we have much more of a credibility profile if we actually, keep not only build these steps in a decisive and serious way, but also keep building and evolving in this direction.
Marek, for a country like Czech Republic, what are the expectations you have about the increasing data sharing policies? What do you expect? What do you wish for? And what could the Czech presidency do about it?
In the Czech Republic, inside these comprehensive cancer centers, we can share the data, clinical data and research data, but mostly on the retrospective manner. So, and I think this is the biggest problem which was already issued here. We really need to share the data on clinical data in real time. It will also facilitate the clinical research, for example, the enrollment of the cancer patients to clinical trials. So at this time, it's a real main barrier in the Czech Republic, and I'm pretty sure it must be solved on the European level, as was mentioned already. And there are some ongoing projects like Gaia-X, and for example, we participate in some other commercial project, which is DigiCore, which is led by the French and Italian cancer centers, and it's about how to not only collect but share and analyze the data from the real-world evidence practice. And there was a mention in Uncan, which was announced a few days ago. We are a part of the project as associate members, and it's led by the Gustav Russi Institute. So also it will be the way how we can share this information and to prepare the country to be able to share this data. During the Czech presidency, the main expert meeting will be in July in Brno, and there will be few topics which will deal with that issue. I think one of them will be about the cancer registries, about the European health data space, and all these new regulations come here. And also there will be another topic which will be focused on the comprehensive cancer centers. So it's still ongoing, the preparation, but for sure it will be mentioned during our Czech presidency.
Madeleine, in Sweden, back to you. You have also a long history with National Register and with the translation of this National Register into data that might be used by the researchers. How sharing of data still is an issue and a problem for you researchers in Sweden, and how can the European initiative solve in a way this data sharing situation?
And that is sort of the $1 million question somehow, but
let's say 2 million.
Yeah, even more. But yeah, in Sweden it is a problem because it's a problem at the national level, but also at the regional level, because each region would have their own data management system to a large
and on register and on the register also.
Yeah, and on the registers also, and also there is a, the regions may not even access primary care registers, so it is a difficult hurdle. But I agree with Joanna somehow that we must learn from the pandemic when it actually was possible to share data. For example, the creation of the European COVID-19 data portal. But again, we still have to remember that within clinical research, the problem is, sensitive data, personal data, and patient data that maybe cannot be made openly available, to whatever legal and ethical aspects. But one problem also is that the legal matters are interpreted different between, of course, different nations and like in Sweden, also within different regions. But I would also like to mention the European Open Science Cloud and the establishment of EOS, which the Swedish Research Council is involved in. And I think also the previous speaker mentioned European health data space, which I think will also be very important for the development of data sharing in Europe.
Claire, pour revenir à la France.
Question to Claire. Coming back to France, it's from my point of view, which is naive and candid. We have the impression that we have a data center hub which is being established in France. We have a lot of data warehouses that are being built for the benefit of researchers. We see the European Digital Center being established. We see the UNCAN hub. At some point in time, under the French presidency, will there not be a need to create a policy to share data beyond just creating these bodies, to initiate and establish strong and common principles of data sharing, for example, obliging all the data to be shared on all projects funded by Europe? Answer by Claire. Yes, absolutely, you're right. And I would like to comment on what you said before. There's a risk of having too much data, but we never have too much data. And the question is what you have asked. It's not a quantity of data. It's access to the data, in which conditions, when it's about health data, the organization and sharing and the principles related to that. It's really, all this is essential. In the field of cancer, we're ahead on these topics because it's a field that has structured itself and for which we can start having AI approaches, and for these AI approaches we need huge databases, and in the field of cancer the added value of data for research is key. We have a project which is getting organized in France, which is called France Machine Genomic, around the genetic diagnosis of tumors and cancers and the patient's tissues. And we totally have this question beyond the added value for research and clinical trials, the issue of data circulation, data dissemination, data use, and how the researchers produce them and share them, and how we can remove the barriers to the dissemination of data. That is key. A project has certainly been presented yesterday by Mr. Bousquet regarding a new initiative called FIAC, which enables to have ENG communicating with industrial partners and to federate data sets. Question from Regis. Well, in one member of the trio, is there the fact that during these presidencies we can try to rethink or integrate differently GDPR? Because, of course, it's not only about the data approaches, but we have a recurrent problem. All this has a limit, is the framework that we can do to use data with GDPR. Some say it's a good framework, but we are using it wrongly, or some others say the framework is wrong, we have to change it. So not more data, but the framework, and the framework already exists, it's GDPR. Answer, yes, the framework exists and it's GDPR. We are working on the confrontation between opening of data and the restriction when talking about health. So the duality and difficulty are there. So of course we have to move forward on these topics at the European level, because the legislation is European. The other phase of this subject, this key for research, is the trust of patients, because data is coming from patients but also from clinical trials. And in this equation, the trust of patients is key, because if we lose it or modify it, we lose everything. So this question is both political and technical and very complex, but it has to be asked within this European dimension. Question from Regis. So we have 10 minutes left for questions from present audience and live audience. If you have energy and inspiration to ask a few questions regarding the issues of research, don't hesitate to ask them. So please introduce yourself before asking the question.
Angelique, professor in work and health at Maastricht University in the Netherlands. I talked this morning on cancer and employment, and I was listening to sharing the data. Excellent discussion, I think. And I was also thinking about my wish that work as an outcome would be incorporated in such data sets. And I do not mean only whether people are working or not, but working status also as an indicator of poverty. We are talking about inequity. We're talking about long-term outcomes. Do people end up, do they lose their permanent jobs? Do they end up in partial employment, financial insecurities? Or in some type of disability pension arrangement, or with nothing. That's that might be that's the long-term outcome of those in working age confronted with the diagnosis of cancer. So I thought my question is directed at Ms. Weidenpass best, but if others think that they can address this, that's also, yeah, okay.
Yes.
Thank you.
Normalement, ça marche, voilà.
Thank you for this question. The sort of databases you are wishing for, they already exist. And I give the example of Sweden, where we have a database which is called LISA, L-I-S-A, where we have all this information, and we were, until some time ago, perfectly able to link it to the cancer registry, to the mortality registry, and to several other registries, including the natality registry, to know, for example, in terms of women's cancer, if that woman had, after the cancer diagnosis, a child or not, and even to follow up the success of that child, for instance, in getting employment, him or herself. GDPR has certainly made the life of researchers much more difficult. So the process of obtaining the approval to be able to link such data is much longer, much more cumbersome, and sometimes it became totally impossible. So I think GDPR is an interesting concept, but it's a raw diamond, and at this moment, the raw diamond is inside the shoe of the researchers, because it's making life a misery in many senses. And I speak not only for myself, but on behalf, I think, of many people that work with register linkage studies. And this includes the whole community that works with cancer registries. So we collate cancer registry information globally at the International Agency for Research on Cancer. As per today, we are not receiving data for Scandinavia for the past 2 years or so because of GDPR. So even though we are GDPR compliant, since we are an international organization linked to the United Nations, we are not submitted to national or European laws, we are not able to receive the data. So there are major challenges. And again, I'm quite hopeful that the Commission and the deputies will take this very seriously and not block research because of the GDPR.
Joanna, you will have to knock on many doors to change that, you know, still ongoing, but many more doors to knock to, and to convince the other DGs to make the move. Oh, yes, it's going to be working.
Yeah?
Speak, yes.
Oh, my point was to collect it not only in the Nordic countries where you have already the registers, I know that, but in whole Europe. So we can, because we have now this estimation of 30% or 1/3 losing their job after the cancer diagnosis, but this is an estimation made on, well, not incomplete data. Countries are not represented, and I think for the long-term consequences, it's so important that all the countries are represented. Apart from this issue regarding the GDPR, so maybe Eurofound has in their data collection among the working population has to include a cancer diagnosis. I don't know, but somewhere the link has to be made. That was my, yeah.
What can I say? Of course, this is the clash of the titans. We're talking about the privacy laws, which all of us are very sensitive to. And GDPR was triggered and was driven with that in mind. And this is why, you know, especially in the age we are living, you know, with data being such a commercial shall we say, enabler for many, many, many startups and companies and technology companies. So that is an argument in itself. But yes, of course, one has to acknowledge that this needs to be somehow more equilibrated or calibrated to accommodate the needs of researchers, especially if there are consents that are the available consents obtained. Especially by the patients. Let's not forget also that the inequalities register is existing under the cancer plan, has been established at European level. So I would say, again, going back to my argument of Europe has been built in small but decisive steps. This could be a first step towards making that, shall we say, driving that negotiation.
Some questions from the internet are sublining the fact that if you collect data from patients in the digital center or other initiative, they have to benefit. If they won't benefit, they won't give the data, and that's quite natural. How they could benefit from this initiative of giving the data at these different type and moments?
Well, probably the researchers can answer that question even more, because they can go into the granularity of why sharing data can be so beneficial, first for the science and the solutions and the innovations, including social innovations in this case, by the way, which is deeply rooted in both the mission and the Europe Beating Cancer Plan, the social innovation side, not only the clinical treatment and cure and prevention, etc. We're talking about quality of life, don't forget, also. It's one of the areas of the objectives of the mission. But of course, I mean, if there is more sharing of data, you are in a better position, even as a cancer patient or ex-cancer patient, to get maybe, you know, even recommendations from the professional. If the database links up the professions and the carers, the caring profession, and the doctors or the researchers who are involved in cancer treatment with the patients can get a benefit from that. Plus, I would say that this is not to exclude that the cancer patient, even if you have been a cancer patient, there could also be a possibility that you will be again. It could also lead to, you know, tweaks in policy making that have actually more beneficial social benefit system during the time that you are a cancer patient. It could lead to that, both at a national level, but also at European level. So, of course, there could be, you know, short-term, but also medium to long-term benefits.
Another short question and short answer. We have 1 minute left. It's for you, Joanna, still. How smaller countries shall be more present in the research program with the cancer mission? this is something that, because it's all, the research program are mostly going to the big countries, you know. Is there a chance with the cancer mission, maybe you or Elisabeth, that smaller countries get more program financed?
Oh, yeah, financing, yes. I think there is financing, but
selected and
financed. So I think the mission, we are entering now a second wave where new board members will be incorporated. And I know as a fact that there are many people putting forward their time and their willingness to participate. And so I'm sure the diversity will be large and it will be very inclusive. So I'm convinced about that. Moreover, we have stakeholder groups which are broad, which are comprehensive, and which are very inclusive. And the stakeholders groups can also have a very active role in the mission. We will also have different conferences, and my colleague Christine Chomian is working in an event that will take place on the 21st of March in this very room, which is including patient representatives and the public in general. So there are many ways to be included, and so it's a very inclusive program, I would say. In terms of financial support, I mean, applying for European grants has become easier. I mean, the bureaucracy is lower than it was in previous programs. The way to fill in forms is much more straightforward. So progress is, as my colleague, Dr. Drake just said, it's very important progresses. It's small steps, but it's getting easier. I think the matching between researchers that have less experience in applying with researchers that have more experience in applying is really what makes a difference. So that increases the probability of success rather dramatically.
Thank you. Yes, just
maybe one comment on that. I completely agree, especially the first option which was mentioned. It's very important, especially for the countries from the Central and Eastern Europe, how they can be more involved in this project. And one comment on the data sharing. I think one of the most benefit is continuity of care, and the patients understand it.
Okay, thanks a lot. This is a good end word for this roundtable and this moment we spent together. Thanks a lot. We can applaud our guest present and the guest present at distance too. And I let you go back to the audience, and thanks a lot, each of you, for your participation of the day. We're ending this European meetings, and we will end them with Norbert Ifra. We will come to do the conclusion of these 2 days, and I leave the stage and I leave the mic to Norbert Ifra for this conclusion. Thank you.
Mesdames et messieurs,
ladies and gentlemen,
chers collègues,
dear colleagues, dear friends, for a large part of you,
nous voilà arrivés à la fin de
we have come to the end of these 2 days, which have been rich in sharing of experiences, knowledge, and exchanges between all the stakeholders in the fight against cancer in Europe. I am proud to say that they have kept their promises and made these meetings a European plea for enhanced cooperation in the fight against cancer. First of all, I would like to express my thanks. I cannot mention them all, one by one, but I would say thank you to the ministers, the directors of central administrations, the presidents, to all our colleagues, and all those in charge of think tanks, of patients' associations risk factor associations, but also for their participation in the event, as well to the representatives of the scientific and technical network, for their interest that they showed, and for their valuable contributions. My special thanks go to the European Cancer Organizations,
qui se sont mobilisés depuis plusieurs semaines,
the association and researchers who have been working together for several weeks to propose concrete actions to take the fight against cancer further in Europe. Thank you. I would like to repeat to all the speakers who have contributed to the rich and ambitious debates. From these meetings, what I have learned is the need for a coordinated European response in the fight against cancer. Diagnosed in 2.7 million people in the European Union in 2020, leading to 1.3 million deaths, cancer will become the leading cause of death in Europe in 2035 if urgent action is not taken. The stakes are so high that the response can only be a joint one. For the past 2 years, the European Union has been strengthening its role in health. As far as cancer is concerned, it can play an even greater role. The European plan to overcome cancer and the cancer mission are ambitious new commitments. However, I am convinced that we can move towards more cooperation and thus place Europe at the forefront of the global fight against cancer for the benefit of all the populations of the member states. The political declaration, which is a concrete result of these 2 days, represents a strong commitment in this direction by the trio of the presidency of the Council of the European Union, namely France, Sweden, and the Czech Republic. This declaration reaffirms the political and scientific priority of the fight against cancer at European level in the context of the European Cancer Plan, by calling for the implementation of new concrete actions wherever the plan can be accelerated, completed and reinforced. This is the challenge that I have retained from these first European meetings organized by the National Cancer Institute, to strengthen our cooperation wherever it can enable us to achieve greater progress. 5 key themes were proposed by the National Cancer Institute in consultation with all our European partners. You've heard it. Prevention, cancers with a poor prognosis, childhood cancers, employment during and after the disease, and international cooperation. 5 themes at different stages of the patient's pathway and at different levels of the fight against cancer, where joint European action can have the greatest impact to speed up progress for the benefit of all. Firstly, on cancer prevention, a key issue. I would like to remind you once again, I think we repeat ourselves all the time, that 40% of cancers at least are linked to avoidable risk factors, and all our endeavors must be aimed at preventing them. We have therefore called for a coalition of European prevention actors to implement large-scale, high-impact actions on all known risk factors for cancer, especially the absolute enemy number 1, tobacco. With 700,000 attributable cases annually in Europe, we call, in line with the European Cancer Plan, for a comprehensive tobacco control strategy to achieve our ambitious goal of a smoke-free generation in Europe by 2040.
Les cancers pédiatriques ont également été érigés en priorité européenne.
After prevention treatment during these meetings, we focused on the treatment of so-called poor prognosis cancers in order to significantly increase the survival of patients affected by the type of cancer.
Là encore, l'Europe
In addition to cancers with a poor prognosis, pediatric cancers have also been made a European priority. Despite significant progress, the 5-year survival rate is now 80%. Cancers remain the leading cause of death from disease in children in the European Union. Here again, Europe has a lot to contribute. It can achieve significant scale effects in research. We can reinforce our research strengths. Whatever the progress that we've seen, a certain number of cancers did not have any progress. We consulted on so-called poor prognosis cancers. I note from the work that has been performed the development of research programs that are potentially disruptive. High risk, high gain, so we say. When we talk about risk, we talk about scientific risk, of course. And also innovative European clinical trials. And they are struggling to find funding. But they're all crucial in advancing our knowledge of these cancers and to identify new ways to treat them. After prevention, after treatment, and in fact, the quality of life of people, of survivors. It's not only survivors. It is essential that patients be better supported and protected, in particular by encouraging them to stay in work and return to work, at school, for studies. It's very important to improve their quality of life and to limit their social exclusion. To adapt the working environment to the situations of people with cancer, a European framework could be developed with the involvement of everyone, may they be from the private or the public sector. All these priority themes are based on a common project, strengthening European cooperation in the fight against cancer. This issue of cooperation goes even beyond Europe, but we are convinced that the European Union can play the role of world leader on the subject. The creation of an international group in charge of this coordination could play a leading role. It could actually facilitate global synergies, channel funding, and create a coordinated global strategy on the most complex scientific issues. The project is very ambitious, but the results it could bring are commensurate with the difficulty of the task. All these measures have been designed together with our European partners in coordination with the trio of the Presidency of the Council of the European Union. These are large-scale, concrete measures which we believe are essential to fight the scourge of cancer. They have been supplemented by a series of actions that have been presented to you this morning, resulting themselves from workshops, bringing together the main European stakeholders in the 5 areas I have already mentioned. In conclusion of these first European meetings, I hope they'll be the first, that means they'll be followed by others, and that we have had the honor to host. I call upon you all. May you be decision makers, scientists and associations to take ownership of all these proposals and to continue this vital work towards greater commitment and cooperation. I hope that from now on we will meet regularly for meetings of this type, which are so important for moving forward together. I'm really delighted that they are now on the agenda of each presidency of the Council of the EU. I thank you once again for the intensity of your commitment, your participation in these first European cancer meetings, and I will participate with equal enthusiasm in the next ones. Thank you.